So now we are finished with ear. Once you have finished with ear, it means that 50% of your ENT is done. Rest around 20 to 25% is nose, and the rest is divided between your throat, larynx and pharynx. Okay. So now we are going to start the second component, nothing but nose. First of all, in the anatomy of the nose, anatomy of the external nose, that is nothing but this area, you need to know that the upper 1/3 is bony. So I want you all to take your finger and feel your nose. You can see the hard structure here, no? Upper 1/3 is bony, whereas the lower 2/3 is cartilaginous. This entire area is cartilaginous in nature. Okay. Now coming to the various lining epithelium that there is, coming to the sinuses, the lining epithelium here is nothing but the ciliated columnar pseudostratified type of epithelium. So, can you draw the image of a ciliated columnar pseudostratified? How does it look like? You're going to have two layers of cells, right? But the two layers of cells, it is just the arrangemental thing. It is one layer, but because of an arrangemental thing, it is going to look like a two-layered structure. Therefore, it is called as pseudostratified. And as you can see, these are columnar cells and they are ciliated cells. This is how a pseudostratified columnar ciliated will look like. So, they form the lining epithelium of sinuses as well as majority of the nasal cavity. Nasal cavity is also lined by ciliated columnar pseudostratified type of epithelium. Now coming to vestibule. First of all, what is vestibule? It is nothing but the skin-lined portion of the nasal cavity which leads into the nasal cavity proper is called as vestibule. So I told you skin-lined, no? So what is the epithelium that you can see here? It is nothing but the epithelium of the skin. What is it? Stratified, squamous, keratinized type of epithelium is going to be seen in the vestibule area. Now coming to the upper 1/3 of the nasal cavity, we have the olfactory epithelium here. Okay. Now there is an area of the face which is called as dangerous area. So what is this area? This area is where you have your nose and you have your upper lip. This area, this triangular area is called as the dangerous area of the face or nose. Okay. It is called as a dangerous area because of the risk of infection spread to the cavernous sinus via the facial vein connection. So this is the area where there is a direct connection with the brain. So always whenever there is a furuncle of the nose, there is an infection of the nose, or if you have a habit of nose picking, make sure that you do not manipulate too much because there is always a risk of infection going to your brain, and your brain is the most precious thing, right? So be careful. Now, coming to the nerve supply of the nose, coming to the olfactory supply, we'll look at a summary of the olfactory supply focusing on the important points that would come in your exam. Okay, as we saw, the olfactory epithelium is there in the upper 1/3 of the nasal cavity. Remember, this olfactory epithelium receives only around 10 to 15% of the inhaled air during normal breathing. So now I'm talking, but also I'm respiring a little, I'm breathing. No? So in the normal times like this, only maximum up to 15% of the air reaches the olfactory epithelium. But whenever we try to sniff, okay, you see the dog sniffing, no? That is how their sense of smell is very strong. Or when you sniff, when there is a good aroma, that time there is substantial increase in the nasal flow and we appreciate olfaction or appreciate the smell better during that time. The smell is enhanced. Now, coming to the olfactory nerves, there are around 12 to 20 small fibers which pass through the cribriform plate. They pass through the cribriform plate and then they go to the brain. Okay, they pass the cribriform plate and then the synapse with structure called as mitral cells which are located in the olfactory bulb. These mitral cells nothing but form the secondary neurons. Okay. Later, from the olfactory bulb, we have another tract-like thing that projects, which is called as olfactory tract, which gives two striae, medial and lateral striae, which finally goes and relays in the primary olfactory cortex. So, the primary olfactory cortex is formed by the piriform cortex, amygdala, and even the entorhinal cortex. So, from these three structures, the smell next goes to the secondary olfactory cortex. Signals go here. So, what comprises the secondary olfactory cortex? Nothing but the orbitofrontal cortex. The orbitofrontal cortex comprises the secondary olfactory cortex, and this is involved in the odor recognition, and also smell memory is from this area. Now let's look into this pathway in little more depth. So you have lot of olfactory receptors like this, okay, in your nose. These olfactory receptors synapse and then they give rise to the olfactory nerves. So these are the olfactory nerves. These olfactory nerves cross the cribriform plate. So these are olfactory nerve fibers, olfactory receptors. This is the cribriform plate. These cross and go and they synapse with the mitral cells. After they synapse with the mitral cells, where is this mitral cells located? This entire structure, olfactory bulb. Okay. And after they synapse, this olfactory bulb is going to give rise to olfactory tract. The structure that you're seeing here is nothing but the olfactory tract. This is going to give two divisions, the medial striae and lateral striae, which is going to go and rely in the brain, in the primary and the secondary olfactory cortex. The secondary olfactory cortex is the most developed cortex, and here we get the smell or odor recognition, odor memory. Now, for example, if you sense a smell of biryani, how your brain knows how it smells, and it can also compare with the smell, that is the smell memory that is there. So you go to a place and you can say that whether the smell was similar to the biryani that you had there last time. It is because of the odor memory that is stored in the secondary olfactory cortex. Now we have seen the olfactory pathway. Now we'll go one step further and see the olfactory disorders. Okay. So all the olfactory disorders are very easy to remember because by their name only you can guess what is the condition that the examiner is talking about. Firstly, hyposmia. What is hypoxia? That is nothing but reduced perception of smell or olfaction. See, hypo means less, no? So, decreased perception of smell is called as hyposmia. So, whenever there is partial nose block, whenever you have cold and you have stuffy nose block, you can't smell anything, no? This happened with a lot of people during COVID, no? Because the hyposmia, reduced perception of smell. Next, you have anosmia. Whenever the word a comes before an actual word, it means no or absent. That is, no perception of smell is called as anosmia. So, where all it can be seen in viral infections, like for example, COVID, cribriform plate fracture, when the olfactory nerves that cross the cribriform plate are completely damaged. It could occur in olfactory bulb tumors. Olfactory bulb tumors, example, frontal meningioma. Because frontal lobe is the area where we have the olfactory bulb going through, no? So, whenever there is frontal meningioma, there could be complete loss of smell. And in atrophic rhinitis, because of the damage to the olfactory receptors in the nasal cavity. Now, coming to one more condition, parosmia or cacosmia or dysosmia. There is going to be distorted perception of smell. So, what happens? The smell is of something else, maybe a flower, maybe a scent, but you perceive the sound as rotten egg or burnt rubber. It is because of the aberrant nerve regeneration. Next, you have something called as phantosmia. What do you understand by phantosmia? It means olfactory hallucination. That is nothing but false sense of smell. In actual, there is no smell around you, but you feel like there is a smell that is coming, a very good smell in fact that is coming. This is nothing but the patient or the person hallucinating about smell. It is seen in temporal lobe seizures. Next, presbyosmia. In the earlier part of discussion, we studied about presbycusis, no? AIDS-related hearing loss. Okay, like that we also have AIDS-related reduction in the perception of smell, which is called as presbyopsia. Okay, there is reduction in the smell as the patient ages, and it is a process of normal aging. It is seen in the gradual course and also in certain neurodegenerative diseases, for example, in Alzheimer's or in Parkinson's. Even these conditions can show presbyosmia. Next, we have congenital anosmia. That is, right from birth, the patient doesn't have any perception of smell. Absent sense of smell since birth. Can you name a condition where it is seen? You would have studied this condition in OBG. It is nothing but Kalman syndrome. What is Kalman syndrome? This is nothing but hypogonadotrophic hypogonadism. This is a condition in which the gonads are affected. There is a decrease in the production of the gonadotrophins, and also there is going to be associated anosmia, congenital anosmia seen in these patients. Now we know that there are various conditions related to smell, no? Now how are we going to diagnose these? So there are various tests that are used for testing olfaction. The number one is called as smell diskettes. So why do we use smell diskettes? We use it as a screening test for olfaction. Okay. Next we have a test which is called as UPSIT, U-P-S-I-T, which is also called as the University of Pennsylvania Smell Identification Test. Okay. The image that is shown here is a picture of UPSIT. This can come as a spotter in your exam. So in UPSIT, what happens? There are going to be around 40 odorants which are available in these sheets. Okay. You're supposed to take a pencil and scratch the sheet. Okay. There are some small circles. You're going to scratch it, and then the micro encapsulated odorants release out. So you're going to sniff it. And when you sniff it, what happens? Lot of odorant molecules are going to go into their olfactory epithelium. And then there is a MCQ pattern that is given showing option A, B, C, D. So based on whatever smell you feel, you are going to tick one of the options given. Now you might ask me, we are so tired studying for multiple choice questions. Now to get to know about the olfaction also, should we do a MCQ test? It is as it is, you cannot do anything. It is the UPSIT test. Now, after you have answered all the 40 odorant questions, you are graded, and how much is the degree of your smell loss is going to be given to you or told to you. Okay. There is also a 12-item short form version of this test, which is also called as cross-cultural smell identification test. And this test is useful in quantifying the smell loss when less time is available, because here only 12 items are there, so it can be done very fast. There is also something called as sniff and sticks test. It is a relatively newer test of smell of the nasal chemosensory performance based on smell dispensing pen-like devices, or the odor dispensing pen-like devices are used here in order to test the smell sensation, and this test is called as sniff and sticks test. Now let us look into certain disorders of the nasal septum. So the number one condition that we are looking is nothing but that of septal hematoma. What do you understand by septal hematoma? We saw it in the ear also, no? There was hematoma in the pinna. What did we see there? Collection of the blood in pinna was hematoma there. Okay, here we are going to see collection of blood in the nasal septum, which is nothing but septal hematoma. So how does the patient present to you, or how do you get a question in your exam? It says that there is a person who has gone to play football and he's been hit over his nose by the football, and he comes to you the next day with severe pain in the nose. When you try to examine, you're trying to feel the septum, and you can see boggy swelling on both the sides of the nasal septum. What is this condition? This condition is nothing but septal hematoma. You can look at the image here. You can see that on either sides of the septum, there is boggy swelling that is seen. Okay. So there is always history of trauma that is going to be there. In the question that we saw, it was being hit by football. Okay. So what are the clinical features? There is going to be bilateral boggy swelling on both the sides of the nasal septum. Because there is swelling in both the sides of nasal septum, it is going to block the nasal cavity. So the patient also has nasal obstruction. He might also complain of pain and tenderness. So pain is the feature that our patient came to us with. And sometimes this condition can be mistaken just to a deviated nasal septum if not examined carefully. So what do you understand by this? Usually if you just put a torch and see, or if you just take a Tudicum's nasal speculum and examine the nasal cavity, you might see that there is just a bulge in the nasal septum. But how are you going to actually feel for septal hematoma? With a gloved finger, you're just going to palpate and feel the septum. If it gives you a boggy appearance, that says that it is a septal hematoma that you're looking at. So what is the deal here? What happens if there is a septal hematoma? There is cartilage in the lower one third lower two third as we discussed. So when you do not treat this, if it remains untreated, it can go for septal abscess formation. It can also go for septal necrosis. And again, if it is not treated finally, it can go for septal perforation. And when the entire cartilage is affected and the cartilage damage happens, cartilage loss happens, there is going to be saddle nose deformity. So what do you understand by saddle nose deformity? There is going to be a downward depression that is seen over the dorsum of the nose because the cartilaginous support to the dorsum or the framework of the nose is lost. Okay. Now, how are you going to manage this condition? Incision and drainage ideally done less than 72 hours after the injury has occurred. And after you do incision and drainage, you are going to pack the nose. Why are you going to pack the nose? Can't you leave it open? No, you can't leave it open. You are going to pack the nose because you have to prevent from the collection building up again. So even in the case of pinna hematoma, we saw to it that after we did incision and drainage and drain the hematoma, we always did a contour dressing, a tight dressing so that the recollection is prevented. Similarly, inside the nose, you're going to put packs so that recollection is prevented. Okay. And also you're going to give antibiotics to prevent secondary infections. Okay. Okay. This is what you're going to do. Now, coming to the next condition of the nasal septum, we'll look at deviated nasal septum. Deviated, deviation, bent. Bent nasal septum is nothing but DNS or deviated nasal septum. This is one of the most common causes of nasal septal defect. Every other person might have a very small amount of deviation in your nasal septum, and if the patient does not have any symptoms of nasal obstruction, you need not do anything to that patient. But if the patient comes to you with recurrent nose block symptoms, not at all able to manage, then you have to give him a surgical correction. Now, coming to the various causes for the deviated nasal septum, the number one being developmental abnormalities. This is the most common cause of a deviated nasal septum. So, developmental abnormalities is the number one cause, and then birth trauma. If there is trauma to the nose during the birthing process, even then it could lead to a deviated nasal septum. Also, if there is an external trauma, being hit by a football, being punched on the face, even these could cause deviation of the nasal septum. So, what are the clinical features that the patient comes to you with? They have something called as paradoxical nasal obstruction. That is, your deviation of the nose. For example, I'll show it to you in this picture. This is your nose and this is the left side and this is the right side. Okay. So, your septum is deviated to right side. So, there is the bend towards right side. Okay. Now, you can see in the opposite side, the area of the nasal cavity is too big. So, that area is constantly exposed to the heavy nasal currents, the heavy air currents, because of which there could be a lot of crusting and dryness that could happen. So, our body, in order to prevent this, what it does, there are natural turbinates. This turbinate is going to hypertrophy and it is going to occupy the entire area of the nasal cavity, because of which, even though the bend of the nose is towards the right, there can be nose block seen in the other area, in the left side, paradoxically, because of the hypertrophy of the turbinates. Okay. Next, the patient can also have recurrent attacks of sinusitis. Why sinusitis? Because if the deviated nasal septum is pressing on any of the sinus opening or the ostia, the ineffective clearance of secretions from these ineffective air current flow through the sinuses could cause recurrent sinusitis. Also, there could be recurrent otitis media that happens in this patient. How recurrent otitis media? It is because whenever there is a deviation in the nasal septum, what happens is that the nasal area, the nasal cavity area becomes reduced. Normally, if there was free flow of air current through the area, now this air current has to go through a narrower cavity. Hence, the turbulence is created in the nasal airflow. And when there is turbulence, it is going to alter the pressure in the nasopharynx, which gets transmitted even to the eustachian tube. And there is excess negative pressure that builds up in the eustachian tube, because of which it cannot effectively clear secretions or collection from the middle ear, thus giving recurrent episodes of otitis media. There could also be epistaxis if there is spur. So, what is spur? Sharp bend in the nasal septum. So, if this is the septum, if there is a sharp bend like this, it is nothing but spur. This has a lot of blood vessels which can get stretched out, and these are also exposed to continuous air currents, because of which there could be epistaxis or bleeding from the nose, recurrent attacks. There could be hyposmia, that is reduced perception of smell because of the nose block that the patient has. On examination, you can see a visible septal deviation when you use a Tudicum's speculum and do an anterior rhinoscopy. And also you can see a compensatory hypertrophy on the opposite side. Most commonly, the inferior turbinate is the one which hypertrophies. Next, what are the investigations that you do? You can do a nasal endoscopy, and when you do a nasal endoscopy, it is going to be the confirmatory test for deviated nasal septum. Then there is also one more test which is called as Cortels test. This is going to assess the function of the nasal valve area. So you can see the image here, no? The patient's cheek is going to be pulled upwards and laterally. This reduces obstruction. This reduces the nasal obstruction. It suggests that there is block or there is deviation in the nasal septum at the area of the nasal valve, or there is going to be some problem in the nasal valve. This is the significance of this test. What is the name of the test? It is called as Cortels test. Now coming to the management, you have to do surgical management, that is septoplasty, only when the patient has lot of symptoms and the nose block is not at all coming down with any of the medical management that you do. Only then surgical correction or septoplasty is needed. Otherwise, a lot of people have a certain degree of nose bend and nothing has to be done for that if they do not have symptoms. Okay, so septoplasty is not done until the person reaches 17 years because the nasal bone and the facial bone development continues up to 17 years of age. So the indication is nothing but persistent obstruction, or if they have epistaxis attacks again and again, and also if they have recurrent infections, recurrent sinusitis. Okay, so there are two types of surgeries. One is nothing but SMR, which is also called as submucosal resection. So this is an obsolete surgery now. We do not do the surgery, and the incision that you give here is called as Killian's incision. How to remember Killian's incision? I told you, no, this is a surgery which is very old. It's a killed surgery. You do not do it anymore. Dead. So Killian's incision. You also have septoplasty, which is a recent surgery where only the most deviated part of the nasal septum is removed. Here the incision that you give is Freer's incision. You're doing this surgery in order to free the person from the obstructive symptoms. So you can see here there is an image of a deviated nasal septum. If this is right and left, you can see that there is going to be a bend with a spur to the right side that is seen in this image. Now coming to yet another condition of the nasal septum that we're looking at, it is nothing but septal perforation. Perforation, tear or hole in the nasal septum. So what is the most common cause of septal perforation? It is nothing but trauma following any surgery of the nasal septum. What is the most common surgery of nasal septum that you know of or you're aware of? Nothing but septoplasty. So what is septoplasty? It is a surgery of the nasal septum in order to correct the bend, right? So when the surgeon is operating, by chance, if he does tear in the bilateral, mucosa of the septum, then you get a septal perforation. And then most common cause of cartilaginous perforation. So you know that the lower part of the septum is cartilaginous, no? It can undergo perforation or tear in certain granulomatous conditions of the nose. For example, tuberculosis, sarcoidosis affecting the nasal septum, SLE, systemic lupus erythematosus, and leprosy. All these conditions can affect the cartilaginous portion of the septum and cause a perforation. The bony part of the septum, which is a little resilient and usually non-traumatic, or usually the perforation can't happen, but there are few conditions which will cause perforation even here. So what are those conditions? They are nothing but vaginous granulomatosis. Vaginous is also called as GTR. That is polyangiitis, granulomatosis with polyangiitis, and you also have syphilis, which could cause bony septal perforation. What are the other causes? Tumors, nasal myiasis. Nasal myiasis, that is nothing but the maggot infection. No, the patient's hygiene, nasal hygiene is so poor that there is growth of worms inside, maggots inside, which could start feeding on the nasal septum. That is why there could be perforation. And also perforation could occur because of foreign body like battery. Now what happens is that whenever there is a battery that is put into the nasal cavity, this battery over time is going to release certain corrosive electrolytes. These corrosive electrolytes are going to slowly damage the cartilaginous portion of the nasal septum. It is going to bring in necrosis and finally results in tear or perforation in the septum. Now, what is the treatment of choice in the conditions when there is perforation? For example, if the cause is nasal myiasis or maggots, what are you going to do? You are going to give a wash with chloroform water and turpentine oil drops in the form of nasal douching. So, how do you do it? There are certain douching kits that are available. Okay, for example, nasal wash. You're going to take that bottle, fill it with water, and here in this condition, usually whenever you have to prevent crusting, you're going to give saline irrigation. Now, in this condition where you have to prevent and stop the growth of maggots, you're going to give chloroform water with turpentine oil drops. You're going to push it from one side and see to it that the water regurgitates and comes out of the another side. So, this is going to help you clear the maggot infection. Now, what is the management of septal perforation? You can also give septal buttons. So, when you give septal buttons, this can be done for small perforations, okay. You can see the image, no? This is an image of a septum where there is a perforation seen. You are going to give a button to fit exactly here and cover this perforation. Remember, it can be done only if it is a small perforation. If it is a larger perforation, you have to repair it and cover the perforation with flaps. Now, we can see here a lot of worms in the nasal cavity. These worms are nothing but nasal maggots, which can ultimately feed on the surrounding structures and destroy the cartilaginous portion of the septum, causing septal perforation. Now, coming to one more topic, we'll be looking into atrophic rhinitis. What do you understand by the term atrophic rhinitis? Whenever there is chronic inflammation in the nasal cavity, resulting in atrophy of the mucosa, the nerve endings, glands in the nose, and even there is destruction of the turbinates. There is atrophy of all these structure leading to a formation of a wide roomy nasal cavity. This condition is nothing but atrophic rhinitis. Okay, this is seen in females more than men. Okay, and the typical onset is around puberty, which also says that there is some amount of hormonal role that is played in this condition. Now, coming to the primary atrophic rhinitis, mostly the cause is unknown. And one of the bacteria that is implicated, microbe that is implicated is nothing but Klebsiella ozonae. Okay. Now, coming to secondary atrophic rhinitis, as the name suggests, the atrophy happens because of some secondary condition. Now, for example, there could be some granulomatous diseases like that of SLE. There could be conditions like sarcoidosis or TB, which is going to cause extensive destruction of the nasal cavity structures, leading to wide nasal cavity. Some tissue destructive surgery, that is excessive removal of the turbinates, can cause wide nasal cavity. And empty nose syndrome, post-surgical complications, same. You have removed the inferior turbinates, middle terminates, has so much space that the air currents come and hit the nasal mucosa, causing excessive dryness and crusting. This could also be one of the causes of secondary atrophic rhinitis. So, coming to clinical features, what features are we looking at here? So, there is going to be bilateral excessive crusting seen. As I told you, the cavities are very big. The air currents that come is going to hit to the wide mucosa that is available and cause crusting. This crusting is going to block the entire nasal cavity, and there is nasal obstruction as one of the other complaints. So, you might be wondering, there is so much space in the nose. Now, why is there obstruction? It is because these crusts fill in all the space and the space is not empty, because of which, even though there is a wide cavity, there is going to be nasal obstruction. There is foul smelling nasal discharge. Okay, And one of the classic symptoms, it is the answer clincher that comes in your MCQ, is about the merciful anosmia. That is, the husband and wife comes to the doctor and husband says that, doctor, night when I sleep, I cannot take the smell. There is bad smell coming from my wife's nose. But wife says, no, my husband is lying. There is no such smell. So it is merciful anosmia. That is, there is bad smell, but by mercy of God, the wife is not going to get that smell because all the nerve endings that are there in the nasal cavity are dead because of atrophy, because of which she cannot sense that smell. This is called as merciful anosmia. There can also be epistaxis, dryness, and also lot of secondary infections that could be seen in this condition. Okay. Now coming to the treatment. Now we have seen all the clinical features. You know that it is very troublesome for the partner living. So how are you going to help this patient? The number thing that you can do is to remove all the crust that is there in the nasal cavity. You can teach the patient something called as alkaline nasal douching. Okay. So here you are going to use a composition of 2:2:1 of 3 substances in distilled water. So what are these 3 substances that you are going to use? Number 1 being sodium chloride, common salt. Okay. Next, you are going to use sodium bicarbonate and you are going to use sodium biborate. So sodium chloride in the composition of 2, sodium bicarbonate 1 and sodium biborate 1. In distilled water, you are going to mix all these and you are going to teach the patient douching. So because this is alkaline, this is going to help in effective clearance of the crust from the nasal cavity. Now coming to how are you going to treat infection and promote mucosal healing. You are going to give the patient something called as 25% glucose in glycerin solution. Around 2 to 3 times in a day, the patient is going to take few drops of this and put in the nasal cavity. This composition of 25% glucose and glycerin is going to help in moisturizing the nasal cavity, which ultimately promotes the mucosal regeneration. Plus, it also prevents the growth of proteolytic enzymes, proteolytic bacteria and enzymes. That is how it is going to help the patient. Now, you can also treat the patient with chymicetin solution. So, chymicetin solution is a combination of 4 important substances called as COPD. C stands for chloramphenicol. It is nothing but an antibiotic that is effective against Klebsiella ozonae. Next, you have estradiol, which is going to promote the mucosal regeneration. P for propylene glycol, which is a moisturizing agent, which is going to moisturize and keep the nasal cavity away from being dry. And vitamin D again promotes healing of the nasal mucosa. Now, if all these fail, you have to finally go back to the last resort, which is nothing but surgery. So, there are 2 types of surgery. One is called as young surgery, where you completely obstruct the nasal cavity. But this is seldom done these days because if you completely obstruct the nasal cavity, it becomes difficult for the patient to breathe. They are going to come to you again with nasal obstruction. They do not get any symptomatic benefit because obstruction is still there. Okay. You can also do modified young surgery where you do a partial closure so that this gives the patient extra benefit. There are a few conditions in the nose which are the granulomatous conditions. For example, rhinosporidiosis, rhinoscleroma, rhinophyma, very confusing terms, right? Everything starts from R. So, we are going to look at all these conditions one by one. Firstly, we will be looking at rhinoscleroma. What is rhinoscleroma? It is a chronic granulomatous condition affecting the nose where there are going to be different stages and we look at what happens in each and every stage. The rhinoscleroma condition is caused by Klebsiella rhinoscleromatis. This is the organism which causes rhinoscleroma. We also studied about Klebsiella ozonae. What does it cause? It causes atrophic rhinitis. Okay. So, this Klebsiella rhinoscleromatis is also called as Frisch bacillus. Okay. So, if you get a question about the etiology of the causative organism of rhinoscleroma and you do not have Klebsiella rhinoscleromatis in the answer, in the options, you have to always look for Frisch bacillus in your option. Okay. And this condition is mostly endemic to Asia and Africa. Now, coming to the different stages, there are 3 main stages. Number one, the first stage is called as atrophic stage. This features are similar to that of atrophic rhinitis. So when I say atrophic rhinitis, what do you see in atrophic rhinitis? There is going to be a lot of atrophy in the nasal cavity. There is going to be crusting that is seen in the nasal cavity, and because of the crust occupying the nasal cavity, there is blockage or obstruction in the nasal cavity. Also, there is lot of foul smelling discharge or secretions from the nasal cavity. The second stage is nothing but granulomatous stage, where there are a lot of nodular growths that are seen in the nose. Lot of granulomas start appearing in the nose. Also, the nose gives you a woody hard feel on touch. Now we have the third stage, which is called as cicatricial stage, where there is going to be fibrosis, stenosis and deformity in the nose, giving it an appearance of an Hebra nose. So what is Hebra nose? You can see in the image here, right? This is a picture of a Hebra nose. This deformed nose is nothing but called as Hebra nose. So is there any importance to the name Hebra? It is nothing but named after the dermatologist who first described the condition, and the cicatricial nose with fibrosis, stenosis and deformity is called as Hebra nose. So here also you can see, in this image there is going to be lot of damage to the nasal cavity structures. It happens in the cicatricial stage of Rhinoscleroma. Now coming to the histopathology, when you do biopsy and send the sample for histopathology, you can see two types of cells which are very characteristics of Rhinoscleroma. So this is a H&E picture. Now when you zoom it, you can see two types of cells. One is called as Miculic cell. What are Miculic cells? These are nothing but large foamy histiocytes. What are histiocytes? Nothing but macrophages with bacilli in them. This is nothing but Miculic cell. So you can see here that these are the foamy histiocytes, large histiocyte. You can see the whitish area, foamy areas with so many bacilli in them. This is how a Miculic cell looks like. Next, you have Russell bodies. What are Russell bodies? These are nothing but eosinophilic inclusion bodies. These are nothing but Russell bodies. So you can see here, these are the eosinophilic inclusions that are seen forming a Russell body. How do you remember it? E for eosinophilic. You have E in Russell, no? So remember that Russell stands for eosinophilic inclusion bodies. Now, coming to the clinical features, there is going to be progressive nasal obstruction that is seen. Why there is nasal obstruction? Because there is lot of crusting, and this crust is going to obliterate the nasal cavity, giving features of nasal obstruction. Also, there is going to be lot of crusting with nasal, blood-tinged nasal discharge. There is also going to be woody, hard nose that is appearing. Also, in the later stages, when the cartilaginous part of the septum is completely spoiled, destructed, there could be septal perforation that is seen, and cartilaginous part destruction happens in what all conditions? Can you recall? We have done this 2-3 times. What are the conditions? Number 1, TB. Number 2, sarcoidosis. Number 3, what is it? SLE. And 4, leprosy. So when we talk about destruction of the cartilaginous portion of nose, these 4 things should be at the tip of your tongue. Now coming to destruction of bony part, it happens rarely in certain conditions, like for example, vaginous. Vaginous is also called as GPA, granulomatosis with polyangiitis, and it could also happen in syphilis. Now, when the cartilaginous portion of the septum is destroyed in the later stages, what happens? The bony support to the external framework or the dorsum of the nose is lost, because of which there could be saddling. So, if this is the appearance of the nose laterally, there is going to be a depression seen here in the dorsum, which is called as saddle nose. It will appear like the saddle of the horse. Okay. Now, we saw the name of one of the deformity was Hebra. Sometimes this deformity is also called as tapir deformity. So, have you seen this animal called tapir? You can see in this picture, This is the picture of this animal called tapir. If you look at the nose of this tapir, you can see that it is a slightly upturned, not a very good looking nose, not a sharp, nice looking nose, So, this picture here of this woman shows a tapir deformity, especially happening in the 2nd and 3rd stages, where there is lot of woody granulomas that are seen in the nose, distorting the shape of the nose. Now coming to how you're going to treat this condition, you have to always treat this condition with antibiotics initially. That is, what antibiotics are you going to give? You're going to give ciprofloxacin. So ciprofloxacin is nothing but the drug of choice in this condition, and you're going to substitute it, give it for long duration of time. You can also give streptomycin, rifampicin and tetracycline. So combination of all these antibiotics for long term will bring substantial results. Also, you can try giving the patient steroids, especially to reduce fibrosis. In which stage are we seeing fibrosis? In the third stage, that is, in the cicatricial stage, we see fibrosis, and in this stage, we can give steroids in order to reduce fibrosis. Now, we have seen what happens in rhinoscleroma. Now, let us go to the second condition starting from R. What is it? Can you guess? It is nothing but rhinosporidiosis. So, which is the organism that causes rhinosporidiosis? It is nothing but Rhinosporidium seaberi. So, Rhinosporidium seaberi is the organism that causes rhinosporidiosis. So, is it a bacteria, virus? What is it? It is an aquatic protozoa. So, it is a protozoal infection that we are talking about. So, what are the clinical features? There is going to be nasal discharge, which is blood tinged. Along with blood tinged nasal discharge, there could be episodes of epistaxis, nosebleed that happens, and also there could be nasal obstruction. So these three are the features that the patient complains of. So when you examine this patient, you can see that there is a mulberry or strawberry mass that is seen in the nasal cavity with white colored dots. So you can see this image, right? There is a strawberry-like mass in the nasal cavity, left nasal cavity, with so many white dots on them. This is a classic picture of rhinosporidiosis. Okay. There are also subcutaneous nodules which develop on the skin. So, two things, strawberry or mulberry mass in the nasal cavity with subcutaneous lesions. So, you can see here, no, in the pinna, there are a lot of subcutaneous lesions. Here in the hand, there is a subcutaneous lesions. So, these two features together gives you a classic clencher, history clencher for a question of rhinosporidiosis. So, when you do biopsy, what do you see? You see lot of sporangiums filled with sporangiospores. You can see here, no? These are nothing but sporangium filled with lot of sporangiospores. This is how it is going to look like. Now, how are you going to manage it? You are going to excise it, wide local excision of the lesion along with cauterization of the base, and after you cauterize the base, you are going to give dapsone in the post-operative period so that the recurrence is prevented. Now, coming to the next condition, what is this? If you look at the nose, it looks swollen, like a potato almost. What is it? Potato nose. What is the scientific name for it? Rhinophyma. It is also called as potato nose, or also called as, does it have another name? Yes, there is another name. It is called as elephantiasis of the nose. Have you heard of elephantiasis anywhere else? In the leg, swollen large legs. What is it? Filarial infection. So, in the nose, rhinophyma is called as elephantiasis. What is the epidemiology? It is seen mostly in the middle-aged males. The older males are the ones who are mostly affected by rhinophyma. It is considered as a severe form of acne rosacea. Okay. So, what is the pathophysiology? It occurs because of the hypertrophy of the sebaceous glands. Okay. Sebaceous glands hypertrophies and gives us this potato nose-like appearance. It is associated with long-standing case of, as I told you, acne rosacea. Okay. So, whenever there is lot of hypertrophy of the sebaceous glands, there develops thickened, bulbous, deformed nose appearance. So, how are you going to manage this? Surgical removal is the mainstay of the treatment. So, you do surgery and you remove this. So, how are you going to remove it? You can either use a surgical knife, or you can also use a carbon dioxide laser in order to debulk the tissue. Also, you can do skin excision, wide skin excision for larger lesions. Got it? Okay. Now, Now coming to one more important question that could come in your exam or potential MCQ for you, it is nothing but inverted papilloma. So these are the images that could come in your exam. If you look at the nasal cavity image here, you can see a undulated polyp-like appearance in one of the nasal cavity, right? This is how you could see this inverted papilloma when you see through the anterior rhinoscopy using a Tudicum's nasal speculum, or whenever you do a diagnostic nasal endoscopy. Okay. Now, in the MRI, in the T2 weighted image, you could see brain-like cerebriform appearance. No, this is classically seen in inverted papilloma. So, what is the meaning of cerebriform appearance? It means a brain-like appearance with lot of grooves and ridges. That is nothing but cerebriform appearance seen mostly in T2 weighted image, MRI image. Now, there are various names of inverted papilloma, and as NEET going aspirants, you need to know about some of these names, because in your exam, in the options, they may not mention inverted papilloma, but some other name, synonym of the condition could be mentioned. For example, inverted papilloma is one important name, right? It can also be called as Schneiderian papilloma. Why it is called as Schneiderian papilloma? Because it arises from the Schneiderian epithelium. It can also be called as Ringer's tumor. There are around 7 to 8 names. It is completely okay if you can't remember all the 7 to 8 names, but try remembering these 3 synonyms, okay? Some other names include benign papilloma, transitional cell papilloma, cylindrical cell papilloma, and so many more, okay? So, what is the etiology? This is one of the most common type of benign tumor of the nasal cavity, and it is mostly associated with HPV infection, human papilloma virus infection. Which subtypes? Types 6 and 11. So, 6 and 11 is also implicated in causing warts. Okay. So, HPV also causes one of the most important cancer, no? Which cancer are we talking about? Cervical cancer. So, which type of HPV causes cervical cancer? It is by 16 and 18. Okay. Now, males are affected more than female, and the age group that is commonly affected is from 40 to 70 years. And remember, this tumor in around 90% of the cases is seen in unilateral nasal cavity. So, what are the clinical features? Because it is seen in one nasal cavity, there is going to be unilateral nasal obstruction along with blood-tinged nasal discharge. And as the tumor grows in size, it is going to cause pressure effects and fullness over the nose area, and also there is going to be recurrent sinusitis episodes when the sinus ostium are all blocked because of the overgrowing tumor. Okay. Now, how are you going to diagnose it? You are going to do a nasal endoscopy where you see a polypoidal mass in the nasal cavity. You can also do CT and MRI. It is going to show the extent of the mass. Plus, it will also show you if there is any bony erosions, bony remodeling. We get to know all these by doing CT and MRI. And as I told you, MRI is a definitive thing, no, for diagnosis. It is going to give you the classical cerebriform appearance. And when you see this cerebriform appearance, nothing should come to your brain except inverted papilloma. And whenever you do biopsy, this biopsy is going to be confirmatory. It confirms the diagnosis. And how are you going to manage it? You manage it by removing it. You are going to remove. How are you going to remove? The endoscopic method is preferred over the external removal, because with endoscopy you can do a surgery which is not very extensive, less blood loss, more vision and less trauma. So, endoscopy is always better than external. External, you can do a lot of approaches. There is lateral rhinotomy, Weber-Ferguson, medial maxillectomy. So many approaches are there, but these days endoscopy is always in the upper hand compared to the external methods. We've seen some of the conditions of the nose, right? Now we are going to look at certain cancers of the nose or carcinoma of the nose. Number one cancer of the nose that we're looking at is nothing but basal cell carcinoma. You have to always remember that basal cell carcinoma is a very slow growing, locally aggressive cancer. If you can see in the nose here, see, it is a slow growing and it is a very small cancer, but it is going to bury and go inside like a rodent. Therefore, it is also called as rodent ulcer. Okay. Now, this is the most common carcinoma of the external framework of the nose. And histopathology or the biopsy and you do histopathology, it is going to be diagnostic of basal cell carcinoma. You're going to look at two features. So what are the two features? Number one, you're going to see basophilic cell rests. What do you understand by basophilic cell rests? Nothing but, as you can see in the image, these are nothing but the basophils, no? There are a lot of collection or rests of basophilic cells that are seen. This is nothing but basophilic cell rest. You also have one more feature, nothing but peripheral palisading of nuclei. What do you understand by peripheral palisading of nuclei? It means that around the tumor, so this is a tumor, no? So around the tumor, if you can see this image, there is going to be fence-like organized arrangement of the nuclei. You can see here, no? I'm going to mark it with blue color. So you can see, very organized arrangement of the nuclei around the tumor in the form of a fence. This is called as peripheral palisading of nuclei. So as I told you, this is a very slow growing tumor, hence it is just locally invasive and it rarely metastasizes. We have one more tumor called as squamous cell carcinoma. This squamous cell carcinoma is also called as nose pickers cancer. So, nose pickers cancer meaning there are a lot of people who continuously do nose picking. What happens is that because of continuous abrasion and trauma in the nasal cavity, because of injury from the nose, ultimately could result in a squamous cell carcinoma. Therefore, if you have this habit of nose picking, kindly stop it. Okay, this is the most common carcinoma which is seen in the nasal cavity. It is locally destructive and this cancer, squamous cell carcinoma, can even metastasize. So, how are you going to diagnose? You do biopsy. Biopsy gives confirmatory results and you can also do imaging, CT or MRI, in order to find out the local spread of the disease. What is the extent of the spread is going to be given by CT or MRI. Next, coming to management, whether it is a squamous cell carcinoma or a basal cell carcinoma, the management, the surgical treatment remains more or less the same. Firstly, you are going to excise the tumor surgically. So, surgical excision is done, after which is followed by plus or minus radiotherapy. If it is an extensive disease, you are going to give radiotherapy, or if it is a small disease, you are just going to remove surgically with proper margins and you are going to leave it. Now, if it is a very large tumor, especially a basal cell carcinoma on the dorsum of the nose, imagine it is around 1 into 2 centimeter, you remove it, there is a white space that is there, no? Cosmetically, it is not very appealing. In such conditions, you can do reconstructive surgery. So, reconstructive surgeries is done in wide or bigger appearing carcinoma or lesions. Follow-up is essential due to recurrence risk, especially in the case of squamous cell carcinoma. Now, coming to yet another most important topic for your exam, it is nothing but epistaxis. What do you understand by the term epistaxis? Epistaxis means nasal bleeding. Okay. So, before you understand more about epistaxis, you need to know which are the arteries that are giving arterial supply to the nose. Okay. So, there is something called as Kisselbach's plexus that is found in the antero-inferior aspect of the septum. See, this circular area here shows us the location of the Kisselbach's plexus and there is arterial anastomosis in this area and this is the area from which we get arterial bleed in most of the cases. Okay, especially in children and young adults, this area, Little's area, which has Kisselbach's plexus, is the area which is most commonly involved in arterial bleeds. Okay. In adults and elderly, it is usually the venous bleeds or the posterior bleeds that we look at. And in elderly, we do not know the cause. Mostly it is idiopathic or some other causes like hypertension or venous hemorrhage. And in adults, mostly if it is there, it is going to be very severe and very dangerous at times. Okay. So, what are the most common cause? Most common cause in children is nothing but trauma, especially nose picking. Because all these blood vessels have very thin, these are very fragile in nature, very thin muscular coat, and whenever the child does a lot of nose picking, there could be burst in these arteries causing torrential hemorrhage. In adults and elderly, as I told you, most common cause is nothing but idiopathic. That is, we cannot assert in a particular cause. Now, coming to the arterial supply of the septum, you can see that Arterial supply to the septum comes from both the interior carotid artery, the internal carotid artery and the external carotid artery. So, this internal carotid artery gives an ophthalmic artery. This ophthalmic artery further gives an anterior ethmoidal artery and a posterior ethmoidal artery. This anterior ethmoidal artery gives a branch to the Kisselbach's plexus, whereas the posterior ethmoidal artery doesn't form a branch in the Kisselbach's plexus. So, the first question that the examiner is going to ask you, which of the branch of the internal carotid artery doesn't form the Kisselbach's plexus? What should be your answer? Posterior ethmoidal artery. Okay. Now, this is the branch from the internal carotid artery. Now, let us look at the branches from the external carotid artery. So, external carotid artery gives two main arteries, facial artery and the maxillary artery. From facial artery, you have the superior labial artery, which also gives a septal branch which goes and forms a Kisselbach's plexus. Now, from the maxillary artery, we have two arteries. We have the greater palatine artery, which supplies the palate and also goes and forms one of the component of the Kisselbach's plexus. We also have spinopalatine artery, which is from the maxillary artery, goes through the spinopalatine foramen and gives supply to the septum. So, these four arteries, anterior ethmoidal, septal branch of the superior labial, the spinopalatine and greater palatine comprise the arteries in the Kisselbach's plexus in the little's area. Now, you can get one more question. Which is the only artery from the internal carotid artery which forms a branch or which gives a branch to the Kisselbach's plexus? What is the answer? There are only two arteries from the internal carotid, anterior and posterior. We know that posterior doesn't form a branch in Kisselbach's plexus. So, what is the answer? Obviously, anterior ethmoidal artery. Got it? This is how the examiner is going to confuse you and ask questions. So, you have to be very thorough in this topic. Now, coming to which is the most common artery involved in epistaxis, it is nothing but the spinopalatine artery. And the spinopalatine artery is involved in both the anterior and posterior type of epistaxis. Now, there is a red flag thing that you have to know, okay? If a juvenile comes to you, who is a juvenile? Do you know the age group of juvenile? Somebody above 10, below 18 years. This is the age of juvenile. They come to you with recurrent episodes of nosebleed and he is a young man, a young juvenile man. The diagnosis that has to come to your mind, one of the differentials is nothing but juvenile nasopharyngeal angiofibroma. Okay, you cannot miss this diagnosis. So, the patient comes to you with recurrent epistaxis. He is a young male, juvenile. He also has unilateral serous otitis media. If there is bilateral otitis media, it is seen in adults or young? It is seen in young. What is the condition that causes it? Adenoid hypertrophy. Whereas unilateral serous otitis media in a young male with recurrent epistaxis, it is a clencher. It has to be JNA. Now, how are you going to manage the nosebleed? Initially, you are going to assess what is the damage and how much is the blood loss. And when you come to know that there is a lot of blood that is lost, whenever there is a large volume bleed, you have to always secure the airway, breathing, circulation. That is A, B, C management has to be done first, after which you take a IV acids. Because whenever there is large blood loss, your aim is to correct the fluids, no? And give the patient with fluids. So, you have to always get a IV access, do blood grouping, because in case they want a blood transfusion, you need to know the blood group of the patient and do fluid resuscitation in order to compensate for the fluid loss from the body. And then you have to obviously identify the underlying cause which caused epistaxis and control it. Now, initially patient comes to you, how are you going to manage the condition in a systematic stepwise manner? Number one, firstly, you are going to do something called as Trotter's maneuver or a Hippocratic maneuver. What do you understand by Trotter's or Hippocratic maneuver? You can see the image here, no? How is the person sitting? He is sitting with his fingers pinching the nose, right? And also, he is leaning forward. So, this classical appearance where a patient is pinching nose and leaning forward, this is what is called as the Trotter's or the Hippocratic method. So, usually I remember one of my friends saying that if we were talking about what to do as an initial first aid method when there is nosebleed. The first thing he told me was, hold your nose and bend back so that it doesn't bleed from front. Do we do that? No. If the patient bends back like that, the entire blood is going to the lungs. There is aspiration and the patient might choke. So, there are certain first aid things that you have to tell your friends and family. This is one such thing. Always lean forward and pinch your nose. Along with this, you can also give cold compresses to the patient in the form of ice packs around the nose so that it causes vasoconstriction of the local arteries and the bleeding reduces. Next, if the bleed is not getting controlled by this, you can always do endoscopic cauterization. So, there are two types of cauterization. Number one, chemical cautery. So, what do you do for chemical cautery? What do you use? Silver nitrate is used. So, basically, you are going to take a bud and you're going to take very little amount of silver nitrate and carefully see the bleeding spot and place it there. It is going to stop bleeding. Or you can also do electrical cauterization. You are going to burn the area wherever bleeding is happening from. Now, both of these methods is not giving you any benefit. What are you going to do? You do something called as anterior nasal packing. That is, you take a ribbon gauze or you take a Mirasil sponge and pack the anterior nasal cavity. How do you do it with ribbon gauze? Ribbon gauze is a very long gauze. No, you're just going to fold and pack the nasal cavity. Next, if you have Mirasil sponge, you're just going to dip it in Vaseline or put a Neosporin ointment and you have to pack the nose. When you do this, you remember that if you are going to keep it for more than 72 hours, that is more than 3 days, it's going to cause a lot of infection, and also in worse come worse scenario, it can also cause toxic shock syndrome. Therefore, always start the patient, admit the patient and start the patient on antibiotics. Now, you have done anterior nasal packing and you see the posterior pharyngeal wall, there is bleeding. So, you get to know that it's not the anterior bleeding, there is posterior bleeding happening. Now, how are you going to manage it? By using Foley's catheter. You take a Foley's catheter and then you insert it through the nose, and when it reaches the nasopharynx, you are going to inflate the bulb so that it stays there, puts pressure and stop the posterior epistaxis. Okay. Now, after doing all these maneuvers, if the bleeding is not getting controlled, you do something called as surgical ligation of the arteries. So, there is an order that you have to follow in ligating the arteries. Number one, you are going to ligate TESPAL. T-E-S-P-A-L. You are going to ligate the spinopalatine artery. So, spinopalatine artery, as you all know, is one of the major artery giving blood supply, and this is an artery which is involved in both anterior and posterior epistaxis. Therefore, you are going to ligate it first, after which if there is no benefit, you are going to ligate the maxillary artery, because maxillary artery gives two branches, no, spinopalatine and greater palatine. So, you are going to ligate it. If no benefit, you are going to ligate the external carotid artery. So, when you ligate the external carotid artery, it gives how many branches in Kesselbach's plexus? 3. Spinopalatine, greater palatine and superior labial giving the septal branch. Okay. Now, you do all this. Even then, you're not able to control bleeding. What are you going to do? Are you going to ligate the internal carotid? No. If you ligate the internal carotid, the patient is going to die, because the internal carotid gives major blood supply to the brain, right? So, you can't ligate the internal carotid, which is a branch of the internal carotid that supplies the Kesselbach's plexus. There's one branch, no, which is that is the anterior ethmoidal artery. So, finally, you're going to ligate the anterior ethmoidal artery. So, these are the sequence, stepwise things that you're following whenever you get a case of epistaxis. Now, as I told you, TESPAL is nothing but transnasal endoscopic spinopalatine artery ligation. No? So, where do we do it? We do it in the spinopalatine foramen. So, where is the spinopalatine foramen located? 1 centimeter behind the inferior turbinate. This is where you can find the spinopalatine artery foramen. Okay. Next, if you are not able to control bleeding with TESPAL, you go for maxillary artery ligation. And what is the approach that you follow? You follow a Caldwell-Luke approach. Caldwell-Luke approach by endoscopy, nothing but you do a sublabial incision. You can see here, no? This is a sublabial incision that you do, and you assess the maxillary artery by the pterygopalatine fossa root. Okay, this is what you need to know. This picture shows how if you get this picture in the question of epistaxis, that means you're going to ligate the maxillary artery. It is an endoscopic ligation that you do by giving a sublabial incision. Next, external carotid artery ligation. This is the third artery that you are looking at. Where do you do it? You do it in the neck. Where exactly do you do it? At the area just above its branch. Which branch? Superior thyroid artery. After it gives superior thyroid artery, just above it, you are going to ligate the external carotid artery in the neck. Okay. Next, if everything fails, which artery are you going to ligate? Branch of internal carotid, nothing but anterior ethmoidal artery ligation. So, whenever you ligate the anterior ethmoidal canal artery, you are going to ligate it in the anterior ethmoidal canal. So, you can see this image, no? This is the anterior ethmoidal artery. Okay. So, a bony canal over this is removed in the image. That is nothing but the anterior ethmoidal canal. So, you can see this canal lying under the frontal recess. This is the frontal recess. This side is the right side lamina papyracea. This side is the right middle turbinate. So, the anterior ethmoidal artery lies in between these three structures. Now, these are all the anterior epistaxis and the arteries involved in anterior epistaxis. There is something called as venous epistaxis also. What do you understand by venous epistaxis? Venous epistaxis means there is bleeding because of damage to the venous plexus. There is a venous plexus called as Woodruff's plexus, which is seen behind the inferior turbinate on the lateral wall. This is a cause of venous bleeding in people. And this is a cause of posterior epistaxis, especially it happens in the adults and old people. There is also one more type of vein which is called as anterior retrocolumellar vein. This is there in the septum. This could also cause venous bleeding in people. So, these are the things that you have to know. Remember that the arteries comprising the Kisselbach's plexus has to be in the tip of your tongues. Now, we have seen various conditions of nose. Now, we will be looking at various conditions of the sinuses. So, how many sinuses do we have? We have maxillary sinus, we have ethmoids, we have frontal, we also have sphenoid. Ethmoids is further divided into anterior and posterior. Okay. So, there is also one more division. There is anterior group of sinuses and posterior group of sinuses. Which are the sinuses that comprise the anterior group of sinuses? Maxillary, frontal and anterior ethmoidal. Coming to the posterior sinuses, sphenoid and the posterior ethmoid. Okay. Now, let us see how the ventilation happens in the sinuses. The ventilation mostly happens during the time of expiration. So, what happens normally is that if you look at the image of the nose, if you take this as nose, whenever there is inspiration, the air is going to go like this. Okay. Now, when the patient is expiring or the person is expiring, the air currents that come out like this is going to experience some degree of resistance in the nasal valve area. So, this area is nothing but the nasal valve area. Okay. So, when it experiences some degree of resistance in this area, what happens? It is going to reverse its direction. It is going to reverse its direction and form something called as eddy currents, which are going to go and ventilate all the sinuses. So, this is one concept that you have to understand. So, where is the resistance? Resistance is given at the nasal valve area, and this results in the formation of eddy currents, which is ultimately going to go and ventilate all the sinuses. Now, coming to the first sinus that we are discussing today, it is about maxillary sinus. So, maxillary sinus is also called as antrum of Haymor. So, this is the other name for maxillary sinus. So, this is the largest sinus with capacity of around 15 ml. This is the capacity of the maxillary sinus, and maxillary sinus is one of the earliest sinus to develop. So, at birth only you are going to see this sinus. And extra feature, this is the most common sinusitis seen especially in adults. Okay. So, what are the risk factors? Whenever there is any condition, whenever there is any dental infection that the patient presents with, there could be spread of infection into the maxillary sinus. Also, remember that whenever you do extraction of the tooth, the second premolar or first molar, because this is in close proximity with the maxillary sinus, it is going to give formation of a oroantral fistula. Okay, this is something that you have to know about. So, recently I saw a patient who came to us with regurgitation of fluid from nose. So whenever this patient had water, this fluid would come out from the nose. Why was this happening? This was happening because of the oroantral fistula which developed because of the removal of two of his tooth. Which one? The second premolar and the first premolar, because of which there was a connection that developed between the oral cavity and the maxillary sinus, and whenever he had fluids, it would go through the maxillary sinus and regurgitate from the nose. This is what happens. Okay. Now coming to the second sinus, we'll discuss about the ethmoidal sinus. So, ethmoidal sinus is the most pneumatized sinus at birth, and the most common sinusitis in children is nothing but that of ethmoidal sinusitis. This is the most common sinus which could cause certain orbital complications such as damage to the orbit and the contents in the orbit because of common venous drainage. And the second reason is that the medial wall of the orbit. What forms the medial wall of the orbit? Nothing but the lamina papyracea. This is a very thin bone. So, it can easily get eroded and the infection could spread to the orbit. So, whenever there is any ethmoidal sinusitis, where are you going to palpate? You are going to palpate near the medial canthus of the eye. This is the area where you have to palpate to find out if there is ethmoidal sinus tenderness. Then maxillary, where are you going to palpate? You are going to palpate in the canine fossa, and if there is tenderness, it is going to point towards maxillary sinusitis. The next sinus is nothing but sphenoidal sinus. Okay, this is the least common type of sinusitis, and the best type, there is something, okay, this sphenoid sinus is always in close relation to sella. What is sella? Sella is nothing but the bony part that covers the pituitary is called as sella. So, based on the relationship between sella and sphenoid, we have three types of relations, okay. So, these three types of relations are the number one called as precellar, number two is called as cellar, and number three is called as postcellar. So, what do you understand by these? If you look at the image of the sphenoid sinus here, you can see that here, whatever I am pointing with orange, no, this is the area of sella. Here the pituitary lies. Now, with green I am going to point the posterior limit of the sphenoid sinus. So, this is the posterior limit of sphenoid sinus. It is going to end before the anterior wall of the sella. That means this is precellar variety. Now, coming to the cellar variety, this sphenoid is going to go beyond the anterior wall. See, in orange color I am showing you the sella. This is the sella. And the sphenoid is going to go beyond the anterior wall. This is called as cellar variety. And the third one, again, sella is marked with orange color, and you can see that this sphenoid, the pneumatization goes beyond the posterior wall. Then it is called as postcellar. Okay. So, among the three types of sphenoidal pneumatization that you've seen with relation to sella, which is the best type for transsphenoidal hypophysectomy? This is a direct one-liner. It is nothing but the cellar variety. Now, coming to the key relationship of the structures that are there in and around sphenoid, what are there? Optic nerve is in close relation to the sphenoid sinus. We have the internal carotid artery which is in close association. We also have the pituitary in the sella which is in close association with the sphenoid, the pituitary gland. Okay. What are the structures? Optic nerve, internal carotid artery and the pituitary gland. Remember that whenever a patient complains of sphenoid sinus, it is a posterior group of sinus, no? The posterior most sinus in fact. So, he is going to say that he has on end of occipital region headache. Okay. Now, frontal sinus is the last sinus that we'll be looking at. If you can see the superior most sinus, see in green color whatever I am showing, this is frontal sinus. So, the superior most sinus is nothing but frontal sinus. It is the last to develop. It is usually not present at birth. Because it is last to develop, it can be seen on X-ray only around 6 years of age. And how does the frontal sinus drain? They drain through the frontal recess. And frontal sinus is the most common sinus to undergo mucocele formation or to undergo osteomyelitis. This is something you have to know. Now, let us see few pictures and we will try to identify the sinuses, okay. So, in this picture, you can see that this inverted pyramidal-like appearance, This is nothing but maxillary sinus. You can see that, see, this is right and this is left, okay. In the left side, you can see that there is certain opacity that is seen in the maxillary sinus, no. So, this area is pointing to that of maxillary infection, collection in the maxillary sinus. Now, in this image, which are the ethmoidal sinus? These are the ethmoidal sinus. And remember that ethmoidal sinus are in close proximity to the orbit. Medial wall of orbit is very thin, so infection can easily spread to the orbit. Also, they have common venous drainage, because of which infection could spread. Posterior ethmoids lie behind the anterior ethmoids. Next, you have sphenoid sinus. Which is the sphenoid sinus? We saw so many images of sphenoid sinus, no? In one of the images, I am going to point it. This is nothing but the sphenoid sinus. And frontal sinus, as we saw, the superior most sinus is nothing but frontal sinus. Got to know how do you identify each and every sinus on X-ray? Okay. Now, coming to some more X-ray views, there is something called as Waters view. This image that you can see here is Waters view. How are you going to identify it as Waters view? If you see the X-ray, you can see that the mandible, this part, no, mandible is facing upwards. So, this is a view, Waters view. Okay. This view is also called as occipital mental view, and the sinus that is best appreciated in this view is nothing but maxillary sinus. So, you can see this is the maxillary sinus, bilateral maxillary sinus that you can see here. Coming to the next image, this is nothing but Pierce view. What do you understand by Pierce view? It is nothing but Waters view, but here the patient keeps his mouth open. So, because the mouth is open, you can also see the sphenoid sinus. So, basically, you can call it as Waters view plus, if sphenoid is seen, then it becomes a Pierce view. So, what are the other sinuses that you see here? You see the frontal sinus, you see the anterior ethmoids, you see the maxillary, and through the maxillary window, you can also see sphenoid. What is not seen? Posterior ethmoids are not seen here. So, can you mark sphenoid and maxillary here? This area, the inverted pyramid, is nothing but maxillary, and this is nothing but the sphenoidal sinuses. Got it? Okay. Now, coming to Caldwell view. What is Caldwell view? It is nothing but a occipitofrontal view. You're going to pass X-ray beams through and through, which is going to be the best X-ray to diagnose any disease in the frontal sinus. Now, can you help me detect frontal sinus in this X-ray? These two sinuses, superior most sinuses, is nothing but frontal sinus. In this image, you can also see inverted pyramid. No, this is maxillary sinus. You can also see ethmoids near the orbit. Okay, this is a Caldwell's view. It is going to be straight, and this is best for diagnosing pathology in the frontal sinus. Now, coming to the next X-ray, this is called as Townes view. So, what do you understand by Townes view? Townes view is an X-ray which is helping us in order to see the magnum, foramen magnum, as well as the sella. So, if you see the image carefully, you can see this donut shaped circular thing. No, this is nothing but foramen magnum. In this X-ray, this is taken from posterior side, okay. So, you can also see certain bones. So, this bone is nothing but the parietal bone, this area. Then you have the occiput. This is the occipital region, and this side is the temporal bone. So, you can see all these. And what is the use of Townes view? Whenever there is any fracture, you can see whether there is any fracture in the occipital bone through this view. Also, in any congenital anomalies, you can identify if the foramen magnum is bulging, if the foramen magnum is small. All these can be identified with the help of a Townes view. Coming to the last X-ray, this X-ray that you can see here is nothing but a Law's or Schuller's view, and this is one of the X-ray that you commonly see in OPDs. And why do we do this X-ray? In order to see the mastoid air cells and the sinodural angle before we take a patient to either tympanoplasty or a cortical mastoidectomy. So, as you can see in the image here, this area is showing the external auditory canal, and the area behind it, which is pneumatized, this area is nothing but mastoid air cells, and this is an X-ray which is called as Law's or Schuller's view. Now, we have seen the different sinuses. We'll look at the ethmoid sinus in little depth, because in ethmoid sinus, there are a lot of named anterior and posterior ethmoidal air cells that you have to know of. The first cell being agar nasi. What is agar nasi? It is nothing but the anterior most ethmoidal air cell is called as agar nasi. Okay, ethmoidal air cell. Now coming to bulla ethmoidalis, this is nothing but the largest and the most prominent anterior air cell is called as bulla ethmoidalis. Next, we have Haller cell. What is Haller cell? Where is it seen? It is seen in the infraorbital area. That is, it is seen in the floor of orbit. Okay. So, we saw three cells, no? Agar nasi, anterior most. How are you going to remember? A for A. Agar nasi, anterior most. Bulla, large bulla, big prominent air cell. Haller, it is seen in the infraorbital margin, that is nothing but the floor of orbit. So, there is an X-ray here, right? What is it showing? It is nothing but it is a X-ray showing the various ethmoidal air cells and where they are. They are between the nose and the medial wall of the orbit. Okay. Now, if the middle turbinate is pneumatized, what is it called as? It is called as concha bullosa. Do not get confused between the bulla and the concha bullosa, okay? Both are different things. Bulla is an ethmoidal air cell, whereas bullosa is nothing but pneumatized middle turbinate. Now coming to one more ethmoidal air cell, it is nothing but Onodi cell. What is Onodi cell? It is nothing but the posterior most ethmoidal air cell is called as Onodi cell, and this Onodi cell is in close relation to the optic nerve. So in conditions where there is hyperdevelopment or more pneumatization of Onodi cell, it could compress the optic nerve. Okay. Now, the investigation of choice to detect all these named ethmoidal cells is nothing but high resolution CT scan. Now, we need to know about a structure called as osteomeatal unit. So, with this image, you are going to learn it. Okay. So, this is nasal septum and this is nothing but the inferior turbinates. Let's label them for easy understanding. This is nothing but the septum and this is nothing but the inferior turbinate. Okay. Now, let us add an S to this. So, when we add this S and we are going to connect the top, this structure that is formed is nothing but osteomeatal complex. Okay. The image looks very scary in your textbook, no? This is the easiest way to draw an osteomeatal complex. Now, let us see what are the different structures, okay? Now, as I told you, this is the inferior turbinate. We have a bony projection arising from here and this is nothing but the uncinate process. So, this is the uncinate process. Now, we also have a largest ethmoidal air cell. What is it? Bulla. It is seen here. So, here we are going to see bulla. Okay. Next, if this is bulla, what is this structure? This is nothing but orbit. Okay. You have the one more inferior turbinate is done. No, here you have one more turbinate which is nothing but the middle turbinate. Okay. So, you have got to know, you have got a hang of all these structures. What is this entire cavity? This is nothing but maxillary sinus. Okay. Now, let us look at the various structures comprising of an osteomeatal complex. First of all, osteomeatal unit is a unit where there is opening of the maxillary sinus ostium seen. Okay. So, there are four important structures that we have to know. One is the uncinate process. So, in the image, where is the uncinate process? This is the uncinate process. Let me mark with a different color for you to understand it well. So, this is your image and with orange I am pointing, no, this is the uncinate process. Okay. And then you also have one more structure which is called as bulla, ethmoidal air cell, bulla ethmoidalis. So, where is bulla? I am marking again with orange. This structure that I am marking with star is nothing but bulla. Now, between the uncinate and bullous, there is a way, no? Between this that I am marking with green arrow, this way is nothing but hiatus semilunaris. It is the way that is present between the bulla and the uncinate process. It is a semilunar space. Now, this semilunar space is going to lead to a structure which is called as infundibulum. So, what are the four structures that are there in the osteomeatal unit? Uncinate process, then we have the bulla ethmoidalis, we have the hiatus semilunaris and also we have the infundibulum. Infundibulum is a place where the maxillary sinus comes and drains. So I'm going to mark that with purple color. This area that I'm marking now is nothing but infundibulum. It is bounded by the uncinate process and the lateral wall. Here the maxillary sinus comes and opens. Okay. Now whenever there is any pathology involving the osteomeatal area, we do a surgery, and which is a gold standard surgery. It is nothing but FES, which is nothing but functional endoscopic sinus surgery. Functional endoscopic sinus surgery is called as FES. Now we also have a Kiros classification which is used to find out the depth of the olfactory fossa. Now why do we have to know the depth of the olfactory fossa? It is because if the depth is more, it could be easily damaged during surgery. So skull base damage could increase during surgeries. So based on Kiros classification, we have type 1, type 2, type 3. Type 1 is when the length is 1 to 3 mm. Type 2, 4 to 7 mm. Type 3, 8 to 16 mm. The more is the damage to the skull base during the surgeries, like for example, FES. It is going to give the distance between the ethmoidal roof and the cribriform plate. Okay. Now coming to the drainage of the paranasal sinuses, first we look at the inferior meatus. Inferior meatus, just at the highest level of the inferior meatus, we have the drainage of the nasolacrimal duct. Okay. So what is the direction of the nasolacrimal duct? Double. Downwards, backwards, laterally. Downwards, backwards and laterally. Middle meatus, as you all know, is the most congested meatus because it has the highest drainage from the sinuses. All the anterior group of sinuses drain here. Which are the anterior group of sinuses? Maxillary. You also have anterior ethmoids which drain here. Also, you have, which is the other sinus that drains here? That is nothing but the frontal sinus. Now coming to the superior meatus, which structure drains in the superior meatus? It is nothing but the posterior ethmoids. Posterior ethmoids drains in the superior meatus. Finally, we have something called as the sphenoethmoidal recess, and in the sphenoethmoidal recess, we have the sphenoid sinus that drains. Got it? Okay. Let us see this image now. So in this image, you can see, there is opening of the lacrimal duct at this area which I am pointing with star. Okay, so this is the highest point in the inferior meatal area. This is where the nasolacrimal duct opens, and this is the area where we have opening of the anterior ethmoids, opening of the maxillary. This is the area where you can see hiatus semilunaris. So hiatus semilunaris is seen between bulla ethmoidalis and the uncinate process. You can also see the posterior ethmoids which drain into the superior meatus here, and also sphenoethmoidal recess which receives drainage of the sphenoid sinus. Now coming to one of the infective conditions of nose and sinuses, it is nothing but rhinosinusitis. As the name suggests, there is infection in the nose and also there is infection in the sinuses. Okay, so mostly the etiology is by viral infection, but sometimes there could be super added bacterial infection that causes acute rhinosinusitis. So what are the general features of sinusitis? You're going to have nasal obstruction. You're going to have nasal discharge, either pus or a mucopurulent discharge is seen. You can have facial pain because of the pressure effects from the sinuses, and also you can have hyposmia. That is, decrease in the perception of smell is called as hyposmia. Now, based on the location of the pain, you can say which of the sinuses is affected. So, let us see each of the sinuses in detail. Firstly, when we talk about ethmoidal sinus, pain and tenderness is seen over the root of nose. Can you show me where the root of your nose is? Here. Pain and tenderness is going to be there in the root of the nose, and this pain is going to be there mostly medial and deep to the eyes. Medial and deep meaning like this. Okay, they say that with movement of the eye, their pain increases. These are the classic features that are seen in ethmoidal sinusitis. Okay. Now, the second one, frontal sinusitis. Where do you have pain in frontal sinusitis? Pain is present over the forehead region. This is the area where the patient presents with pain. What is the area? Forehead area. And this frontal sinusitis is also called as early morning headache, periodic or office headache. So what happens? Why is it early morning? Because when the patient is lying down, because of gravity, all the infection gets collected in the frontal sinus. And as the patient gets up, there's going to be a lot of pain because of the collected infection. But as the day progresses, because of gravity, the secretions are going down, and when the secretions go down, automatically there is going to be reduction in the pain. Therefore, they say that frontal sinusitis headache is called as early morning or office headache, and by evening the patient is symptom free or he is better. Okay. Now coming to maxillary sinusitis, the pain is there over the cheek and the upper jaw. This is the area where you palpate for the maxillary tenderness, in the cheek and in the upper jaw. So, which is the area where you palpate? It is called as canine fossa. Okay. Now, sphenoid sinus. Where do you have pain? Sphenoid sinus, as you know, is the posterior most type of sinus. No? Because it is posterior most, you have pain in the occipital region. The patient complains of occipital headache. So, these are the different types of sinusitis and where pain is seen. Now, coming to two main type of divisions that you have to know here, it is nothing but acute rhinosinusitis and chronic rhinosinusitis. Acute rhinosinusitis means the duration is less than 12 weeks. Less than 12 weeks means less than 3 months. If it persists for more than 12 weeks, then it becomes chronic rhinosinusitis. Now, what is the etiology of acute rhinosinusitis? Most common etiology is viral. There could also be superadded bacterial infection. Infection by which organism? It could be either Streptococcus pneumoniae, or infection could be because of Haemophilus influenza, or infection could be because of Mirabilis catarrhalis. These are the different bacteria that causes infection. Now coming to the chronic rhinosinusitis, here there is a disordered interaction between the immune system and the local microbes. The local microbes are going to win here and our immune system is not able to clear the infection. There is going to be chronic inflammation hence, and there is obstruction of the osteomeatal complex drainage. Okay. Now coming to the investigations that you do, you can do anterior rhinoscopy, especially in cases of acute rhinosinusitis, and also you can do nasal endoscopy. So when you do endoscopy in acute cases, you can see pus, or you could also see mucopurulent discharge at the level of the middle meatus. This confirms that it is the rhinosinusitis acute type that you are dealing with. But if it is chronic, you have to always do a nasal endoscopy followed by a non-contrast CT, which is the investigation of choice in cases of chronic rhinosinusitis. So here also endoscopic features are going to be same. You are going to see pus or mucopurulent discharge in the level of the middle meatus. Now coming to how we are going to manage. If the patient is symptomatic, you can give nasal decongestants. This is going to relieve the congestion and it is going to make the patient feel better. The nose block gets relieved. You can give painkillers if they complain of too much pressure symptoms over the face and the head. And also you can give antibiotic to treat the bacterial infection. Do you do surgery here? Usually in acute cases, you do not advise any surgery. You always treat it with medical management first, and even after giving medical management for 1 month, the patient is not showing any improvement, then you plan for surgery. Coming to the chronic rhinosinusitis, here also you try medical management for 1 month. You can also give steroid nasal sprays, which is a treatment of choice in cases of chronic rhinosinusitis. You can also give saline irrigation. When you give saline irrigation, it is going to break down the pus and the mucopurulent discharge, and it is going to wash off, giving the person a feeling of reduction in the nose block symptoms and reduction in the pressure symptoms. You can also try giving antibiotics if there is acute exacerbation of the disease here. But in case if the patient does not have any benefit, it's more than 3 months since the patient is complaining of rhinosinusitis, the treatment of choice becomes surgery, which is a surgery that you will plan. It is nothing but FES, functional endoscopic sinus surgery is done to relieve symptoms here. So you're going to widen the ostiums of the sinus so that there is effective ventilation to the sinus. Also in the same setting, you're going to drain all the pus and collection that is there in the sinuses. Now we are going to look at one more condition of the sinus, which is nothing but allergic fungal sinusitis. So what do you understand by allergic fungal sinusitis? It is a non-invasive condition affecting the sinuses. Can you also name an invasive condition? Invasion. What comes to your mind? Mucormycosis. Yes, rhinocerebral mucormycosis is a condition which causes invasive fungal sinusitis. And in which time was it more common? During COVID. A lot of people would complain of black fungus, right? Black fungus is nothing but the mucormycosis. So, allergic fungal sinusitis is a non-invasive condition, and which investigations are investigation of choice? We do a non-contrast CT. And when we do non-contrast CT, we are going to see heterogeneous opacities which are called as double density sign. Double density sign. So, if you see this image here, this non-contrast CT image that I am pointing to, you can see this here. This mass is nothing but an allergic fungal sinusitis mass. If you can see it clearly, you can see that there are areas of hyperdensity and hypodensity intermixed with each other. That is why it is called as double density sign. You have the hyperdense as well as hypodense areas together. Now, there is a diagnostic criteria that we use for allergic fungal sinusitis, which is called as Bent and Kuhn diagnostic criteria, and this is used for allergic fungal sinusitis. Okay. You can also do biopsy in this condition, and when you do biopsy, you get something called as a peanut butter appearance, which is also called as axil grease appearance. This is something that you have to know. Okay. This is one of the named signs that can be asked in your exam. Peanut butter or axil grease, seen in allergic fungal sinusitis, seen in biopsy. Okay. Now, there is also one more image that you can see here. Lot of mucinous strands that are there and lot of non-invasive structures that are there here. This mask-like thing, this entire picture is the picture of allergic fungal sinusitis when you see through the anterior rhinoscopy in the nasal cavity. Got it? Okay. So, there is a small mnemonic that you can remember in order to find out the different criteria, the major and minor criteria features of the Bent and Kuhn classification. And Mr. Kuhn, this word itself tells us about the major criteria. Now, using the mnemonic Mr. Kuhn, let's try to find out what are the 5 major criteria. Number 1, M stands for mucin. What is the type of mucin that is seen? It is eosinophilic mucin that we are talking about in allergic fungal sinusitis. See, in allergic fungal sinusitis, the word allergy is already there. And whenever there is allergy, there is going to be increase in eosinophils. Therefore, the mucin is going to be eosinophilic. Now, you do a fungal mount, KOH mount, that is nothing but fungal smear. Fungal smear is the major criteria. 2 years back, there was a question that was asked and the question was, among the following options, which one is not a major criteria? So, there was fungal smear also in the option. You also had fungal culture. So, a lot of students got confused between these two. The major criteria is nothing but fungal smear. This is something that you have to remember. Okay. And this is for K, right? KOH mount. What is the next word? U. U stands for or 1. 1 means type 1 hypersensitivity is seen here. It's an allergic condition, So, we have atopy and the type 1 hypersensitivity is going to be seen here. So, we finished 3 features: eosinophilic mucin, fungal smear, type 1 hypersensitivity. Now, we discussed about CT, non-contrast CT finding. What was that? Double density sign. So, this double density sign is one more feature of the major criteria, and also we have nasal polyps. Nasal polyps is easy to remember, allergic condition, polyp development, like that you can remember. It is very difficult to remember major and minor criteria both. So, always focus on remembering the major criteria. Whatever is not in major criteria comes in minor criteria. I'm just going to brush through those. They are nothing but Charcot-Leyden crystals, unilateral condition, radiographic bone erosion, eosinophilia, asthma, and fungal culture. There are 6 minor criteria. You make sure that you remember the major criteria. Repeat after me. Eosinophilic mucin, KOH mount showing that is nothing but fungal smear, type 1 hypersensitivity, double density sign in non-contrast CT, as well as nasal polyp. Now coming to yet another topic, we're going to be discussing about mucormycosis. So around 3 to 4 years back, we had COVID, right? I think you had heard a lot of people complaining of something called as black fungus, and this was in the news for a very long time. So what is this black fungus? It is nothing but mucormycosis, and this mucormycosis is also called by another name. It is called as rhinocerebral phycomycosis. So it is caused by which fungi? It is either caused by mucor or it could be caused by rhizopus. So these are the two fungi that is going to cause mucormycosis. And whenever a person has mucormycosis, there is going to be anesthesia over the entire nasal mucosa inside, and there is also going to be anesthesia over the cheeks. They say that they cannot feel any sensation in these areas. On examination, that is whenever you do an anterior rhinoscopy, you put a tudicum speculum and examine the nasal cavity, you see that all the turbinates have become black. You can see black turbinates, and also you can see that there are going to be lot of debris in the nasal cavity. Now, what is the investigation of choice that you do in order to get the diagnosis? To confirm the diagnosis, you take a biopsy from this area and send it for a histopathological examination. And when you do histopathological examination, you can see the HP image here. No, what are you seeing here? You can see that there is going to be broad aseptate hyphae. Can you see this? This is very broad hyphae. There are no septations. So, broad aseptate hyphae. And what are you going to see? Which is branching at 90 degree. So this is a classical feature that you see in a case of HP of mucormycosis. Broad aseptate hyphae branching at 90 degree. Now, how are you going to treat the condition? You're going to treat the condition with amphotericin. Remember, amphotericin is a very expensive drug. That's why the treatment becomes very, burdensome for the patient, especially if they have financial constraint. Amphotericin is expensive. The surgery is very vast. In surgery, you're going to debride all the areas that are looking black. You're going to extensively remove all these structures. Now, when you do CT in these people before surgery, can you find any characteristic signs seen? You can see that all the sinuses which are involved show opacification in the CT. Why there is opacification? Because of the sinuses being occupied by the fungi, because of the fungal growth. There is also going to be bony erosion. We saw one more condition, right, recently where there was no bony erosion, a fungal growth. What was that? Allergic fungal sinusitis. There won't be a bony erosion there, but here we have bony erosion, and we can also see lot of tissue infiltration. And mostly, whenever we talk about mucormycosis, we have to know that it is not going to be seen in each and every person. It mostly occurs whenever there is an underlying immunosuppression. For example, in people who had COVID, who also had decreased immunity. For example, if they were case of diabetes mellitus, if they were on anti-cancer drugs, if they were on any systemic steroids, all these would have reduced their immunity. That is when this fungus could easily invade and grow. Okay, so your main aim should also be in order to remove the features of immunosuppression in these people. Okay, now coming to one more topic, it is nothing but rhinitis. What is the most common cause of rhinitis? It is nothing but rhinovirus. Okay, so there are a few more terms of rhinitis that you have to know. Whenever you have seen people skiing, no? What are these people called as? Skiers. So rhinitis is commonly seen in these people because of continuous exposure to cold air blast, air currents going into their nasal cavity, and in these people it is called as skiers rhinitis. Now, there is also something called as drug-induced rhinitis. What do you understand by drug-induced rhinitis? There are certain drugs, for example, alpha blockers, estrogen, which cause vasodilation and a lot of congestion in the nasal cavity and cause cold. So, this is called as drug-induced rhinitis. Now, in those people who use decongestants for number of days, okay, number of days meaning more than a week, more than 7 days. What type of decongestants? Oxymetazoline or xylometazoline. You get all these, no, as Solvin, Nasoclear in the market, and these people take this, for example, Solvin, and they continuously use it. And when they do this, what happens? For a brief period of time, they feel like they have benefit, but within few minutes, they feel like using it again. Why is it? It is because of the rebound nasal congestion that happens because of the continuous use of decongestants, and the condition is called as rhinitis medicamentosa. That's why you have to always advise your patients to not use decongestants for more than a week, okay? Next, we have something called as vasomotor rhinitis. What is vasomotor rhinitis? It is caused because of increase in the parasympathetic activity, or in other words, due to parasympathetic hyperactivity. If you have rhinitis developing, that is called as vasomotor rhinitis. So, which is a nerve involved? It is a Vidian nerve that is involved. So, how is Vidian nerve formed? It is having two components. One is nothing but greater superficial petrosal nerve. Did we study about this nerve somewhere? Yes, it was a branch of facial nerve. Now tell me, where was it given? At the level of first genu. It supplies what? It supplies palatal, nasal and lacrimal gland. And the second component of Vidian nerve is nothing but the deep petrosal nerve. Now, coming to the greater superficial petrosal nerve, this is going to cause vasodilation and increase in secretions, whereas when we talk about deep petrosal nerve, it is going to cause vasoconstriction. So, these two are the components of Vidian nerve. Vidian nerve is also called as nerve to pterygoid canal or nerve in the Vidian canal. Okay, so whenever there is a patient who comes to you with vasomotor rhinitis, the nasal mucosa is going to be congested, whereas the Ig level is going to be normal. If it is allergic rhinitis, because of allergy, Ig levels is going to be increased. This is a non-allergic condition, non-infectious, and it is having a perennial type of rhinitis, whereas allergy is mostly flared up. It has seasonal, variation seen, but in vasomotor rhinitis, that is not seen. So, how are you going to treat it? You can try giving steroids to this patient. You can give them decongestants. What type of decongestants? Either oral or local decongestants. And also in cases which does not respond to this treatment, you can always go for Vidian neurectomy, because Vidian nerve is a culprit in this condition. Now, we also have allergic rhinitis. So, allergic rhinitis is a condition which is having allergy, and when you see the nasal mucosa looks edematous, and it is also type 1 hypersensitivity that you see here, and in this condition the Ig levels is going to be substantially increased. Now, moving forward with the next topic, we'll be discussing about CSF rhinorrhea. So, what do you understand by CSF rhinorrhea? Here also the patient presents to you like cold only. They have increased watery secretion from nose, but now it is not the cold that the person is suffering from, but instead the cerebrospinal fluid is leaking from the nasal cavity. Okay, so what is the most common cause? Normally, you know that CSF won't leak from nose, no? So, there has to be a trauma which has damaged the skull base, the base of skull, because of which the cerebrospinal fluid is leaking through the nasal cavity. So, if you can see in this image, I'm going to point at this area. No? The bony skull base is defective here because of trauma, due to which the cerebrospinal fluid is leaking through the nose. Okay, so there are a few common fracture sites, and these are the areas from where the CSF could leak. So, what are these common fracture sites? One, in the anterior cranial fossa, we have the cribriform plate. Especially the lateral lamella of this cribriform plate is very weak, and it can get damaged due to trauma very easily. Even in the fractures of frontal bone, we can see CSF leak. Now, if you look at this image, can you look at this image? Can you tell me what is this structure that I'm marking? What is this? Correct. Maxillary sinus. What are these structures? These are nothing but turbinates. Okay. What is this? Ethmoids. Right. So, you can also see that on top, I'm going to point with orange color. So, this area is there, no? These two walls, these are nothing but the lateral lamella of the cribriform plate. So, this can get easily damaged because of trauma, leading to CSF rhinorrhea. Now, in the middle cranial fossa, there could be damage of the sphenoid sinus or the transverse temporal bone, which could again lead to CSF rhinorrhea. Mostly the CSF otorrhea occurs because the middle cranial fossa is directly going to drip the CSF through the ear. Okay. Now, coming to the clinical features, what do you see here? As I told you, you are going to get a history of trauma, classic history of trauma, and then the patient presents with unilateral nasal discharge, and this nasal discharge increases on leaning forward. That is, the patient is going to tell you, doctor, when I sit like this, I'm normal, but when I bend back, there is gush of secretions, watery secretions coming out of the nose. Like drop by drop, it is going to continuously fall. Okay, and this patient cannot sniff it back. So, inability to sniff. So, usually if a person has common cold and he has watery secretions, if he sniffs back, he is can take the secretions inside his nasal cavity back, no? But that is not the case with CSF rhinorrhea. Therefore, we say that reservoir sign is positive here. Wait, did we also see reservoir sign somewhere else? Mastoiditis. What do you understand by reservoir sign? Even though you try to clear secretions, it immediately fills up because somewhere else a bigger space acts as a reservoir. So here also, once all these nasal secretions drip out, even then immediately when he goes back and comes forward, again there's going to be gush of secretions because it is coming from the above the skull base. Okay. Now, there is something called as handkerchief test that you do. Usually what happens whenever you have rhinitis and you try to clean your nose with a handkerchief, after a while you notice that the handkerchief has got stiffened, no? But in case of CSF rhinorrhea, it does not stiffen, it stays as it is. So, no stiffening is seen in case of CSF rhinorrhea. There is also a classic sign that you see whenever you put these drops on the filter paper, you can see a halo or a double ring sign. So double ring sign on filter paper meaning that centrally there is blood and this blood is surrounded by a halo of CSF. You can see in this image, no, centrally you have blood and this blood is surrounded by CSF in the periphery. Now, coming to what are the investigations that you do in order to diagnose a case of CSF rhinorrhea. Number one, you do certain biochemical tests. And these biochemical tests are the investigation of choice for CSF rhinorrhea. The number one you do is nothing but beta transferrin levels. Beta transferrin levels gives you the most specific diagnosis of CSF rhinorrhea. You can also use beta trace protein levels, but the most specific among these two is nothing but beta transferrin level. Radiology is the investigation of choice again. Which kind of radiology? You do high resolution CT scan, because when you do high resolution CT scan, it is going to help you to identify the site at which there is a skull base fracture. And you can do other investigations also which help you to localize the site of active leak intraoperatively. So what are these investigations? Number one, you can do a CT or you can do a MRI guided cysternography, and when you do the cysternography, intraoperatively you can find out which is the exact place from which the CSF is leaking. You can also do intrathecal fluorescein study. This intrathecal fluorescein study is also going to tell you what is the site of active leak. So what do you understand by this word intrathecal? It means to the spinal cord you're going to inject the fluorescent dye in order to localize the site of leak. Now, you have diagnosed the condition. How are you going to treat it? Firstly, you have to try with conservative management. And by conservative management, how long can you try conservative management? For about 2 weeks, you can try conservative management. The number one thing that you advise the patient to do is nothing but head elevation. That is, you advise the patient to be in a propped up position. Okay, and then you have to ask the patient to avoid straining, avoid forceful nose clearing or nose blowing, and avoid forceful coughing, because whenever they do these, there is going to be a gush of fluid that comes out of his nasal cavity again. Okay, you have to give them stool softeners, because if they have constipation, again they're going to put a lot of pressure, and even that increases the nasal secretions. And you can also give prophylactic antibiotics, but the role of prophylactic antibiotics is still controversial. Okay, and why do you give prophylactic antibiotics? It is given in order to prevent meningitis. Okay. Now, if none of these medical management and the conservative management is giving any relief, you go for surgical management, and surgical management is a definitive treatment. And when do you do this? You do this after trying the conservative management for about 2 weeks. So, what is the surgery that you are going to do? Is it endoscopic or external? It is always the endoscopic surgery which gives better results, and it is more preferred than an external approach. Why endoscopy is better preferred? Obviously because of reasons like less invasive, more field of vision, and nobody wants a scar externally, right? So that is why endoscopic surgery is always preferred these days. Now let's move into one more important topic in the nose, and this topic is nothing but the topic of polyps. So as you all know, there are two types of polyps mainly. You have the ethmoidal polyp and you have the anterochoanal polyp. Okay, so there are various etiology for an ethmoidal polyp. So in your question, you can definitely expect one of the questions from this topic. Okay, especially from the etiological part. Now coming to ethmoidal polyp, one must know that this is the type of polyp that is seen bilaterally, and allergy is one of the most common etiology of ethmoidal polyp. Now there are various etiological causes in adults and children, and we'll look into each of them separately. Now coming to the adults, the number one reason for an ethmoidal polyp is nothing but allergic rhinitis. It is the most common cause of an ethmoidal polyp. So whenever there is allergic rhinitis, as we saw in the earlier discussion, there is going to be watery nasal discharge seen. The patient also has sneezing, itching around the nose, itching around the eyes. These are all the classic features of allergy that the patient comes to you with, and with that he also has features of nasal obstruction because of the polyp formation that is happening. There is always going to be family history of allergy or atopy, and also if you look into the levels of IgE, the IgE level is going to be increased in these people. Now coming to the second etiological cause, we have something called as AERD. What does AERD stand for? Aspirin exacerbated respiratory disease, which is also called as Samter's triad. This is one of examiner's favorite part. So in Samter's triad, as a word suggests triad, it comprises of three things. Number one, see, as a name suggests, aspirin exacerbated respiratory disease. So something to do with aspirin. These people have severe insensitivity to aspirin. So aspirin insensitivity is seen. And along with aspirin insensitivity, these people also have nasal polyps. So how to remember this? We are studying about AERD or Samter's triad in the topic of nasal polyp, right? So obviously nasal polyp has to be one of the component. Aspirin insensitivity, it is there in the name itself. And the third feature is nothing but asthma. So these three things comprise the Samter's triad. This is a non-IgE mediated hypersensitivity reaction. Therefore, the IgE levels are going to be normal. There is going to be abnormal arachidonic acid metabolism involving COX-1 and 2, COX-1 more than COX-2. Now, do you know how the arachidonic acid gets metabolized? So, you have to know that this arachidonic acid can get metabolized by two pathways, either a cyclooxygenase pathway or a lipooxygenase pathway. When the metabolism is through COX pathway or a cyclooxygenase pathway, it gives rise to formation of the prostaglandins. This prostaglandins further has a role in stabilizing the mast cells. So when the mast cells are stabilized, that means there is reduction in the histamine release. So this is a normal thing that happens in the COX pathway. Whereas when you look at the LOX pathway or the lipooxygenase pathway, this is a pathway where arachidonic acid is broken down in order to form leukotrienes. And what is the function of leukotrienes? These leukotrienes is going to increase the secretions, the respiratory secretions, bronchial secretions, and also it is going to bring in bronchoconstriction. Okay. Now what happens whenever there is Samter's triad or aspirin exacerbated respiratory disease? There is going to be defect in the COX pathway. So when there is defect in COX pathway, all the arachidonic acid is going to the second pathway, that is the lipooxygenase pathway. It all goes to lipooxygenase pathway. So what happens? There is increased leukotrienes. Because of increased leukotrienes, there is going to be increased bronchial secretions and bronchoconstriction. That is the number one thing. Plus, it is not going through the COX pathway, the cyclooxygenase, because of which the prostaglandin production is reduced. So it is not going to stabilize the mast cells. Therefore, there is increase in the histamine release. This is what you have to understand when we talk about Samter's triad. So the person has insensitivity to aspirin. So the treatment here is aspirin desensitization, and also you can give the patient with montelukast. There are a lot of researches which say that montelukast brings in a lot of changes in the condition. Now the third etiological condition for ethmoidal polyp is nothing but Churg-Strauss syndrome. This Churg-Strauss syndrome is also called as eosinophilic granulomatosis with polyangiitis. This Churg-Strauss syndrome is going to affect both the upper respiratory tract and the lower respiratory tract. When it affects upper respiratory tracts, it is going to cause chronic sinusitis, and when it is going to affect the lower respiratory tract, it is going to cause asthma. And also, when you take a biopsy, you're going to see that in histopathology, there is a lot of peripheral eosinophilia, and the eosinophilic count is more than 10%. Now coming to the fourth cause, it is nothing but Young syndrome. Young syndrome is very, very rare. It also has a triad. Okay. what are the three things that come in triad? Number one, you're talking about nasal polyps, no? So there is polyps and sinusitis. This is nothing but the first component. The second component is related to lung. That is, you have something called as bronchiectasis. That is nothing but improper clearance of secretions from the bronchioles, from the bronchi, lungs. And the third one is nothing but obstructive azoospermia, causing infertility. So, how are you going to get a question in your exam? They're going to say that a person comes to you with bronchiectasis. He also has a chronic sinusitis and he also has infertility. What is the person suffering from? Your answer has to be young syndrome. How are you going to remember this? You're going to remember young male having infertility. There is also one more syndrome which is nothing but carcinomas syndrome, and it also has three limbs. So the first feature, even there is sinusitis, and the second one is bronchiectasis. Only one difference is with the third one. Instead of azoospermia, there the person has dextrocardia. So how are you going to remember both? As I told you, remember that young syndrome, the patient always has azoospermia, young male with infertility. Okay. Now let us look at few images of ethmoidal polyps. If you look at this picture here, this is a nasal cavity, and when you do an anterior rhinoscopy, you can see that a polypoidal mass is protruding between the middle turbinate and the nasal septum. This is nothing but a picture of an ethmoidal polyp. Now coming to the second image, you can see a CT guided image here, and in this CT image, you're seeing that this pyramidal structure is nothing but with sinus, maxillary sinus. You have the ethmoidal sinus here, and then from the nasal cavity, you can see a mass that is hanging. This mass is nothing but ethmoidal polyp. Okay, this is also the same image. This is the polyp that you can see. Okay. Now coming to causes of ethmoidal polyps in children, we have two major causes. Number one being cystic fibrosis, and we also have carcinomas syndrome. When we talk of cystic fibrosis, this is also called as mucoviscidosis. So here there is defect in the chromosome number 7. The chloride channels are defective. When the chloride channels are defective, the chloride channel functioning is absolutely necessary for the proper functioning of cilia. Because the chloride channels are defective, the ciliary motility is affected, because of which there is improper clearance of secretions. The patient comes to you with sinusitis, the patient also has nasal polyps, and the patient also has recurrent lung infections or recurrent pulmonary infections. Pulmonary infections in the form of bronchiectasis is also seen because of improper clearance of lung secretions. In the case of cystic fibrosis in a child, you always see certain extra features like intestinal obstruction, pancreatic insufficiency, and malabsorption syndrome. Now coming to the next cause, it is nothing but carcinomas syndrome. So what happens in carcinomas syndrome? Here we also have a triad like that of young syndrome, but young was seen in young males. No? Carcinomas is seen especially in children. The number one feature, can you tell me, similar to young syndrome? It is nothing but nasal polyps or sinusitis. And the number two feature is nothing but bronchiectasis. And the third feature here is nothing but dextrocardia. That is, normally the heart is turning towards left, no? But in this condition, the tip is pointed towards the right side. Or the feature is also called as situs inversus. So basically, you have to understand that the ciliary functioning here is lost in carcinomas syndrome. Therefore, the syndrome is also called as primary ciliary dyskinesia. Okay. So, here you can get a question where the doctor tells you that a patient comes to you with recurrent sinusitis-like features, nose block, obstruction, and then he also has certain lung infection, lower respiratory tract infection, and in the X-ray you can see to it that the tip of the heart is turned to the right side. What might the person be suffering from? Then your answer has to be carcinomas syndrome. Now, coming to how are you going to manage this condition? Initially, you can always go for medical management. You can give nasal steroids. These steroids are going to reduce the size of the polyp by reducing the inflammation, and it is going to bring in symptomatic relief in the patient in all the symptoms. You can also give the patient saline nasal spray. This saline nasal spray is going to moisturize the nasal cavity, plus it is also going to help in clearing the allergens. Now, surgically also you can manage the condition. So, what do you do surgically? You are going to do the classic surgery. The surgery is named as FES. Functional endoscopic sinus surgery is done in this person, and as you all know, FES is a minimally invasive surgery and it restores the sinus drainage and ventilation. So in FES, what are you going to do? You can do FES for two reasons. Okay, whenever there is infection in the sinuses, you can do FES to clear out all the infection, and if there is any block like this, whenever there is polyps, you can go clear polypoidal mucosa from each of the sinus, and you can also increase the size of the ostium, so the effective ventilation of the sinuses is maintained and all the secretions get cleared out immediately. Now, nasal polyp excision can also be done. Whenever the polyp is excised, it is going to bring in relief in the symptoms of nasal obstruction in the patients. Now we have looked into the various etiological factors contributing to the formation of ethmoidal polyp. Now let's look at another type of polyp which is called as anterochoanal polyp. As the name suggests, it originates from the antrum. Where is antrum? For which sinus we are talking about? We are talking about the maxillary sinus. So this polyp arises from the maxillary antrum and it is going to go posteriorly into the choana. What is choana? The posterior nasal cavity is called as choana. So when the polyp arises from the maxillary antrum and goes to the choana, then it is called as the anterochoanal polyp. And remember, the most common etiology for an anterochoanal polyp is nothing but infective. And also, anterochoanal polyp is always a unilateral. Mostly around 90 to 95% of the time, it is going to be a unilateral polyp that you see. So in the image, you can see that there is a polyp which is developing from the maxillary antrum and it is moving backwards to the choana. And what are the causes? Gravity, the angulation of the opening of the maxillary sinus and the more space that is available in choana, all these contribute to the movement of this polyp posteriorly. Okay, and then in this is another image where you can see different sinuses. Can you help me mark all the sinuses? Number 1, the start sinus here, maxillary sinus. The sinus near the orbit, ethmoidal sinus. Superior most sinus, frontal sinus, right. Now we can see this CT image here which is showing an anterochoanal polyp. You can see that the polyp is completely occupying the maxillary sinus and it has moved out to the choana. And you can see it is unilateral. It is seen only in one side. Now coming to one of the classic sign that you have to know, this sign is called as a Dodds sign. And what is the use of Dodds sign? It is going to help us differentiate between a polyp and a juvenile nasopharyngeal angiofibroma. So how is it going to differentiate, or how is it going to help us differentiate? You can see this lateral view X-ray. No, I'm going to show you that this orange color thing that I'm marking now is a polyp. Okay, this is a polyp that is extending beyond the soft palate, and above this you can see that there is a crescent of air, that is this black shadow that you see above it. No, this crescent of air is seen. That means the air crescent is positive, and the sign that is called as dot sign is also called as crescent sign because of the presence of the air space above the polyp. But if you talk about nasopharyngeal carcinoma, you cannot see this air column. The cancer completely obstructs the cavity, the posterior choana, and it goes behind the soft palate, and this air crescent sign is not going to be seen in a case of JNA. Now let's go into one more topic. This topic is about nasal bone fracture. So basically, you know that the nose is the most protruding part of the face. No? So whenever you bump into something or there's an accident, assault, nose can commonly get injured because this is the first point of contact with the external surrounding. So as you all know, it is the most common type of facial bone fracture, and I told you the reason. What is the reason? Because it is the most protruding part of the bony framework of the face. And there could be various causes of the nasal bone fracture. It could be assault, it could be accidents, or also it could be because of any contact sports injury. When a patient has nasal bone fracture and they come to you, what are the complaints that they come to you with? Because of the nasal bone fracture, because of the septal deviation, there could be nasal obstruction that the patient has. There could be edema over the nasal dorsum. That is, there's going to be bulged, bulky nose that you can see because of the edema. There could be crepitus over the nose. What do you understand by crepitus? Crepitus is nothing but the grating sound that you hear when you try to move the bones in the nose, or whenever there is any fracture, whenever you try to move the bony ends, you can see this grating noise, which is nothing but crepitus, because of the escape of the air bubbles that are trapped inside. There is going to be visible deformity and deviation seen whenever the nasal framework is damaged. Now, coming to the three different types of nasal fractures, number one, it is called as chevalet fracture. So, what do you understand by chevalet fracture? There is going to be a vertical fracture in the septum. So, whenever there is a vertical fracture in the septum doesn't move a lot. So, there is going to be very minimal or mild deformity seen in the nose, and mostly the septum remains undisplaced. So, the fracture line runs parallel to the dorsum of the nose. So, you can see the image here, no? There is a fracture line which is running vertically in the septum, and this is nothing but chevalet deformity or chevalet type of fracture. The class 2 type of nasal fracture is called as Jarjaway. So, in Jarjaway fracture, what happens is that there is going to be a horizontal or a C-shaped fracture line running in the nasal septum. And here, there is going to be gross deformity seen because the septum here is going to be deviated. This is what you have to understand. In chevalet fracture, the septum doesn't deviate, whereas in the Jarjaway fracture, the septum deviates either to right or to the left. Now, coming to the third type of nasal bone fracture, it is called as naso-orbito-ethmoidal fracture. So, this naso-orbito-ethmoidal fracture, you can name it as NOE, N-O-E. And as a name suggests, no, right? So, nobody wants to get such a fracture because whenever there is a naso-ethmoidal orbital or the naso-orbito-ethmoidal fracture, there is going to be pig nose deformity that develops. You can see the image here, no? How is the nose of this person looking? Like the pig's upturned nose. So, whenever the nose looks like this, it is nothing but a pig's nose deformity, and it is seen in naso-orbito-ethmoidal fracture. No fracture, nobody wants to get it. There is pig nose deformity. Why there is pig nose deformity? Because of fracture of multiple bones. Fracture of nasal dorsum, fracture of perpendicular plate of ethmoid, fracture of cribriform plate, and even lamina papyraceae. So, you have to remember one more point here, that this is also a fracture post which the patient can come to you with CSF rhinorrhea. So, if you have a question which says that a person had nasal fracture recently and currently the patient has come to you, he says that whenever he leans forward, watery secretions come out of his nose and he's not able to sniff it back, and whenever he tries to clean it with handkerchief, it doesn't stiffen. What is the classic diagnosis that comes to your brain? CSF rhinorrhea. Which type of nasal fracture leads to it? Type 3 fracture. Which is a type 3 fracture? NOE, no fracture. What is it? Naso-orbito-ethmoidal fracture. Now, you have seen the different types of fracture. Let's look into the treatment method of these fractures. So, for class 1 and 2, the treatment remains same. And for class 3, we have a different treatment protocol that we follow. Whenever there is a class 1 or 2, that is a chevalet or Jarjaway fracture, if the patient presents to you early, that is, if they present to you within 3 weeks, you do a certain type of management. That is, you wait for about 5 to 7 days for the edema to subside, and only then you're going to manipulate the fracture. How are you going to manipulate the fracture? You're going to do a closed reduction. And when you do closed reduction, you use two types of instrument. What are they? They are nothing but the Walsham's forceps, and you use one more forceps which is called as the Ashes forceps. Now, by looking at this image, you tell me which is the Walsham forceps and which is the Ashes forceps. So, the first image that you're seeing here is nothing but a Walsham forceps, and this is a forceps that you're using in order to reduce any fracture in the lateral wall of nose. Now, the second image that you're seeing here is nothing but an Ashes forceps, and the Ashes forceps is used in order to correct any deformity in the nasal septum. Now, both these, forceps look almost same. How are you going to say which is Ashes, which is Walsham? If you get this picture as a spotter in your exam, how are you going to say which is Ashes and which is Walsham? So, I'm going to tell you a simple trick that you can use to remember. So, you can see this, no? In this Ashes forceps, the apex of the forceps, there is going to be a apical bend. Correct, no? The tip or the apex of the forceps is bent. There is an apical bend. So A for A, apical bend is seen in the Ashe's forceps. And the septum will be usually depressed in case of fracture. You are going to put it has that bend because that bend has to go inside the nasal cavity and bring the depressed septum backwards. This is how we can remember. So the forceps which does not have an apical bend becomes the Walsham's, which you use for the lateral wall. So once you reduce the fracture, you are going to apply external nasal splint and support, and you're going to keep it for quite some time so that the contour of the nose is maintained. If the patient presents to you after 3 weeks, it becomes a late presentation, and that time a deformity would have set in. So you're going to do a open rhinoplasty, or you can do a septorhinoplasty in order to correct the deformity. And whenever you're planning for a septoplasty or a septorhinoplasty, remember it should never be done less than 17 years of age, because the facial bone development wouldn't have stopped by 17 years of age. So only after the patient turns more than 17, you're going to plan a septoplasty or a septorhinoplasty. Now, this is what you're going to do when the patient comes to you with class 1 or class 2 fracture. Now imagine the patient comes to you with class 3 fracture. So in class 3, we know that it is a no fracture. No, nobody wants that fracture. There are going to be severe deformity associated with class 3. There is also CSF rhinorrhea that is associated. So here, whenever the patient comes to you with this fracture, you're going to do the ABCD protocol of trauma. You're going to maintain the airway, breathing, circulation, defibrillation, and you're directly going to take the patient to the operating theater, and you do an immediate surgical intervention. And mostly you're going to do a open surgical reduction and internal fixation. Nothing but ORF, open reduction with internal fixation. So this is a treatment for severe fractures seen in class 3 type of nasal fractures. Now let's look into certain other fractures involving face. The number one fracture that I want to discuss here is about the blowout fracture. The other name of blowout fracture, what is it? It is nothing but the orbital floor fracture. Okay, so whenever there is an orbital floor fracture in CT, you have two important named signs. They are nothing but a teardrop sign and a trapdoor sign. So you have to know these two signs. Okay, so the teardrop sign is nothing but the orbital fat which is protruding into the maxillary sinus through the defect in the floor of the orbit. So you can see this image here. No, there is a defect. There is a fracture line that is running here. This is a fracture line because of which the orbital fat is protruding into the maxillary sinus. So it looks like a teardrop, hence called as a teardrop sign. So we have second sign which is called as trapdoor sign. This is also seen in the floor of orbit fracture. Here what happens, there is a fracture in the base, the floor of the orbit, and when this fracture segment tries to resolve on its own, tries to go back, it is going to incarcerate an extraocular muscle. So it is going to incarcerate an extraocular muscle as it is trying to reduce. So usually what happens, it is called as trapdoor because you are trying to open the door. What is it? That is nothing but the fracture fragment. I'll show you in the next image. So this is the image of a trapdoor sign. So you can see this fracture fragment that I am marking now. This, you consider this as a door. So it has come into the maxillary sinus. Now it is trying to close and go back to the floor of the orbit. When it is closing, it is going to entrap this extraocular muscle in its way. Then this sign is called as a trapdoor fracture sign. Where is it seen? In the orbital floor fracture. Other name of orbital floor fracture, blowout fracture. Coming to the next fracture, tripod fracture. As a name suggests, tripod. What does a tripod stand have? 3 legs, no? Similarly, this tripod fracture has fracture in the 3 bones. Okay. So what are the 3 bony fractures that you see in a tripod fracture? Let's discuss with the help of this image. Number 1, nothing but, where is it? This area. This is the number 1 area of fracture. This is nothing but zygomatico maxillary fracture. Whenever there is zygomatico-maxillary fracture, there is going to be damage to the infraorbital nerve, because of which there could be anesthesia seen over the face area, over the cheek area. Okay, the zygomatico-maxillary component can also be said as an infraorbital component of the tripod fracture. Next, you have the second one. The second one is nothing but the zygomatico-frontal. This area here, no, this is showing the zygomatico-frontal. Number 2. Zygomaticofrontal, which was the first one, zygomaticommaxillary. This is zygomaticofrontal, and the third limb of this tripod fracture is nothing but zygomaticotemporal. So you have 3 fractures seen in this patient. Zygomaticotemporal, it's marked this in the image. This area is showing the zygomaticotemporal. So there is vast fractures here, no, because of which the patient presents with trismus. He has difficulty in opening his mouth. There can be diplopia because of the infraorbital and the zygomaticommaxillary component. There could be enophthalmosis, that is pushed out appearance of the eye, and also there is going to be periorbital emphysema, air collection around the orbit seen in this tripod fracture. Now coming to the certain other fractures of the temporal bone. So whenever we talk about a temporal bone fracture, remember there could be 2 types of fractures. Number 1, longitudinal fracture, and number 2, nothing but transverse fracture. Always remember the word longitudinal. Long list of fractures come under these type of temporal bone fractures. So around 80% of fractures are longitudinal fracture. And as the name suggests, the fracture line is going to go through the long axis of the temporal bone. And in the long axis of temporal bone, what do we have? We have all the vital structures of hearing. We have the tympanic membrane, you have the ossicles. So there is going to be discontinuity here, damage to the tegmen, because of which the patient can have conductive hearing loss. Also, patient has ear bleed. Patient also can have CSF leak. These are the 3 important things that you have to know. 80% of the fractures of temporal bone are longitudinal, conductive hearing loss, bleeding, CSF leak. Okay. And when do you get a longitudinal fracture? You get it whenever there is a parietal blow. That is blow here. Parietal region, you are going to get a longitudinal fracture. Second type of fracture is nothing but a transverse fracture. That is, it is going to bisect the temporal bone horizontally. So it is going to bisect the temporal bone horizontally, because of which there is more damage to the inner ear. Let's see some of the important features that come in the transverse fracture. Number 1, it is little less. Only 20% of the cases present with a transverse fracture. And here we have a sensory neural hearing loss, because the inner ear is affected, cochlea is affected, because of which we have features of inner ear defect, sensory neural hearing loss. Patient has vertigo. Patient also can have other features like facial nerve injury, because facial nerve is in close proximity in this area. Also, if you talk about bleed in CSF rhinorrhea, that is not going to be very significant here. If you try to remember all the points, you are going to get confused. So remember 2-3 key points for each of these. And the transverse fractures occurs whenever there is an occipital blow. The lower blow causes a transverse fracture. How are you going to remember it? Longitudinal fracture, most common. Long, most common. No, it is up. Okay. And then the transverse fracture, it is less common. It's in the lower limit. Got it? This is how you can remember it and not get confused. So what is the second image? This is an image which is showing this collection of blood or ecchymosis behind the ear in the post-auricular area. What is this called as? This is called as the battle sign. When do you get battle sign? You're going to get it whenever there is a skull base fracture, especially in the area of the middle cranial fossa, because of the blood getting extravasated and getting collected in this area, forming an ecchymosis. Now, there are certain fractures of the face which are called as lay-foot fractures. We'll look into what are these fractures, okay? Like that of nasal fractures, we also have 3 classes of fractures here, lay-foot 1, 2 and 3. Coming to the lay-foot 1, here the fracture line runs parallel to the palate. That is, the fracture line is going to run in the floor of the nose and the maxillary sinus. Okay, this is a named fracture. We have so many conditions starting from G, Radinigo. So this is also starting with G, called as Guerin type of facial fracture or Guerin type of lay-foot fracture. Which type of lay-foot? Lay-foot type 1. Okay, so when you do X-ray or CT, you're going to characteristically get a floating teeth or a floating palate type of appearance, because the palate is completely got separated from the rest of the face. Now, the lay-foot 2, there is a fracture line which is running through the maxillary sinus, infraorbital margin, lacrimal bone up to the root of the nose. So, this is running in the form of a pyramid. So, this is also called as a pyramidal fracture. Okay, you can see the image here. Lay-foot type 1, it is running through the palate. This is lay-foot type 1. Left-foot type 2, like a pyramid, it is running through the maxillary sinus, infraorbital margin, lacrimal bone up to the root of the nose, giving a fracture in the shape of a pyramid. Okay, this is also called as a hanging maxilla. Left-foot 1 was hanging teeth or palate. This is a hanging maxilla. There is going to be CSF rhinorrhea that is seen in this condition. Why CSF rhinorrhea? Because the damage goes up to the root of the nose. Cribriform gets damaged, because of which there is CSF rhinorrhea. Also remember that the infraorbital nerve gets damaged because the infraorbital margin is damaged, because of which there is going to be anesthesia over the face and over the cheek region. Now, the third type of fracture is called as left-foot type 3 fracture, which is also called as craniofacial disjunction. Craniofacial disjunction means the entire cranium head is separated from the face. This is called as craniofacial disjuncture, and the fracture line runs like this, separating the cranium and the rest of the face. And even in this condition, we can get CSF rhinorrhea because the base of the skull is damaged here. Now, a quick question to you. Tell me the 3 fractures that we studied up till now where CSF rhinorrhea is seen. Number 1, we saw it in nasal fracture. No type of fracture, that is type 3 of the nasal fracture, naso-orbito-ethmoidal fracture. We have also seen in 2 of these left-foot fracture, no? In left-foot 2 and left-foot 3. These are the 3 conditions where you get, what do you get? Rhinorrhea. You're going to get CSF rhinorrhea. Now let's look into certain important structures that are seen in the lateral wall of nose. Firstly, whenever we talk about lateral wall of nose, we need to know about the turbinates that are there. There is one turbinate called as inferior turbinate in the lowermost part of the lateral wall, and this is the largest turbinate and it occupies the entire lower third of the lateral wall of nose. And remember that the inferior turbinate is a separate bone. Okay. Whereas the other 2 turbinates, the middle and the superior turbinate, are nothing but ethmoturbinal. That is, they are the part of ethmoidal bone. Okay. Now, to understand that these turbinates are nothing but bony extensions. So, beneath these there are spaces which are called as meatus. Okay. Now, let us look into these images. So, this is the image of the lateral wall of the nose, and you can see that this turbinate here, which is very big, this is nothing but the inferior turbinate, and as you can see, it is going to occupy how much? The entire lower third of the lateral wall of nose. Above that is the middle turbinate, under which you have the middle meatal structure, and then you have the superior turbinate in the superior most direction, beneath which you have the superior meatus. Okay, and above that posteriorly you also have the sphenoethmoidal recess. So you can also see sphenoidal sinus in this image. This is the sphenoidal sinus, this area. Above that is the stella turcica, and then you can see the pharyngeal tonsil here. Where is the pharyngeal tonsil located? In the lateral part of the oropharynx. Then in the nasopharynx you also have certain structures. For example, you have the torus tuberous. You have the opening of the eustachian tube. This is the opening of the eustachian tube, and behind that there is a bulge which is called as torus tuberous. Okay. Here you can see the soft palate. Then you can also see the horizontal plate of the palatine bone. This is nothing but the palatine bone that you are seeing. And then you can also see some other structures. What are the other structures? You have the frontal sinus. This area is nothing but the frontal sinus. And then you can also see the nasal vestibule. This area is called as the nasal vestibule. Let me mark it with blue color. This area is called as nasal vestibule. What is the vestibule? That is nothing but the skin covered part of the nasal cavity leading to the cavity proper is called as vestibule. So these are the important parts that you have to know in the lateral nasal wall. Now, there is one more image. So this image is showing you the base of skull. This entire bone here, no? This forms the base of skull. Then you have the choana. What do you understand by the term choana? Choana is nothing but the posterior part of the nasal cavity called as choana. And in this image, you can also see the opening of the eustachian tube. Where is the opening of eustachian tube? Here. This is the opening of eustachian tube. And then you have the fossa of Rosenmuller just behind it. And there is also retropharyngeal space that is seen. This area comprises the retropharyngeal space. Now, what is this? Nasal septum. Okay. Now, coming to the different meatuses. So, I told you the space enclosed beneath the turbinates are nothing but meatuses. So there are three meatuses: inferior, middle and superior. Inferior meatus is the largest meatus because it is beneath the largest turbinate, the inferior turbinate. No? So what is the opening that opens here? It is nothing but the nasolacrimal duct. Where does it open? It opens at the junction of the anterior 1/3 and posterior 2/3 at the highest point. At the highest point of this junction is the opening of the nasolacrimal duct, and it is bounded by wall of Haisner. And what is the direction or orientation of this? It is given by the formula called as double. That is, the duct is going to run downwards, backwards, laterally. So it is going to run downwards, backwards, laterally. Repeat after me: down, back, laterally. And this is also the direction in which you massage in case the child has a block. And whenever there is block in the nasolacrimal duct, what happens is going to be excessive epiphora, excessive tearing in the eye, and when you have to correct it, you are going to massage the lacrimal sac and duct in the same direction. Even post endonasal diaphragmectomy surgery, you are going to do the same type of massage so that the flow becomes efficient. Now coming to the second meatuses, we look into the middle meatus. This meatus is the most congested meatus. Why is it the most congested meatus? Because mostly all the anterior sinuses open here. Because of the rich opening of all the sinuses, this meatus is congested. And this is the most common meatus that we approach during FES. Now, name the anterior group of sinuses for me. Maxillary. Yes, right. Then we have one of the ethmoidal, anterior ethmoidal, and we have frontal. So all these three sinuses are going to drain into the osteomeatal complex. So this osteomeatal complex is located where? It is located in the middle meatus. Okay, now we have seen the inferior and middle. We'll go into the superior meatus. So superior meatus has only one sinus that drains there, which is nothing but the posterior ethmoids. Okay, we saw about all the anterior group of sinuses. We saw about the posterior ethmoid, which is the only sinus remaining, nothing but sphenoid sinus. So this sphenoid sinus drains into the sphenoethmoidal recess. Okay. Now, there is a point that you have to note here, that is, the middle turbinate more than the inferior turbinate is most commonly involved structure in compression of the anterior ethmoidal nerve, leading to what condition? Sluder's neuralgia. What do you understand here? You have to understand that whenever there is a deviated nasal septum, okay, if this is the nose and this is the septum, deviated nasal septum with a spur. So this bony bend that you can see in the septum is nothing but a spur, the sharp projection. If it goes and impinges on the middle turbinate, okay, if it impinges on the middle turbinate, it is going to irritate a particular nerve. Which nerve? Anterior ethmoidal nerve, because of which the patient has headache, which is called as Sluder's neuralgia. What you have to remember here is it is not the spur impinging on the middle turbinate, but whereas the central turbinate, middle turbinate, which is affected. Okay. Now you would have heard about the term called as hypertrophied turbinates. No? What do you understand by the word hypertrophied turbinates? Is it the bone that has become hypertrophied and big? No, it's not the bone. It is the mucosal lining over the turbinate which has become thickened and it undergoes hypertrophy to such an extent in some people that it completely obstructs the nasal cavity. Now we'll look into one more topic which is examiner's favorite. It is nothing but angiofibroma, or in other words, juvenile nasopharyngeal angiofibroma. Okay, so whenever you get a patient with angiofibroma, how are they going to come to you? Or how is the examiner going to give you a question in these terms? He's going to mention that there is a male who is around 17 years old who comes to your OPD with complaints of one-sided nose block, recurrent epistaxis attacks, and when you do an otoscopic examination, you find that in one of the ear, for example, left ear, there is serous otitis media that is seen. And when you carefully observe the face of the patient, you can see that the nasal widening is there and there is proptosis. What is the diagnosis that has to click to your brain? It is nothing but JNA, or juvenile nasopharyngeal angiofibroma. Okay. So what is this? This is nothing but a vascular malformation which arises or which occurs because of an incomplete regression of the first pharyngeal artery. Okay. Plus, androgenic stimulation plays a major role, And this androgenic stimulation, how do you know that it plays a major role? Because this condition is seen only in men. And it originates from the spinopalatine foramen. Where is the spinopalatine foramen located? It is located 1 centimeter behind the middle turbinate. Now, this is one of the most common benign but locally invasive tumor of the nasopharynx. And as I told you, it is seen in young pubertal male, young juveniles. Juvenile, who is a juvenile? Less than 18 years. That 10 to 18 can be taken as a count. And they present to you with recurrent epistaxis. And I told you, the nasal bridge is broadened. There is proptosis. This is nothing but a characteristic frog facies appearance. If you see this image, you can see widening of the nasal dorsum, and also there is proptosis. So these two features constitute the, what does it constitute? The frog facies. And do you do biopsy here to confirm the diagnosis? Absolutely no. Biopsy is contraindicated because there is lot of bleeding that happens in this patient if you do biopsy. The bleeding can be torrential that you might even want to stop the surgery and take the patient to ICU. Okay, therefore biopsy is contraindicated. Staging is done by something called as Radkowski staging. And what is the investigation of choice? You do CCT. And CCT, you see a characteristic sign which is called as Homer-Miller sign. This Homer-Miller sign is also called as antral sign. So, what do you see in antral sign? If you see this image here, this is the maxillary sinus, the one that I am marking in orange color. So, this is the anterior wall of the maxillary sinus and this is the posterior wall of the maxillary sinus. In the left side, you can see that the base or the posterior wall is completely pushed anteriorly. You can see this, the pushing of the posterior wall of the maxillary sinus anteriorly. This is a common clinical feature that you can see in a contrast enhanced CT, and the sign is called as antral or a Homer-Miller sign. So, how do you treat this patient? Obviously, you're going to excise the tumor surgically. But remember, you can't directly do a surgery. You have to always do a pre-op embolization of the maxillary artery to control bleeding. Only after that, you can take the patient and do surgery and completely excise the nasopharyngeal angiofibroma. So, there are some cases when it is unresectable, okay. So, whenever it is stage 4B, it is unresectable. In such case, you can try giving radiotherapy. So, what do you give in radiotherapy? You can give flutamide. Now, coming to the staging of the cancer of the angiofibroma, we have 3 stages, stage 1, 2 and 3. So, in Radkowski staging, in stage 1, we are talking about the medial spread. Where can the tumor spread medially? It can spread either to the nose or the sinuses. So, stage 1 medial spread, 1A becomes the spread to the nose and 1B it is going to spread to the sinuses. Now, stage 2 stands for the lateral spread. When it goes laterally, what happens? Stage 2A, it is going to minimally spread into the spinopalatine fossa. Stage 2B, it is going to completely fill the spinopalatine fossa, plus it is also going to extend into the orbit. So, it is this stage from where the frog facies develop. What is frog facies? Proptosis and broadening of the dorsum of the nose. 2C, when the tumor spreads laterally into the infratemporal fossa. Okay. Now, we have the stage 3, which is nothing but intracranial extension. 3A stands for limited intracranial extension and 3B stands for extensive intracranial extension. When the intracranial extension is extensive, we cannot resect the tumor. It becomes unresectable. And when it is unresectable, what do we do? Surgery? No, we do not do surgery. We give the patient radiotherapy. And what is the agent that you give? You give flutamide. Now, we studied about angiofibroma. Let's see one of the other cancer. It is nothing but nasopharyngeal carcinoma. So, this nasopharyngeal carcinoma is also called as Guangdong cancer because this cancer is commonly seen in Guangdong region. So, what is the most common cause? That is what I going to say here. What is the type of cancer? This is nothing but squamous cell carcinoma that we are looking at. So, what is the origin of this cancer? It is nothing but fossa of Rosenmuller. Okay. Now, what is the clinical feature? An elderly patient comes to you with painless cervical lymphadenopathy. Patient also complains of nose block. Patient also has serous otitis media. And when you look at the voice of the patient, they have something called as rhinolalia clausa because of the tumor obstructing the nasopharynx. So, when you see a patient with all these features, Which cervical lymphadenopathy am I talking about? I'm talking about upper deep cervical lymphadenopathy, or you can specifically say level 5 lymph nodes are going to be enlarged and it is going to be painless. So when you have all these features, then we are looking at a picture of nasopharyngeal carcinoma. So what is the etiology? The etiology is Epstein-Barr virus. Epstein-Barr virus CD21, this is the marker. Also the viral capsid antigen and the early antigen levels are also going to be increased in cases of nasopharyngeal carcinoma. There is a classic triad that you have to know in this condition. It is called as Trotter's triad. So what do you understand by Trotter's triad? That is, whenever the tumor is growing superiorly, it goes and occupies the sinus of Morgagni. So whenever it occupies the sinus of Morgagni, where is sinus of Morgagni located? Between the skull base and the superior constrictor muscle. Okay, so there are 5 important structures here. You have the tensor palatini, you have the levator palatini, you have the ascending pharyngeal artery, you have the ascending palatine artery, and even the eustachian tube. So whenever all these structures are compressed, affected, there is going to be development of a triad which is called as Trotter's triad. So we have 3 major features in the Trotter's triad. They are nothing but palatal palsy. There is going to be palsy in the palate, palatal palsy. You also have mandibular neuralgia, and you also have conductive hearing loss. So if a question says about conductive hearing loss, mandibular neuralgia and palatal palsy, you have to think of Trotter's triad seen in nasopharyngeal carcinoma. Now, how are you going to treat this condition? If the patient comes to you early on, then you have to give early stage radiotherapy to the patient. But if the presentation is in later stages, then you have to give radiotherapy plus chemotherapy. Now we'll look into the image of the nasopharyngeal carcinoma. So in this image, we're looking at the right nostril. So this is the image of a right nostril, and as you can see that here you are seeing the septum, and in the other side you can see an opening here. Now what is this opening? This opening is nothing but right eustachian tube opening. So behind the eustachian tube opening you have a elevation which is called as tubus tubaris, and behind that you have what structure? Fossa of Rosenmuller. And this fossa of Rosenmuller is an area from which you get the origin of the nasopharyngeal carcinoma. So this is the carcinoma that is coming out from the fossa of Rosenmuller, and it occupies the vault of nasopharynx. Okay, and this is nothing but the floor of the right nasal cavity. How are you going to identify that this is nasopharyngeal carcinoma? By looking at the eustachian tube that is given. So eustachian tube is seen in nasopharynx. Behind that you have an elevation, torus tubaris, and behind that is the structure of fossa of Rosenmuller. So if a cancer is arising from there, it means that it is a nasopharyngeal carcinoma. So now we've studied about ear and nose. Now we'll go forward and study about pharynx. Firstly, you have to know that pharynx is grossly divided into 3 parts. Which are the 3 parts? Nasopharynx, oropharynx, and hypopharynx or laryngopharynx. Now, when we talk about nasopharynx, you have to understand that the pharyngeal part behind the nasal cavity is nothing but nasopharynx. From where is the extension starting from? It starts from the skull base and it goes up to the hard palate. Okay. Now, coming to the part of pharynx that is there behind the oral cavity, it is nothing but oropharynx. So, oropharynx extends between the hard palate and the hyoid bone. Now, laryngopharynx is behind the larynx and it extends from the hyoid bone up to the lower portion of the cricoid cartilage. Okay, this is what you have to know. Extension is very important. Now, coming to the nasopharynx and oropharynx, it is covered by which type of mucosa? It is covered by pseudostratified ciliated columnar mucosa. Whereas coming to laryngopharynx, it is surrounded by which mucosa? It is surrounded by stratified non-keratinized type of squamous epithelium. Okay. Now coming to the nerve supply of the pharynx, firstly we have nasopharynx. So nasopharynx is supplied by the maxillary division, V2 division of the trigeminal nerve, and the lymphatic drainage is into the level 2 lymph nodes. Which is a level 2 lymph nodes? Upper jugular. Okay. Now we have oropharynx which is supplied by the 9th nerve and the 10th nerve, and the lymphatic supply, the drainage is into the 2nd, 3rd and 4th group of lymph nodes, which are the upper, middle and lower jugular nodes. Next, we have the laryngopharynx, which is supplied by the internal and the external branch of the superior laryngeal nerve and also by the recurrent laryngeal nerve. Lymphatic supply again by the level 2, 3 and 4 nodes. Now, there is a structure called as pessavins ridge. You have to know the formation of pessavins ridge. It is formed by the superior constrictor muscles and the palatopharyngeal muscles. So, what is the use of a pessavins ridge? Pessavins ridge, no? It is in the form of a ridge like this. So, what happens whenever you try to swallow, the food has to go from the oral cavity to oropharynx and the esophagus. It should not go to the nasopharynx or the nasal cavity, right? So, this pessavins ridge is going to cover that opening of the nasopharynx, formed by superior constrictor and palatopharyngeal muscle. Major component is from the superior constrictor. Now, coming to one more term that you have to know, the term is nothing but rhinolalia clausa. Rhinolalia clausa means that there is a nasopharyngeal obstruction, because of which if there is any obstruction, it is going to close the opening. So, clausa, rhinolalia clausa. There is also something called as rhinolalia aperta. That is nothing but there is an opening, okay, that is seen in conditions where there is condition like cleft palate. Now, coming to hot potato voice. Hot potato voice. Would you understand the hot potato voice? So, whenever you put any hot stuff into your mouth, like for example, hot french fry or something, whenever you try to talk, the voice that comes, the breathy, husky voice that comes, that is nothing but the hot potato voice. It is seen in any condition affecting the oropharynx. Can you name any condition where it is affecting oropharynx? Conditions like quinsy, peritonsillar abscess and the parapharyngeal abscess. Now, if there is any mass or infection in the eustachian tube, it could either cause acute otitis media or it could cause serous otitis media in children and adults. Mostly all these diseases are seen mostly in the children. Now, coming to the lateral pharyngeal wall, you have to know the structures that are there in the tonsil pit. So, looking at this picture, the number one relationship, this is the number one structure that we are talking about. This is nothing but the capsule of the tonsil itself, and the capsule is formed by the pharyngobasilar fascia. Now, coming to the second structure, this is nothing but the loose areolar tissue beneath the tonsil, which contains a vein, which is a vein, paratonsillar vein. Next, you have the superior constrictor muscle behind the tonsil. You have the styloglossus muscle. You also have the glossopharyngeal nerve. You have the facial artery. You have the medial pterygoid muscle, angle of mandible. Submandibular salivary gland is also there. Pharyngobasilar fascia, as I told you, pharyngobasilar fascia is the one which is forming the capsule of tonsil, and you also have buccopharyngeal fascia. So, you have to know the structures comprising the tonsil bed, because you can get a question in the exam stating that which of the following does not constitute the base of the or the floor of the tonsil. That you need to know what structures do not form the tonsillar floor or the tonsillar bed. Let us look at this ring structure here. What is this ring? You can easily tell, right? You are familiar with this, I assume. This is nothing but Waldeyer's ring. Now, you know what are the components of Waldeyer's ring? You have adenoids, you have tubal tonsil, you have palatine tonsil, and you also have lingual tonsil. Out of all these, adenoid is a unilateral or a single mass, whereas others are all 2 in number found on each side. Now, along with these structures, there are also some small constituents which are nothing but the lateral pharyngeal band that you can see here. This band-like thing, this is the lateral pharyngeal band, and also you have few nodules which are seen in the posterior pharyngeal wall. These nodules also constitute a structure of the Waldeyer's ring. Now, these adenoids, you have to know that they are non-capsulated in nature. The other name of adenoid is nothing but Luschka's tonsil. And what is the other name of tubal tonsil? It is also called as Gerlach's tonsil. Now, you have to remember one thing here, that is, now your examiner knows that all of you know about this Waldeyer's ring. But this Waldeyer's ring that we are talking about is nothing but the internal component of the Waldeyer's ring. Okay. So, we also have another ring around this, which is nothing but the external Waldeyer's ring. So, this external Waldeyer's ring structures are also very important, and you have to know about these. So, it has a structure here behind adenoids, which is called as retropharyngeal nodes. Then, you also have near the lingual tonsils, what is this? Submental nodes. Then, you also have submandibular nodes. And in the lateral side, you also have the JD or the jugulodigastric nodes, and just in anterior to the jugulodigastric nodes, you also have the jugular chain of lymph nodes. So, this is an extra H that you have to know for your NEET exam. Now we'll be looking into the muscles of pharynx. First of all, you have to understand what is the role of the muscles that are there in the pharynx. They push the food to the esophagus. So there is a different phases, no? Whenever you try to swallow, you have the oral phase, you have the pharyngeal phase and esophageal phase. So in the pharyngeal phase, these muscles act in order to push the food into the esophagus. They propel the food in the esophagus. And you have to know that there are two types of muscles. You have the longitudinal muscles and also the circular muscles. Remember, the longitudinal muscles act as dilators of the pharynx. Okay. So you have three longitudinal muscles, stylopharyngeus. Coming from the styloid to the thyroid, you have to know that all the three muscles, longitudinal muscles, attach finally to the thyroid. Okay. So stylopharyngeus, styloid to thyroid, salpingopharyngeus, eustachian tube into the thyroid, palatopharyngeus, palate to the thyroid. Okay. All these muscles have two functions. They dilate the pharynx and also they elevate the pharynx. Okay. Next, we have another group of muscles called as circular muscles. These are called as constrictors. How are you going to remember this? C for C. So, circular muscles are the constrictors of the pharynx. So, there are three constrictors: superior constrictor, middle constrictor and inferior constrictor. Remember that these muscles constrict the pharynx at various levels, at the nasopharynx, at the oropharynx and at the tonsillar bed. Okay. Which of these constrictors is there in tonsillar bed? We discussed about the structures, no? Which one? It is the superior constrictor that is there at the tonsillar bed. Now, when we talk about superior constrictor, there are three things that you have to always remember, okay? 1. It forms the bed of the tonsil. 2. It forms the pessavance ridge. So, superior constrictor is a major portion forming pessavance ridge along with palatopharyngeus. Number 3. It is one of the extent through which the sinus of Morgagni structures go. So, sinus of Morgagni is present between the skull base and the superior constrictor. And in sinus of Morgagni, we have the tensor palatini, levator palatini, ascending pharyngeal artery, ascending palatine artery, and even the eustachian tube. Can you name of any condition where the tumor can spread to the sinus of Morgagni? What is that? We saw it in nose. Nasopharyngeal carcinoma. And when there is nasopharyngeal carcinoma, we get a triad called as Trotter's triad. And Trotter's triad, the structures in the sinus of Morgagni are affected. Now, can you tell me what are the components of Trotter's triad? There are three components: palatal palsy, conductive hearing loss, and what is the third one? It is for you. It is homework, okay? You are going to go back and see the third component, which is there in the Trotter's triad. Coming to the pharyngobasilar fascia is nothing but the anterior fascia, and this pharyngobasilar fascia also forms the capsule of the tonsil. That is, it is thickened at the palatine tonsil, forming the capsule of the tonsil. You also have buccopharyngeal fascia, which forms the posterior fascia. How are you going to remember it? B for back, that is seen posteriorly, and this is seen outside the circular muscles. So, what are the three things that I told you about superior constrictor? Forms the base of the tonsil, pessavance ridge. It is one of the extent through which the sinus of Morgagni comes, the lower limit, which is the other limit of it, the upper limit, skull base. Okay. Now, when you talk about the muscle inferior constrictor, also you need to know about something. So, basically, this inferior constrictor muscle has two types of fibers. They are nothing but thyropharyngeus and cricopharyngeus. How are you going to remember? TP and CP. So, this TP and CP are going to form a dehiscence called as Killian's dehiscence. This is the TP and this is the CP. So, this dehiscence is called as Killian's dehiscence. And what is the importance of Killian's dehiscence? It is a potential space to which a diverticulum could arise. What is a diverticulum called as? Zenker's diverticulum. Is it a true diverticulum? No, it is a false diverticulum. A pulsion type of diverticulum comes out through which dehiscence? Killian's dehiscence. Formed by what muscle? Thyropharyngeus, cricopharyngeus, of which inferior constrictor. Inferior constrictor, is it a constrictor or dilator of pharynx? It is a constrictor. So, it is a longitudinal muscle or it is a circular muscle. It is a circular muscle. This way, you have to always retrospectively revise so that concepts stay in your mind for longer. Okay. Look at the image here. What can you see in this image? You can see a child. No? How is the appearance of the child? Child has open mouth. How is the child looking? Is it looking very happy? No, it's not looking very happy. Dull looking child, and it also has an elongated facies. So, if you look at all these features, what can you think of? You can think of a condition called as adenoid facies. So where is adenoid facies seen? Adenoid facies is seen whenever there is hypertrophy of adenoid, which is characterized by a child who has a nasal obstruction, child also has open mouth, child is dull looking and also has elongated facies. So these are the main features of a child with adenoid facies. Apart from this, there are also certain added features, like for example, crowding of the teeth, the malocclusion of the teeth, the palate is going to be high arched. There is also pinched in appearance of the nose, upturned upper lip and all these, okay. Why is there a pinched in appearance of the nose? Because of the disuse atrophy of the alar nasi muscle. Because the child is trying to breathe only through the mouth, no? So the nasal muscles are not at all functioning. There is disuse of these muscles, because of which there is pinched in appearance of the nose. So now we studied about adenoid hypertrophy and how it affects children. No, there is also one more condition that is commonly seen in children. They come to you with recurrent episodes of sore throat. What is it? It is nothing but acute tonsillitis. So which is the most common cause of acute tonsillitis? It is nothing but group A streptococci. So group A streptococci is the most common bacteria that causes acute tonsillitis. So you can see here, no, the tonsil of the child is severely congested. It is red in color and it is also enlarged. This is how a picture of acute tonsillitis looks like, and there are various types. Membranous is there, and you have tonsillitis with follicles, and so many more type of tonsillitis are there. Tonsillitis with membrane over the tonsil and many more, okay. Parenchymatous. Now coming to the clinical features, there is going to be severe throat pain in the child, and because the tonsils are grossly congested, the child can also have fever, and also the child complains of ear pain. Why does the child have ear pain? Problem is in the throat, no? It is because of referred otalgia. Which nerve is affected? The tympanic branch of glossopharyngeal nerve is affected. What is the name of the glossopharyngeal nerve that goes to the ear? It is nothing but Jacobson's. So the Jacobson's nerve is affected. On examination, you see enlarged or the big tonsils which are congested. There could be purulent exudates on the surface of the tonsil, and sometimes a pseudo membrane could also be there over the tonsil, making it a membranous tonsillitis. And the lymph nodes, the jugulo-digastric lymph nodes, when you try to palpate them, it is going to be tender on touch. Now, what is the treatment? Initially, we are going to treat it with antibiotics because mostly tonsillitis is bacterial in nature. If the child is getting recurrent attacks of tonsillitis, you go for surgery. What is the surgery you do? You do tonsillectomy. Do you do tonsillectomy when there is infection? No, you wait for the infection to settle and then you usually do tonsillectomy. So, one of the most common complications of tonsillectomy surgery is nothing but hemorrhage. There are three types of hemorrhage: primary, secondary and reactionary. Coming to primary hemorrhage, that happens during the time of surgery. And because you're already there in the OT or operating, you can do so many things. You can put pressure and try to control the bleeding. You can ligate the vessel from where bleeding is happening, or you can even use cautery, the electrocautery, in order to cauterize the base of the bleeding vessel. Now, there is also another type of hemorrhage which is called as reactionary. That is, it happens after surgery within 24 hours, or it happens on the first day in the post-op period. And now what do? You go to the OT again, you ligate the vessel, or you do electrocauterization of the bleeding vessels under general anesthesia. So, you're going to take the child to the OT and you're going to do the measures. Now, there is also one more type of hemorrhage which is called as secondary. This happens after 1 day. That is, it happens after 24 hours and anywhere between 1 day to 10 days. This is a time frame in between when you can have secondary hemorrhage, and most common days when it occurs are the 5th to 6th days. Why do you have it? It is because of the infections that could occur. Okay. Now, we should also know about certain conditions which cause membrane over the tonsil. There are many examples, and the classic mnemonic is nothing but all vitamin D. Okay. So, if you try to remember with this mnemonic, you're not going to miss out anything. So, here also a question can come in your exam where the examiner says, in all these conditions, there's going to be membrane seen over the tonsil except one, which is that. And you can answer it only when you know all the conditions. A for, it is A, granulocytosis. L for leukemia. V for Vincent's angina. Dirty gingivitis is seen. I for infective mononucleosis. T for trauma. A for aphthous ulcer, the oral ulcers. M for moniliasis. Moniliasis means candidiasis. And also you have I, any other infections. What are the other infections? For example, membranous tonsillitis, and you also have neoplasia. Now coming to the last D, it stands for diphtheria. So these are all the conditions which cause membrane over tonsil. The important ones among these being scarlet fever, infectious mononucleosis, diphtheria, Vincent's angina, which is also called as trench mouth, oral thrush, moniliasis or candidiasis. Now let us look into certain head and neck spaces. Okay, so firstly we are discussing about something called as a prevertebral space. You have to remember that this prevertebral space continues along the entire length of the spinal cord up to the level of the coccyx. Okay, and then there's something called as danger space. Danger space is bounded by the alar fascia and the prevertebral fascia, and it extends up to the level of the diaphragm. Why is it called as danger space? Because at the level of diaphragm, we also have mediastinum, no? So any infection or any abscess in the danger space can go directly and affect the cardiac structures, the mediastinal structures. Hence, it is called as the danger space. We also have the retropharyngeal space, which is also called as space of Gillette. Okay, so anteriorly it is bounded by the buccopharyngeal fascia, and then you have the alar fascia behind it, and there are certain lymph nodes that are present here, which are called as nodes of Rhuvia. Now let us look into the image here. So in this image, you can see that there is a fascia here, no? This fascia here is nothing but the buccopharyngeal fascia. Behind that, you have the alar fascia. Next, you have the prevertebral fascia, and then you have the vertebra. So, you have to know that between the buccopharyngeal fascia and the alar fascia, this area comprises of the retropharyngeal space. Behind the alar fascia and the prevertebral fascia, you have the second space, which is nothing but the danger space. And between the prevertebral fascia and the vertebra, you have one more space, which is called as a prevertebral space. These are the three things that you have to know. If we have to look at it in a very simpler image, let us see. So, as I told you, behind the pharyngeal constrictor muscles, you have a fascia here. This fascia is nothing but the buccopharyngeal fascia. Okay. And then you have the alar fascia. And then you have the prevertebral fascia. And then you have the vertebral body. Okay. Now, the space which is bounded by the buccopharyngeal fascia and the alar fascia, this region, this space is nothing but the retropharyngeal space. Okay. This is nothing but the retropharyngeal space. And then the area which is bounded by the alar fascia and the prevertebral fascia, this is nothing but the danger space that we are talking about, because infections from this space can directly go into the mediastinum. So, what is this fascia that we are talking about? This is nothing but the danger space. Now, the space that is bounded between the prevertebral fascia and the vertebral body behind is nothing but the prevertebral space, and this in pink is showing you the prevertebral space. So, where is it bounded in between prevertebral space and vertebra? Hence, it is also called as prevertebral space. Okay. You have to remember one thing, that in the retropharyngeal space, we have a midline fibrous raphe. So, this is a midline fibrous raphe in the retropharyngeal space, because of which, if at all there is any infection in this area, there is going to be only paramedian bulge. Either the right side or the left side is going to bulge out. Whereas, if you have a prevertebral abscess, because there is no midline structure separating it, you are going to get an entire medial bulge. This is one thing that you have to know. And as I told you earlier, that there are going to be lymph nodes in both the compartments of the retropharyngeal space. These are called as lymph nodes of Rhuvia. These are the two things that you have to know. Now we have one more image here. This is also a similar image. That is, you have pharynx. Pharynx, behind that you have the buccopharyngeal fascia. So, behind the buccopharyngeal fascia, and this is the alar fascia, you have the retropharyngeal space. Between the alar fascia and the prevertebral fascia, you have the alar space. And between the prevertebral fascia and vertebra, you have the prevertebral space. Now, let us look into certain abscesses and cellulitis conditions of the head and neck spaces. The number one thing that we're looking at is nothing but Ludwig's angina. You have to understand that Ludwig's angina is not an abscess but a cellulitis condition. So, how a question can come in your exam? The examiner is going to say that a middle-aged diabetic female walks into your OPD, and when you notice her, you can see that there is going to be a woody hard edema in the submandibular area. And when you look at the dental condition or the oral hygiene, the patient comes with poor oral hygiene. What is the probable diagnosis? The diagnosis can be nothing but Ludwig's angina. So, what is the classic history or the cause of Ludwig's angina or the cellulitis in the submandibular space? It is history of dental infection. They're going to have very bad dental caries that you can see. So, Ludwig's angina basically happens in the which space? It happens in the submandibular space. You should also know that this submandibular space is further divided by the mylohyoid muscle into two compartments. You have the sublingual compartment and also the submaxillary compartment. Okay. Now, what are the clinical features that the patient presents to you with? You can see that there is going to be edema in the submandibular area. That is nothing but swelling and edema in the submandibular area. And it is bilateral. It is not restricted to only one side. You can see that through and through bilateral edema. You can see the picture here, no? You can see this edema in the entire aspect of the submandibular space. So, this is how the patient presents to you with, and whenever you are going to touch this edema, you have to remember that when you touch it, it is going to give you a woody hard feel. Therefore, it is called as a brawny edema. Now, what are the other clinical features? If you ask the patient to open the mouth, you can see that the floor of mouth is raised or elevated, and also the patient has difficulty in opening the jaw. There is trismus. There is severe restriction in opening of mouth. Why is there trismus? Because there is so much collection in the submandibular area. No, the patient can't open mouth effectively. Now, what are the common symptoms that are seen? Now, remember that these common symptoms are called common for a reason. They are going to be seen in each and every condition, each and every abscess of the head and neck space. So, the patient has fever, patient has sore throat, patient has odynophagia. What is the meaning of odynophagia? Painful swallowing. They also have dysphagia, difficulty in swallowing, and also they have pain in the ear. That is nothing but referred otalgia. Why do you think there is referred otalgia here? Because of which division? Glossopharyngeal, Jacobson's nerve. Now, how are you going to treatment? You are going to treat the condition. You are going to give IV antibiotics. You are going to try and wait for about 48 hours. If there is no improvement in 48 hours, you are going to do an incision and drainage, and this is how you are going to treat this condition. Now, the common symptoms, you have to remember everything. I am going to ask these common symptoms in each and every abscess that we study henceforth. Now, coming to the second condition, you can see the image here. No? How does a child look? There is swelling seen in the angle of the jaw. So, the arrow that I am pointing here is showing swelling, and the head is slightly bent to one side. What could be the diagnosis probably be? It is nothing but parapharyngeal abscess. Okay. This parapharyngeal abscess is seen in the parapharyngeal space. Is there any other name for parapharyngeal space? It is also called as pharyngomaxillary space abscess. So, if they give you pharyngomaxillary abscess, do not leave the question thinking that you've never heard about it. Okay. Pharyngomaxillary is another name for parapharyngeal space. Now, what are the clinical features? If you look at the child here, there is swelling that is seen. Where is the swelling seen? It is seen in the angle of the jaw. And this is the external finding. Internally, is there any finding? The tonsil is pushed medially. So, remember, there are two conditions in which this tonsil is pushed medially. So, it is pushed medially in number one, quinsy. What is quinsy? It is nothing but the peritonsillar abscess. And number two, in the parapharyngeal abscess, the tonsil is pushed medially. When tonsil is pushed medially, you can also see that the uvula which is there, it is turned to the opposite side. There is also trismus in this condition because there is a big abscess in this area, no? The mouth opening cannot be done effectively. And remember that trismus is seen only in the pre-styloid variety, whereas in the post-styloid variety, trismus is not seen. Now, what is this pre-styloid and post-styloid? Remember that this parapharyngeal space is divided into two components by the styloid process. So, what are the two components? These are nothing but the pre-styloid cavity and the post-styloid cavity or the space. Now, in the pre-styloid, the major constituent is nothing but fat. And whenever there is abscess, very rare, but whenever there is abscess in the pre-styloid space, there is going to be trismus. In post-styloid, we have cranial nerves 9, 10, 11, 12. We have internal carotid artery, internal jugular vein, and also we have the cervical sympathetic chain. So, whenever there is any lesion in the post-styloid component, you have to know that there is going to be Horner syndrome if the cervical sympathetic chain is involved. So, what are the common symptoms? This time you are going to tell me, okay, what are the common symptoms? Fever, yes. Sore throat, right? You have odynophagia. You can also have dysphagia. And what is another one? Pain in the ear or referred otalgia is going to be seen. How are you going to manage it? Similar to any other abscess, you're going to give IV antibiotics, wait for 48 hours. If there is no improvement, incision and drainage to relieve or release all the pus that is collected. So coming to the next type of abscess, we'll be looking into peritonsillar abscess. This peritonsillar abscess, as the name suggests, abscess around the tonsil, and it is also called as quinsy. So this abscess is located between the superior constrictor muscle and between the capsule of the tonsil. Okay. Now coming to the clinical features, as you can see in this image, the tonsil is pushed medially. You can see that the tonsil is pushed medially, which is another condition where tonsil was pushed medially, parapharyngeal abscess. Okay, there is going to be drooling of saliva because even swallowing of saliva becomes so painful that the patient doesn't swallow saliva. So when the saliva content increases in the mouth, there is going to be dripping or drooling of the saliva from the angle of mouth. There is also something called as hot potato voice. Hot potato voice, how does it sound? It is when you put something hot in your mouth, how you are going to talk, no? The muffled, thick sound that you produce, that is called as hot potato voice. It is seen usually in the diseases of the oropharynx. Even in parapharyngeal abscess, when tonsil is pushed medially, you can get a hot potato voice. But this voice is more characteristic of a peritonsillar abscess or quinsy. The patient also has trismus because opening the mouth becomes very, very painful and difficult. What are the common features? I'm not going to tell you. You are going to tell me this time. Yes. Fever, sore throat. What are the other features? Painful swallowing, odynophagia, difficulty in swallowing, dysphagia, and what is one more? It is nothing but the referred otalgia. From tonsil, which nerve causes referred otalgia? It is there in the oropharynx, so it is the cranial nerve 9. Which branch? Jacobson's nerve. How are you going to treat it? You give IV antibiotics. You can wait for around 48 hours. If it is not improving, you have to do incision and drainage, IND of the abscess. And you can also plan for interval tonsillectomy. What do you understand by interval tonsillectomy? That is, you have to wait for at least 6 weeks after the last episode of infection. After that, you can do a tonsillectomy. Now, coming to the next condition, it is called as prevertebral abscess. So, where is the location of the prevertebral abscess? Behind the prevertebral fascia and in front of the vertebral body. That is where you can find the prevertebral abscess. And this is a X-ray of the neck, okay? Whenever you do a X-ray of the neck or CT of the neck in the sagittal section, the sag view, you cannot differentiate whether it is a prevertebral or a retropharyngeal abscess. Because in both retropharyngeal and prevertebral abscess, the prevertebral shadow is going to be increased. You have to know that the normal prevertebral shadow, how much should it be? Usually, at the level of C2, it is 7 mm in both adults and children. And at the level of C6 vertebra, it is 14 mm in children and it is about 21 mm in adults. So, you have to know that whenever this prevertebral shadow is increased, you mean to say that it is going to be more than these values. Then you say that the prevertebral shadow is increased and it could be either because of a retropharyngeal abscess or it could be because of a prevertebral abscess in the sagittal section. But when you take axial cuts, you can clearly say which of the abscess you're seeing, okay? Now, clinically, in the posterior pharyngeal wall, you're going to see a diffuse bulge. That is, a diffuse midline bulge is noticed in the posterior pharyngeal wall. How are you going to examine the posterior pharyngeal wall? You're going to take a tongue depressor and depress the tongue and look at the posterior pharyngeal wall. If it is a retropharyngeal abscess, you know that you're going to look at the picture of a paramedian bulge. So only one side is bulged. Whereas in case of prevertebral abscess, because there is no midline fibrous raphe here, you're going to see a diffuse medial bulge in the posterior pharyngeal wall. What are the common clinical features? Again, same features. You have fever, you have sore throat, you have odynophagia, you have dysphagia, and also you have otalgia, referred otalgia. Again, here, because of which nerve? Prevertebral space. It could be because of 9th and 10th nerve. Now we'll look into the next abscess. The next abscess that I'm talking about is about retropharyngeal abscess. So retropharyngeal abscess is bounded between which are the two fascias? It is the buccopharyngeal fascia and the alar fascia. So what are the clinical features? So in your exam, your examiner is going to give you a question saying that a 40-year-old male walks into your clinic with severe dysphagia to solids more than liquids. Initially started with mild dysphagia, now he cannot have liquids, water also, and he complains of severe sore throat, he has fever, and then occasionally he even has noisy breathing. Okay, and when you probe the history, the patient says that 2 days back, a week back, he had a fishbone, he was feeling pricking sensation, but then he ignored it. And now this is how he is presenting. What is the diagnosis that you have to think of? The most common cause, the most common abscess will always be a retropharyngeal abscess. And this retropharyngeal abscess can become so severe that can spread to the nearby spaces and it can have big extensions. Okay. So what are the clinical features? Number one, torticollis. So this is one X-ray where you can see torticollis. Why there is torticollis? Torticollis is nothing but stiff neck, okay? It is because of the spasm of the paraspinal muscles. So usually what happens is that the cervical region, when you look at the X-ray, there is a characteristic bend which is seen like this. So, but if you see this X-ray, are you seeing that bend? No. There is straightening of the spine, no? There is straightening because of the spasm of the paraspinal muscles. There can be stridor seen in this patient. Also, when you see the posterior pharyngeal wall of the patient, you can see that there is a paramedian bulge. In which condition did you have a median bulge? You had a median bulge in a prevertebral abscess. Okay. What are the common symptoms? Same as any other abscess of the head and neck region. There is going to be fever. There is going to be sore throat. There is going to be difficulty in swallowing, dysphagia, painful swallowing, odynophagia, and there is going to be referred otalgia. That is nothing but ear pain. Patient can also have trismus. In this condition of a retropharyngeal abscess, the extra things are the torticollis and the stridor that the patient presents to you with. How are you going to treat the patient? Because the patient has stridor, airway management becomes very important. If you cannot manage airway and cannot maintain the SpO2 of the patient, even tracheostomy can be done. IV antibiotics for around 48 hours. If no improvement, incision and drainage is tried in the patient. And this is what you need to know in the case of retropharyngeal abscess. Now, coming to the next abscess, what is the area that we are looking at here? This area, this is nothing but the parotid area, no? So, the abscess in this area is called as parotid abscess. And the most common causative organisms are Staphylococcus, Streptococcus, and even certain anaerobic bacteria. So, what are the clinical features? Same, you have pain, you have fever, you have difficulty in opening mouth, that is trismus. Because there is abscess in this area, the patient has extreme pain when he tries to open the mouth. On examination, how does the abscess look like? Red, tender, and firm on touch. Again, you are going to treat the patient with antibiotics. If no benefit, you are going to do incision and drainage of the abscess. Now, we'll be looking into the triangles in the neck. So, when we talk about triangles in the neck, this is one of the toughest topic for any medico. So, basically, in triangles of neck, everything becomes important. The boundaries are important, floor is important, roof is important, content is also important. So, here in ENT, we are going to study about the boundaries of the triangle and we are going to look at which are the anterior triangles and which are the posterior triangles. In anatomy, you will be learning about all the structures that are there in each and every triangle. So, firstly, when we talk about triangles of neck, we have to know that these triangles are divided into anterior group of triangle and then we also have posterior group of triangle. In anterior group of triangle, it is further divided into 4 triangles. We have the submental triangle, We also have the submandibular triangle. Submandibular triangle. We have the carotid triangle. And then we also have the muscular triangle. Okay. Next, when we talk about the posterior group of triangle, we have two triangles called as the occipital triangle. Occipital triangle and the subclavian triangle. Okay. So, this is the rough division of the different triangles. Now, when we talk about the submental triangle, it is formed by the anterior belly of digastric right and the left digastric and the hyoid bone below. So, let us look at the image here. This image in purple color is showing the submental triangle. So, it is formed between the anterior boundary of both right and the left side of the digastric muscle, and the base is formed by the hyoid bone. The second triangle is submental triangle. So, submental triangle is shown in this picture in pink color. One of the boundary is nothing but mandible, anterior belly of digastric and posterior belly of digastric. So, the triangle between the mandible, anterior and posterior belly of digastric is nothing but the submandibular triangle. Now, which is the third triangle? It is carotid triangle. So, carotid triangle is shown in blue color here. It is formed from the posterior belly of digastric. This is one of the boundary. Anterior border of sternocleidomastoid, and the third boundary is the superior belly of omohyoid. So, can you tell me the boundaries now? Posterior belly of digastric, superior belly of omohyoid and the sternocleidomastoid muscle. Okay. Now, the fourth triangle in the anterior triangle is nothing but muscular triangle, and as the name suggests, it is muscular. Okay. So, one of the boundary is the midline of the neck, and the other boundary is nothing but the superior belly of omohyoid, and the third boundary is the sternocleidomastoid, the anterior border of the sternocleidomastoid. So, what are the names of the anterior triangle? Submental, submandibular, carotid and the muscular triangle. Now, coming to the posterior group of triangle, it is broadly divided, as I told you, into the occipital triangle and the subclavian triangle. So, if you look at the occipital triangle here, this green color triangle is the occipital triangle. You can see that the anterior boundary is the posterior border of the sternocleidomastoid, and the posterior boundary is the anterior border of the trapezius muscle, and the base is formed by the inferior belly of the omohyoid. So, this is the occipital triangle. So, in posterior triangle, we also have one more triangle called as the subclavian triangle, which is also called as the supraclavicular triangle. So, this is depicted in orange color, superiorly bounded by the inferior belly of omohyoid, anteriorly by the posterior border of sternocleidomastoid, and inferiorly by the clavicle. So, the small triangle here is called as the supraclavicular triangle or the subclavian triangle. Now, tell me the names of the posterior triangle, occipital and the subclavian triangle. Now, we have covered ear, nose and pharynx. Let's go forward in our discussion and study about larynx. When you study about larynx, you need to know that there are 3 paired cartilages and 3 unpaired cartilages. Firstly, let us look into the unpaired cartilages. What are the unpaired cartilages in larynx? They are nothing but epiglottis, you have the thyroid and you have the cricoid cartilage. Okay. So, you can get a question in your exam where your examiner gives you 4 options and asks you the question which among these 4 is not an elastic cartilage, and your options are epiglottis, corniculate, cuneiform and thyroid. What is your answer going to be? Let's look at the discussion and try answering this question. So, you have to understand that elastic cartilage, epiglottis is nothing but an elastic cartilage. We also have 2 more small cartilages which are elastic, which are nothing but corniculate and cuneiform. This is something that you have to know. And these are the only 3 cartilages that are elastic in nature, whereas all the other cartilages, which is the other cartilage, thyroid, cricoid and arytenoids, are hyaline in nature. So, we have seen what are the elastic cartilages, right? Epiglottis, corniculate and cuneiform. There is a simple way to remember this. Whenever you write the word elastic, the first word is E, right? This is how you write E. This is how you write C. Remember that E for epiglottis, that is elastic in nature. This also looks like C. So, small c, no? This is not capital C. I am talking about small c, right? So, the small cartilages of the larynx, cuneiform and corniculate are also elastic in nature. This is how you can remember this. Now, coming to the question that I asked you, What is the answer for that question? The answer is going to be thyroid, because all the other 3 cartilages are derived from elastic cartilage. Okay. Now coming to thyroid cartilage, you can see this butterfly shaped cartilage that you can see here is nothing but the thyroid cartilage. In the anterior aspect, it has a prominence which is called as the laryngeal prominence. It is formed by the 2 ala of the thyroid, and in men it is going to be around 90-degree angulation, and therefore it is also called as Adam's apple. In female, it is not that prominent and the angulation is around 120 degree. Okay. Now coming to the third unpaired cartilage, it is cricoid cartilage. Cricoid cartilage is a ring-shaped cartilage. It is a complete cartilage. It has a lamina and an arch. Okay. So this cricoid cartilage has a signet ring shape, and because it is a complete cartilage, it is a cartilage which can undergo stenosis at times. Okay. Now coming to the lateral view, this is the right lateral view. In the right lateral view, you can also see all the paired cartilage. You have the arytenoid cartilage. So the arytenoid cartilage is the one which is pyramidal in shape. And in the apex of the arytenoid, you have corniculate cartilage, and then you also have above the cuneiform cartilage. Remember, the other name for corniculate cartilage is Santorini, sand, corniculate cartilage, and you have cuneiform cartilage, which is also called as cartilage of Risbung. Have you heard the name Risbung anywhere? The sensory part of facial nerve is called as nerve of Risbung. Okay. Now, apart from this, you should see certain membranes that are there. So we have a membrane which connects the thyroid and the hyoid. No? This is the hyoid bone and the thyroid. This is called as thyrohyoid membrane. Okay. And then you also have a ligament which connects the cricoid and the thyroid. This is thyroid, this is cricoid. So the ligament connecting both is called as cricothyroid ligament. You have a ligament in between the cricoid and the tracheal rings, which is nothing but the cricotracheal ligament. In the lateral view, there are structures that you have to know. So coming to those structures, first of all, in the tip you have epiglottis, no? So the fold between the epiglottis and arytenoid is called as epiglottic fold, and the lower border of which condenses to form something called as a vestibular fold. Okay, so this is the vestibular fold, and down you also have a conus elasticus, the upper portion of which condenses and forms the vocal fold or the true vocal fold. This is what you have to know in these images. Now we have seen the anatomy of larynx. Now we will go further and see certain infectious conditions of larynx. Now you get a question in your exam saying that a 3-year-old toxic looking child comes to your OPD and the mother says that the child is not eating anything, it has noisy breathing, drooling of saliva, and then when you look at the child, it is very toxic looking in nature, and also you can notice that the child is always leaning forward. Okay, so when you see such a history, what is the diagnosis that has to come to your brain? That is nothing but the topic that we are going to see now. It is nothing but acute epiglottitis. Always remember there are 2 confusing topics here. One is acute epiglottitis, one is croup. Remember that acute epiglottitis is a condition which is more severe and the child is toxic looking. What is the etiology? Streptococcus is the most common organism which can cause acute epiglottitis. How is the child going to look? The child is having acute onset of fever. There is stridor. What type of stridor? The child has inspiratory stridor. It has odynophagia, that is painful swallowing, and it is so painful that the child cannot swallow the saliva also. So the saliva is dripping or drooling from the mouth. You can see saliva drooling. The child has normal cry and it always prefers a tripod position or a leaning forward position. So if you look at the child, it is always bending like this and it is taking support of its knees. This is a tripod position because whenever it takes such a position, its respiration gets improved and the child feels little relieved. Okay. And the history clencher in this, the answer clencher in this type of question is 1, the toxic looking child, and 2, inspiratory stridor, and 3, nothing but the tripod position. So if you see these 3 features, only one answer can come to your brain, that is nothing but acute epiglottitis. What is the investigation that you do? You get an X-ray done, X-ray of the neck lateral view. You can see the soft tissue thickening seen in the neck in the form of a thumb sign. So this is the thumb sign. You can see, the yellow color that I'm marking. Because of the soft tissue edema over the epiglottis, it is going to look like a thumb of the person. This is very characteristic. This is called as the thumb sign. On laryngoscopy, when you do to visualize the larynx, you can see that the larynx is severely congested. It is going to look like a cherry red color. So, cherry red epiglottitis is going to be seen on laryngoscopy. And here the child has stridor, inspiratory stridor. So, you have to secure the airway and intubate the patient and start the child on IV antibiotics. That is, you are going to start the child on third generation cephalosporins. So, this is the antibiotic that you are going to give to the child. Now, if you get a similar question in the exam, but here instead of a severe toxic looking child, let's say that child, walking, talking child, it is crying, it has come to you, it has odynophagia, it has a stridor, noisy breathing, and it also has barking cough. What is the answer that has to come to your brain? It has to be croup. The other name of croup is nothing but acute laryngotrachobronchitis. Here there is infection, acute onset infection in the larynx, in the trachea as well as bronchioles. Okay, and the other name is nothing but croup. Most common pathogen causing croup is nothing but the para-influenza virus 1 and 2. The child has cough here as I told you, and the nature of cough is nothing but barking cough. And also it has sore throat, and here also the child has breathing difficulty. There is stridor. What type of stridor? An inspiratory stridor or a biphasic stridor. What do you understand by biphasic? The stridor is there both during inspiration as well as expiration. Here also you get an X-ray done, but here you do not get a lateral X-ray done, whereas you get an anterior-posterior view, AP view X-ray, and this is a AP view X-ray. And in the yellow color that I am marking, how does this look like? It looks like a steeple of a church, or it looks like a pencil tip. Therefore, the image that you're looking is nothing but a pencil tip sign or a steeple sign, which is seen in AP view because of the congestion that is seen, constriction that is seen because of the edema that is developing in the larynx, trachea and bronchioles. How are you going to manage it? You are going to give steroids to the patient, and when you give steroids, the edema is going to settle in, the edema is going to reduce. And when the edema reduces, there is opening up of the respiratory passage. You can also give nebulization, that is, you give adrenaline nebs, or you can also give epinephrine nebulization. It is going to make the child breathe better, and you can give antibiotics in order to prevent secondary bacterial infections. We finished croup and acute epiglottitis. Let us jump on to the third one. Third is nothing but the viral bronchiolitis. So, if you look at the X-ray here, what view it is? It is nothing but an AP view, which shows that all the bronchoalveolar markings are exaggerated. There is increased bronchovascular markings that are seen with multiple linear opacities at the hilum. At the hilum region, you have multiple linear opacities. This is nothing but a picture of viral bronchiolitis. So, there is going to be V's present in this condition as all the bronchioles are involved. And the most common cause of viral bronchiolitis is nothing but the respiratory syncytial virus, RSV. And how are you going to treat it? You are going to treat it by giving ribavirin. How are you going to remember it? The causative organism, the name starts from R, respiratory syncytial virus. You are going to give a treatment with the name R, ribavirin. In certain conditions, you can give prophylaxis in high-risk conditions by using a component called as pelivizumab. So, pelivizumab is used for treatment of prophylaxis. Pelivizumab is used for prophylaxis of viral bronchiolitis. Now, let's talk about acute dyspnea. What do you understand by acute dyspnea? It means that sudden onset breathlessness. And the most common cause for sudden onset breathlessness is always going to be a foreign body aspiration. So, can you guess any common foreign body that you see on day-to-day basis as a common foreign body aspiration? It is nothing but peanuts, okay, because peanuts is easily accessible to each and every child. It just takes it and tries to eat it, but by mistake it goes into the your trachea or bronchi, causing foreign body aspiration, and the child presents to your emergency with acute breathlessness. So, whenever you do radiograph, you have to remember that for a foreign body, you have to always do radiograph in both inspiration and expiration, and that helps you in the diagnosis. So usually the foreign body entry into the lungs is prevented by a reflex, and the reflex is nothing but the cough reflex. Okay. So whenever a patient, takes in any foreign body and it is getting aspirated, the patient usually tends to cough violently and hence the foreign body is expelled out. But in some people, this cough reflex is going to be sluggish. Like for example, if the patient is under the influence of alcohol, or if there is damage to the internal laryngeal nerve, there is going to be repeated aspiration seen. Now tell me, internal laryngeal nerve is a branch of which nerve? It is a branch of superior laryngeal nerve. Superior laryngeal nerve has two branches, internal and external. So this is an X-ray which is showing us foreign body at the level of tracheal division into the bronchial in the right side. And always remember, the foreign body entry into the right lung is more common because of a relatively straighter course of the right bronchiole. Coming to the next topic, we are going to be talking about ring case edema. Ring case edema is also called as smoker's larynx because ring case edema is most commonly seen in smokers. It can also be associated with certain other diseases like gastroesophageal reflux disease GERD, or it can also be seen in mixed edema. And what happens here? There is going to be edema in the ring case space. What is ring case space? So, if you look at the structure of the vocal cord, there is a vocal muscle. It is formed by which muscle? Vocalis. It is a part of the thyroarytenoid muscle, around which you have the lamina propria. So, this is the lamina propria. And then you have the external, the mucosa. What is the mucosa? It is a non-keratinized stratified squamous mucosa. So, in the lamina propria, the superficial most layer of lamina propria constitutes the ring case space, and whenever there is edema here, it is called as ring case edema. Okay. So, the patient comes to you with hoarseness of the voice. This is going to be the main complaint. And when you do a video laryngoscopy to examine, you can see that both the vocal cords are grossly edematous and the edema extends to the entire length of the vocal cord. And the patient also gives you sometimes history of chronic voice abuse. How are you going to manage the condition? Because it is commonly seen in those people who are addicted to smoking. You ask the patient to stop smoking. You can also send the patient to a speech therapist to teach them about the proper technique of talking, that is nothing but voice therapy. And also in severe cases where this edema cannot be treated, cannot be reduced at all, you can do something called as reduction glottoplasty, where the bulk of the edema or the bulk of the tissue is going to be reduced. Now coming to vocal nodule, what do you understand by vocal nodule? These are nothing but small sessile nodules that are seen in the vocal cord. So if you look at the video laryngoscopy image here, you can see that on bilateral vocal cord, in the junction of the anterior 1/3 and the posterior 2/3, there are small sessile outgrowths that are there, which are nothing but vocal nodule. Remember that this is always seen bilaterally equally and it is a benign condition of the vocal cord. The patient comes to you with hoarseness of voice and there is always a history of voice abuse. And this is most commonly seen in either singers or teachers. Anybody who screams a lot, who are going to abuse their voice, it is seen in them. Hence, the vocal nodule is also called as a singer's nodule or a teacher's nodule. What is the treatment? You can ask the patient to give voice rest. What do you understand by voice rest? You ask them absolutely to stop talking for like a week or two, and in case they have to talk something, you have to tell them that they can talk in a normal pitch and never to talk in a high pitch or low pitch, because whenever they are increasing or decreasing pitch, it produces more strain over the vocal cord. And here also you can send the patient to speech therapy, and within like 2-3 weeks this condition is going to resolve on its own. Okay. Now remember that in the question they will always give you a history clencher. Like for example, they're going to mention that the patient is a singer or the patient is a teacher, and this has to help you diagnose whether it is a vocal nodule or a polyp. So whenever you're going to see a picture of a singer or teacher, then it is always vocal nodule that the examiner is talking about, and it is a bilateral condition. Now coming to the next condition, we are talking about subglottic stenosis. What do you understand by subglottic stenosis? There is nothing but narrowing of the subglottic area, And where is the subglottic area? It is there under the glottis. Okay. So the most common cause is nothing but congenital stenosis. That is, by birth there is going to be stenosis of the subglottic area. And can it have acquired etiology? Yes, it can also be acquired in nature whenever there is going to be intubation trauma in the subglottic area. Now, whenever there is prolonged intubation, this prolonged intubation is going to cause trauma to the subglottic area. That is, increase in the cuff pressure is going to cause necrosis of the subglottic area, and when necrosis tries to heal in, there is stenosis that is developing here. Therefore, it is always advisable that after specific days after intubating a patient, you have to always do a tracheostomy in order to prevent subglottic stenosis. Okay. Drug used to prevent restenosis, that is, whenever there is stenosis, if you try to operate it, if the raw areas come close to each other, they can again come in contact and get stenosed. So, to prevent it, you are using a drug, and the drug is nothing but mitomycin C. And in any area where there is raw surface and you think that there could be synechia formation, you can always apply mitomycin C. Now, there is a staging for this subglottic stenosis. The staging is called as Cotton-Mayer staging. So, there are 4 grades of subglottic stenosis. Grade 1 is when the obstruction is from 0 degree to 50 degree. That is grade 1. When it is from 50 to 70 degree, it becomes grade 2. When it is from 71 to 99, that is, there is just 1% opening left. Okay, that is grade 3. And when there is no detectable opening at all, then it becomes grade 4. So, you are going to do a surgery where you are going to cut the ends, and then you are going to use a keel in between, and therefore you are going to make the opening little larger and patent. And as I told you, to prevent restenosis, you can use mitomycin C. Now, coming to the next condition that we are looking in larynx, it is of laryngomalacia. So, laryngomalacia is a condition when we can see a omega-shaped epiglottis. So, this omega-shaped epiglottis on a VLS is nothing, or a flexible scopy is nothing but a classical sign seen in laryngomalacia because of the excess tissue that is there in the supraglottic area. In the image you can see, there is omega-shaped, very big epiglottis that is seen, and also the array epiglottic fold is shortened and the arytenoids look very prominent. So, these are the features seen in laryngomalacia. There is going to be stridor that is seen in the child, and the stridor usually aggravates whenever the child is in supine position, whenever the child is crying, or whenever the child is feeding. That is when the stridor aggravates, and whenever the child sleeps in prone position, that is, the child sleeps on its chest, the stridor relieves and the child is going to be benefited. Now, what is the treatment? You are going to reassure the patient, because by the time the child reaches 2 years of the age, mostly this laryngomalacia resolves on its own. So, wait and watch is going to be the primary treatment as it disappears by 2 years. But in some cases, when the stridor is so severe, there is growth impairment, and after 2 years also, if the stridor doesn't come down, if the laryngomalacia persists, then you can surgically remove the excess superadded tissue. That is, you do something called as supraglottoplasty. When you do this supraglottoplasty, you are going to remove the redundant extra tissue in the supraglottis. Coming to the another condition, this is nothing but laryngeal papilloma. So, laryngeal papilloma means there are multiple papillas which are seen on the larynx in the glottis region. So, the most common cause is nothing but human papilloma virus, HPV, type 6 and type 11. So, in 6 and 11 is the most virulent form of human papilloma virus, and the child presents with hoarseness of the voice followed by stridor. So, the initial presentation is going to be hoarseness of voice, but as the size of the papilla becomes more, as the papilla grows in size over months, there is going to be stridor seen, and there is always history of vaginal birth. So, whenever there is vaginal birth, if the vagina has human papilloma virus, that is how it can enter the oral cavity and reach the larynx and cause papillomas. So, on examination, you can see multiple papillomas at the level of true vocal cord and the supraglottis. You can see this image, right? So, in this image on the vocal cord, you can see that there are multiple papillomas that are seen. Okay. And How are you going to treat this condition? You can do a microlaryngeal surgery where by using a microdebrider or by using a carbon dioxide laser, you are going to reduce the papillomas from the vocal cord. And after you have reduced these papillomas, in order to reduce recurrence, you can treat the patient with either cidofovir or bevacizumab or systemic interferons. All these are going to reduce the recurrence of the papillomas after they are excised surgically. Now coming to the next condition, we are going to look at laryngeal TB. So laryngeal TB is nothing but tuberculosis of the larynx, and it is always associated with pulmonary TB. So this pulmonary TB acts as a foci and it is going to spread to the larynx, and that is when laryngeal TB occurs. And here there are 2 to 3 named features that you have to know. Remember that most of the diseases of the glottis affects the anterior part, the anterior commissures, the anterior 1/3 and posterior 2/3 junction. But laryngeal TB is a condition which affects the posterior part of the glottis. So if you see the vocal cord image, you're going to see that there is going to be turban epiglottitis that is seen. You can see here, no, the epiglottis is in the form of turban. This is called as turban epiglottitis. And when you see the vocal cords, you can see mouse nibbled appearance, or you can see rat bitten appearance of the vocal cord. Rat bitten or mouse nibbled appearance of the vocal cord. Also, if you look at the arytenoids is going to be mammillated in appearance. So the 3 features that points your diagnosis towards laryngeal TB are turban epiglottitis, mouse nibbled vocal cord, and a mammillated arytenoids. So whenever you do a laryngoscopy, you have to take a biopsy, send it for culture, and you can send it for staining, and then it is going to confirm the diagnosis, after which the treatment is nothing but anti-tubercular therapy. Now let us look into laryngocele. So laryngocele is a condition of larynx where there is ballooning or where there is a dilatation of the saccule. So what is saccule? The part that I am showing now in the image here, no, between the true and the false vocal cord, this is called as saccule, and this saccule is called as the oil can of the larynx because this is going to provide all the lubrication that is needed for the voice box. Okay. Now in certain people, like for example trumpet blowers, because of the high pressure that they use in order to blow the trumpet, there is going to be dilatation or ballooning that happens in the saccule, and if the ballooning happens, it reaches up to the thyrohyoid membrane but doesn't breach it, then it is called as an internal laryngocele. But sometimes what happens, this membrane that I am showing here, no, this is nothing but the thyrohyoid membrane. But sometimes what happens, the ballooning is so much that it breaks the thyrohyoid membrane and goes out. That time it is going to present in the neck as an external swelling. Okay. Now when there is this external swelling, if you try to compress this swelling with pressure, there is going to be a hissing or an air escaping sound that is heard, which is called as a Bright's sign. Now, what investigations do? You can do MRI as well as X-ray of the neck, and always remember you're going to do X-ray or MRI when the patient is doing Valsalva maneuver. Why do you ask the patient to do Valsalva? Because when they do Valsalva, the size of this laryngocele increases, and when it increases, you can better appreciate the laryngocele in the imaging. Okay. Next. What is the treatment? You have to surgically excise it and you're going to repair the defect. This is going to be the treatment. In case there is going to be blockage, then you have to go endoscopically and you're going to remove the obstruction. So this is all you had to know in laryngocele. Now let us look at one of the applications of whatever we have studied now. So you get a question which says that following thyroid surgery, a patient started having difficulty in breathing and repeated attempts to extubate were unsuccessful. The most probable cause is what? So remember that from this topic of nerve injuries in larynx, you get a question every alternate year. So concentrate and see how we need to approach this question. Okay. So the options are A. Superior laryngeal nerve injury, B. Unilateral recurrent laryngeal nerve injury, C. Bilateral recurrent laryngeal nerve injury, and D. Hematoma. So let us see each option. Whenever there is a superior laryngeal nerve injury, as we saw, superior laryngeal nerve supplies the supraglottis. That too only sensory supply. So if it is gone, there is going to be aspiration. Is aspiration in the question? No. Therefore, first one is not the answer. Second one, unilateral recurrent laryngeal nerve injury. We know that unilateral cases of recurrent laryngeal nerve injury is mostly going to be asymptomatic, and in very few cases there is going to be hoarseness. Is that mentioned in the question? No. So that is also not the answer. Option C, bilateral recurrent laryngeal nerve injury. When both the recurrent laryngeal nerve is gone, what happens? The cricothyroid, only muscle acting because its supply is from the external laryngeal nerve, comes to the center. It gets adducted. There is no glottic space that is left for respiration, because of which the patient goes into stridor. There is going to be breathing difficulty. Is this given in the question? Yes. This is what the question is about. Therefore, the right answer is bilateral recurrent laryngeal nerve injury. Okay. The clinical picture of breathing difficulty and unsuccessful attempts at extubation after thyroidectomy is suggestive of bilateral recurrent laryngeal nerve injury. Remember that bilateral recurrent laryngeal nerve injury is very common post-thyroid surgeries. And if at all they was talking about unilateral recurrent laryngeal nerve palsy, would it be the right one getting damaged or the left one? Which incidence is more? It is always left one because of the longer course of the left recurrent laryngeal nerve. Thyroid surgery may cause injury to both external and the recurrent laryngeal nerve. The upper part of the recurrent laryngeal nerve is in close proximity to the inferior thyroid artery. Okay. Unilateral recurrent laryngeal nerve injury may be unnoticed because most of the time the patient is normal, but in a very few cases there might be hoarseness of the voice. And if there is hoarseness of voice, it is not life-threatening, so you don't do anything. Conservative management. Now let's study about the vocal nerve palsy. One thing that you have to know is the larynx is supplied by two nerves, that is nothing but the recurrent laryngeal nerve and the superior laryngeal nerve. You have to know that recurrent laryngeal nerve and superior laryngeal nerve. Superior laryngeal nerve gives two branches, internal laryngeal nerve and the external laryngeal nerve. So, this recurrent laryngeal nerve is going to supply almost all the muscles except cricothyroid muscle. So, this cricothyroid muscle is supplied by the external laryngeal nerve. This is the first thing that you have to know, the motor supply. Now, coming to the sensory supply, you have to know that the glottis as well as the subglottis is supplied by the recurrent laryngeal nerve, whereas the internal laryngeal nerve supplies the supraglottis. Okay, you have to know this before we go and study more about what happens when each of these nerves is damaged. Okay, now looking at the course of the recurrent laryngeal nerve, in this picture we can see that the right recurrent laryngeal nerve, it encircles, it winds around the right subclavian artery, it goes in the tracheoesophageal groove, and finally it is going to enter the larynx behind the cricothyroid joint. Okay. Now, the left one has a almost similar course, but it is going to wind around the arch of aorta, then it is going in the tracheoesophageal groove and finally enters the larynx by going behind the cricothyroid joint. Now, because the left one has a longer course, it is more prone for damage, and the most common surgery that damages this nerve is nothing but thyroid surgery because of its close proximity with the gland. Now, as I told you, all the muscles are supplied by which nerve? Recurrent laryngeal nerve. Except one muscle, which is that muscle cricothyroid, which is supplied by the external laryngeal nerve, the external branch of the superior laryngeal nerve. If the patient experiences aspiration and exhibit change in voice following base of skull surgery, which nerve damage are we talking about? So, this is a question, okay? It can be a potential question in your exam also. So, let us see what happens when each of the nerve is involved and then answer that question. First of all, whenever internal laryngeal nerve is involved, where does the interlaryngeal nerve supply? If you look at this flowchart that we have done, we know that the sensory supply of the supraglottis is by the internal laryngeal nerve. So, if internal laryngeal nerve is damaged, the sensations from the supraglottis is not sensed. Therefore, if there is a foreign body coming there, will the person get to know? Or if the patient is eating food, will the patient get to know? Or if the cough reflex, is it activated? No, it is not activated because the internal laryngeal nerve, sensory nerve supply is affected. Therefore, the patient has aspiration. Number 2, external laryngeal nerve injury. External laryngeal nerve, is it giving motor supply or sensory supply? It does not have any sensory supply. It is going to supply only one muscle, and the muscle is cricothyroid. And cricothyroid's function is to increase the tension and increase the pitch of the vocal cord. So, if there is damage in the external laryngeal nerve, the patient can't raise pitch of the voice. Now, superior laryngeal nerve injury. What do you understand by superior laryngeal nerve? That means internal laryngeal and external laryngeal, both are gone because both are branches of superior laryngeal nerve. So, therefore, the patient has both these features of aspiration and he cannot raise his pitch. Now, let's come back to the question. In the question, they are saying that after surgery, the patient has aspiration, number one symptom, and there is also change of voice. Maybe they mean that the patient is not able to increase the pitch. So, both the features are there. Therefore, it becomes an injury to the superior laryngeal nerve. This is how you have to approach all these questions. Okay. Now, let us look into the unilateral and bilateral recurrent laryngeal nerve palsy and unilateral and bilateral complete nerve palsy. In complete nerve palsy, I mean that the recurrent laryngeal nerve and the superior laryngeal nerve is gone. Okay. Now, firstly, looking into the unilateral recurrent laryngeal nerve palsy. So, here what happens? Only one recurrent laryngeal nerve is injured, because of which the speech could be normal in most of the cases, or at times the person can have hoarseness of voice. Coming to the second condition, when there is bilateral recurrent laryngeal nerve palsy, speech is going to be normal. So, how is it? It is because we all know that majority of the motor supply to the laryngeal muscles is from the recurrent laryngeal nerve. It supplies almost all the muscles and it keeps the vocal cord in an abducted state. Now, the recurrent laryngeal nerve of both sides is affected. So, only muscle that is functioning is nothing but cricothyroid, because cricothyroid is supplied by external laryngeal nerve. And what is the function of cricothyroid? It is going to adduct the vocal cord. So, the cricothyroid is going to bring both the vocal cords to the center. So, these are in adducted state, and this is the state which is necessary for a person to have normal voice. Therefore, in bilateral recurrent laryngeal nerve palsy, voice is going to be normal. Whereas, in the previous case, when unilateral recurrent nerve had gone, so only in that side, now this is left side, imagine left side is the place where the recurrent laryngeal nerve has undergone palsy. So, it cannot abduct like this. So, this is the area where the cricothyroid pushes it to the center, whereas in the other side, the movement has happening. It can abduct, adduct, because here both the nerves are fine. So, in this case, occasionally there can be hoarseness, but in most of the cases, the voice is going to be normal. Now, coming to unilateral complete palsy, here both recurrent laryngeal nerve and the superior laryngeal nerve of one side undergoes palsy. Here, the patient can have aphonia or dysphonia. Okay. And whenever there is bilateral complete palsy, there is aphonia. Why is it so? Because here both the nerves are gone. No? The superior is gone. Superior is gone, meaning the internal, external also gone. External laryngeal nerve is the nerve that brings the muscle to the center, cricothyroid to the center. This muscle is gone, so it is going to go outside. And when for talking, as I told you, for phonation, both the vocal cords has to be in the median or paramedian space. But now, because it is abducted, the patient can't talk well. And that's why the patient will have aphonia. Coming to the second function of the larynx that we are looking at, it is nothing but respiration. When we talk of respiration, here the exact opposite of speech happens. Here the vocal cords has to be abducted, that is, there should be space, adequate glottic chink for the patient to be able to breathe properly. Whenever there is recurrent laryngeal nerve palsy of one side, only one side is in the median position, whereas the other side, it can go abduct, come back. So, there is some space, no? So, it is going to be normal. Whereas, when bilateral recurrent laryngeal nerve is gone, that is, no muscles are not acting to abduct, only cricothyroid is acting. It has brought the vocal cord to the center. Okay, there is no space in between, because of which this patient comes to you with stridor. Whereas, respiration is going to be normal in both the other conditions like complete palsy, unilateral and bilateral, respiration is going to be normal. Now, coming to the next thing, we are going to study about aspiration. What do you understand by aspiration? Whenever the sensation from the supraglottis is lost, the patient won't get to know whether a foreign body is coming to that area and the foreign body goes to the lung. That is, the cough reflex is not activated. Okay. So, aspiration is seen when the superior laryngeal nerve branch. Which branch? The internal laryngeal nerve is affected, because internal laryngeal branch is the one that is going to give sensory supply to the supraglottis. Okay, it is not at all the function of recurrent laryngeal nerve. So when we talk about recurrent laryngeal nerve palsy, both unilateral and bilateral, the superior laryngeal nerve is normal, right? So in both the cases, we do not have aspiration. But when we talk about unilateral complete palsy, that is recurrent laryngeal nerve is gone, also the superior laryngeal nerve is gone. So superior laryngeal nerve branch, which is nothing but the internal laryngeal nerve, but only if one side is affected. So there can be aspiration, but it is occasional. Only at few times there is aspiration because other side it is functioning properly. But whenever there is complete palsy, complete sensation is lost from both the sides, because of which the patient can have chronic aspiration. And whenever the food is getting aspirated again and again, food goes into the lungs and there could be infections of the lungs seen in this case. Now, how are you going to manage? The first condition, unilateral recurrent laryngeal nerve palsy. The patient is almost normal and sometimes has hoarseness of voice. Nothing has to be done. The patient can be managed conservatively. Now, coming to the second condition where there is bilateral recurrent laryngeal nerve palsy. Both the recurrent laryngeal nerves are gone. Patient has stridor. So when the patient comes to you with stridor, not able to maintain oxygenation in the blood, you do a tracheostomy. Now, you also know that both the cords are in the medial position. The patient is not able to breathe well. So you are going to lateralize the cord. Okay. So lateralization is done. So lateralization is which type of thyroplasty? It is nothing but type 2 thyroplasty. Okay. Now in the third condition, unilateral complete palsy. Here what has to be done? Here the cords, one of the cord is in the abducted state. So you are going to medialize the cord. This is the treatment that you are going to do here. Medialization of the cord, and medialization of proximalization means it is type 1 thyroplasty. Now you have to know that whenever you are doing type 2 thyroplasty, that is lateralization, you can use two procedures. One of the procedure is called as Woodman surgery and the other is called as Kashima surgery. Whereas to medialize, you are going to inject something from the now if this is the cord like this, okay, you are going to inject something from the lateral side so that it moves to the center. So you can either inject fat, you can inject Teflon or hydroxyapatite to bring it to the medial position. Now coming to the types of thyroplasty, you have type 1, 2, 3 and 4. One is nothing but proximalization. So when do you do proximalization? You do it when the cords are away, that is in unilateral complete. When type 2 is nothing but lateralization. When do you do lateralization? You do it in bilateral recurrent laryngeal nerve palsy. When both the cords are together, you are going to lateralize it. Type 3 is nothing but shortening, or it is also called as relaxation. You do it in puberophonia. Type 4 is nothing but lengthening, and lengthening is done in androphonia. And I told you, in ENT there are a lot of S's and T's which come together. This is one such thing where S and T comes together. Puberophonia, P, you do shortening, S. Now I'll be discussing about laryngeal carcinoma. So if you go back and check your NEET question papers of the last 4 years, there has been a definite question from this chapter of laryngeal carcinoma. So this year also, this can be a 5-star MCQ for you. You have to listen to this carefully because definitely I can owe that a question can come from this topic. So you have to know that most commonly seen in males, and this cancer is most commonly seen in smokers, because in smokers, the smoke is continuously going to go and irritate the glottis, irritate the structures in the larynx. Hence, this is commonly seen in smokers. Okay. So in larynx, we have supraglottis, glottis and subglottis. Now, which is the most common subside among these three to be affected? It is nothing but glottis. Okay, and you should also know that laryngeal carcinoma has a best prognosis. Why does it have best prognosis? Because whenever the glottis is affected, what is glottis? It is nothing but the voice box, if I have to tell in simple words. So whenever the glottis is affected, there is going to be hoarseness of voice. So nobody wants a hoarse voice, they want pleasant, good voice. So they will immediately go to a doctor saying that, doctor, something is wrong with my voice. It is very coarse, it's very, I can't hear to it, it's changed. So the doctor is going to examine you and say that, yes, yes, there's something wrong with your cords, so you can get treated early. That is why this cancer has one of the best prognosis, okay, because it presents very early. So which is the investigation of choice which will help us to stage laryngeal carcinoma? It is contrast enhanced CT. Do we also do MRI here? Yes, we also do MRI if we have to know about the cartilage involvement. For cartilage involvement, we do MRI. It is an investigation of choice for cartilage involvement. Now, coming to tumor staging and management, this is something that you have to carefully look into. So, coming to the stages, there are 4 stages: T1, T2, T3 and T4. Okay, so vaguely you have to remember that in T1, what is the vocal cord status? The vocal cord mobility is going to be normal. In T2, what happens? There is going to be a slight restriction in the movement of the vocal cord. Whereas in T3, the vocal cord is going to be fixed. If you just know these 3 things, you can solve majority of the questions pertaining to this topic. Okay. Now let's see the stages in little more depth. Coming to the first one, T1 stage, it is limited to one side or one subside of the supraglottis. What do you understand by this? One side meaning the cancer is either there in the supraglottis, glottis or subglottis. Or if it is there in the supraglottis, they may mean to say that one of the part of the supraglottis is affected. For example, our epiglottic fold, for example, our retinoid, or for example, epiglottis. Only one of the part of the supraglottis is going to be affected. Okay. And what is the vocal cord status here? I told you, right? Vocal cord mobility is going to be normal. So, if the patient comes to you with T1 stage, what is the treatment that you're going to offer to the patient? You are either going to do a transoral laser microsurgery or you are going to give radiotherapy to this patient. Now, T1 is further divided into T1A and T1B. T1A meaning the tumor is limited to only one of the vocal cord. So, the treatment becomes transoral laser microsurgery. Okay. T1B meaning the involvement of both the vocal cords. So, when both the vocal cords are involved, treatment becomes either a transoral laser microsurgery or radiotherapy. Now, coming to the second stage, it is nothing but T2. Here, there is spread to the adjacent site or subsides. That is, now if the primary cancer is in the glottis, now it is going to spread to either supraglottis or subglottis. Or, like initially said, if the primary subside was only supraglottis, only epiglottis was involved, now it extends to involve even the araepiglottic fold. This extension is the T2 stage. Now, what is the vocal cord status here? Here, the vocal cord mobility is slightly restricted. There is going to be slight restriction for the vocal cord mobility. What is the treatment here? It is same as the first stage. You either do a transoral laser microsurgery or you go for a radiotherapy. Now, coming to the third stage, in third stage what happens? There is involvement of the pre-epiglottic space or the para-epiglottic space or the post-cricoid space. So, basically there are certain spaces, okay, in front of the larynx, in the side of the larynx, behind the larynx, okay, that is a post-cricoid space. So, one of these space is invaded by the tumor. It is when it becomes a T3 state. Okay, and also there is one more thing that you have to know here which will help you solve MCQs, that is between T3 and T4, remember that only with respect to the thyroid cartilage, if we have to say, we have to remember that in T3 only the posterior lamina of the thyroid cartilage is breached, whereas in T4 there is through and through breach in the cortex of the thyroid. Okay, so based on only thyroid also you can stage whether it is T3 or T4. Okay, as I told you, only the posterior part, that is nothing but the inner cortex of the thyroid, is going to be breached in T3. And in T3, what is the state of vocal cord? Vocal cord is going to be fixed. Fixed meaning it is not moving, it is fixed in one direction. Okay, now what is the treatment here? In the third stage, treatment becomes concurrent CT-RT, chemotherapy and radiotherapy is going to be given in the third state. Now we have the fourth state, again divided into T4A and T4B. T4A meaning there is local invasion. For example, through and through invasion of the entire thyroid cortex. So when there is a through and through involvement of the entire cortex, as I told you, it becomes T4A. What do? We do a total laryngectomy, plus we are going to give the patient with adjuvant radiotherapy. Whereas in T4B, there is going to be distant invasion. Once there is distant invasion or distant meds, you can't do anything much. Only palliation is the treatment of choice here. Palliative therapy can be given to these patients. So as I told you, this is a very small topic, but from this topic you can expect 100 questions. Okay, you can you can get questions pertaining to vocal cord mobility, pertaining to the staging, or pertaining to the treatment that you can do in each stage. Now we have seen the tumor staging in the laryngeal carcinoma. Now let us go forward and see the nodal staging in laryngeal carcinoma. So basically we have N0, N1, N2 and N3. Coming to N0, 0, right? So there is no nodal involvement in N0. Okay. Now coming to N1, it means that a single node is involved. And what should be the size of the single node? It should be less than or equal to 3 centimeter. Then we say that it is N1 stage. We also have N2 stage. The N2 is further divided into A, B and C. Okay. So N2A meaning a single node is involved, but the single node is more than 3 centimeter but less than 6 centimeter. Okay. N2B meaning multiple nodes are involved, but the size is less than 6 centimeter. And it should be ipsilateral. That means in one side of the neck. N2C meaning again multiple nodes are involved, less than 6 centimeter, but now it could be contralateral or it could be bilateral. Either both the sides of the neck could be involved, or if cancer is in the right side, the left side of the nodes are involved. Then it becomes N2C. Now coming to the last, N3. In N3 we have A and B again. A meaning that a single node is involved, but now the size becomes more than 6 centimeter. Whereas when we talk about N3B, it means that there is going to be extranodal metastasis. So is there a trick to remember this? Not really, but a simple way would be N0 meaning no nodes because it is 0. Now the simple trick to remember this topic would be whenever we talk about N0, as the word suggests 0, so no node is involved. And let's use again tables like we have always used to remember the words. So we're going to learn 3 ones are here. Okay. So N1 meaning the size is less than or equal to 3. In N2 it can be anywhere between 3 to 6. And coming to the N3, more than 6. This is a simple thing that you can remember, and you have to know that in the second stage you have A, B, C, and in the third stage you have only A and B. This is how we are going to remember this. Now we'll also look into one more structure, that is nothing but the lymph node levels in the neck. So how many lymph node levels are there in the neck? It is from 1 to 6. Okay, and 1 to 6 is the one that you have to remember for your exams. Now coming to level 1 nodes. So 1 is further divided into 1A and 1B. Okay. So 1A submental. Where is it located? It is located here in the submental triangle. Now you tell me the boundaries of submental triangle. Anterior border of digastric and the hyoid bone. Okay. Now 1B meaning submandibular. It is located in the submandibular triangle, bounded by anterior and posterior belly of digastric and mandible. Okay. Now in 2, 3, 4 are nothing but upper jugular, lower jugular, middle jugular and lower jugular. So you have 2, 3 and 4. So if you can see the image here, in the submental triangle you have 1A, in the submandibular triangle you have 1B, you have level 2 upper jugular, level 3 middle jugular, level 4 lower jugular. Then you have the next level, level 5, which is nothing but posterior triangular, level 6 anterior triangular. Level 6 also has one more name. What is the name for level 6? It is nothing but Delphian. How are you going to remember? Dolphin, anterior part, C, whatever. So level 6 is Delphian nodes. This is one of the named nodes in the neck. Level 7 is nothing but you have all the pretracheal, paratracheal, prelaryngeal, all these come under the level 7. Okay. Now you have to know that level 2 and level 5 are further subdivided into 1 and 2 each. Okay. Now coming to the level 2, it is divided into 2A and 2B. Right. So what is the structure that is going to divide the level 2? It is nothing but the spinal accessory nerve. This could be an extra question. Okay. And then level 5 is again divided into A and B. What is going to divide level 5 into A and B? By the cricoid cartilage, the lower border of the cricoid cartilage. This is what you have to know in the topic of level of lymph nodes. Now we'll be studying about the radical neck dissection and modified radical neck dissection. So whenever you hear the term radical, it means that there is going to be complete clearance. For example, in the mastoid surgeries, we saw that in the kennel wall down type of mastoid surgeries, we had radical and modified radical. Radical meaning you do a extensive surgery where you remove most of the disease, most of the structure, you're not going to spare anything, okay? Whereas in modified radical, what did you do? You try to clear as much disease as possible by saving the healthy structures, no? So in the same way in neck also, whenever we are dissecting the nodes involved, we can follow either a radical neck approach or a modified radical neck dissection approach. So there are various neck incisions that you put in order to do these surgeries, okay? Now when we talk about the radical neck dissection, level 1 to 5 lymph nodes are going to be cleared. What are the level 1 to 5 lymph nodes? 1A submental, 1B submandibular, 2, 3, 4 upper, middle, lower jugular, 5 posterior. So you're going to clear these many lymph nodes along with certain non-lymphatic structures. So what are the non-lymphatic structures? Spinal accessory nerve, internal jugular vein and the sternocleidomastoid muscle. So to remember, one vein, one nerve and one muscle. So these three are very important because when you do modified radical type of neck dissection, you are going to be sparing few of these, okay? Along with all these structures, you're also going to remove parotid, submandibular gland and the omohyoid muscle. So this is about the radical neck dissection. Now we have seen about the radical neck dissection. Now coming to modified radical neck dissection. So when we talk about this, we need to know that level 1 to 5 group of lymph nodes is removed here also. But where is it different from that of radical neck dissection? It is based on the non-lymphatic structures that we are going to preserve. So there are type 1, 2, 3. So to remember that in type 1, one structure is preserved. Type 2, 2 structures are preserved, and type 3, 3 structures are preserved, okay? Now, in the non-lymphatic structures, we saw that there was spinal accessory nerve, there was internal jugular vein and sternocleidomastoid muscle, meaning one nerve, one vein, one muscle. So, if I give you a question as to which of these would you like to save, whether you're going to save a muscle, vein or nerve, 90% of you would tell that we are going to save the nerve because nerve is most important, no? Correct. So, in type 1, you're going to save the nerve. So, which is the nerve? Spinal accessory nerve. This is going to be preserved in type 1. So, in type 2, one thing that you're going to preserve is same, spinal accessory nerve. With this, you're going to remember one extra thing. Is it muscle or is it vein? It is vein. So, you're going to preserve the internal jugular vein. So, when you come to type 3, it is same as type 2. You're going to save exactly these two structures, but along with this, you're also going to save the sternocleidomastoid muscle. So when you save all these structures, it becomes a functional neck dissection because you're going to save most of the structures here. That is why it is called as functional neck dissection. And this is the neck dissection that is followed by most of the head and neck cancer surgeons these days. Now let's study about tracheostomy. What do you understand by the term tracheostomy? It means that you're going to create a stoma in the neck in order to help the person breathe better. Okay. So there are two types of tracheostomy, that is nothing but emergency and elective. So as the word suggests, emergency, you do it suddenly. So here you are going to give a vertical incision. So from where does the incision extend and up till where? It is going to extend from the lower border of cricoid up to the suprasternal notch. You have elective where you give a horizontal incision, and where do you give this horizontal incision? Either 2 finger breadth above the suprasternal notch or 2.5 centimeter above the suprasternal notch. This is one thing that you have to know. And coming to the tubing, there are different types of tube, okay? So basically it consists of an outer cannula and an inner cannula goes into it, okay? So this outer cannula also has a cuff. This area is the cuff. What is the importance of cuff? This is going to hold the tracheostomy tube in position, and it is connected to outside by a structure called as pilot balloon. So whenever you feel like it is not in position, you're going to check through the pilot balloon if there is enough pressure inside to maintain the position, okay? And then there is something called as inner cannula. So inner cannula is going to be fitted into the outer cannula. So usually what happens, a lot of people who have tracheostomy, have undergone tracheostomy, have a lot of secretions, okay? And if they are not doing suctioning properly or not cleaning the tube properly, the tube can go into tube block because of increased collection inside. But now if you also have an inner cannula, the inner cannula is a detachable part. So as and when needed, like 2 to 3 times in a day, you can remove the inner cannula, clean it and insert. The main aim of this is to prevent tube lock and keep the tracheostomy tube for longer time. Okay, to basically increase the shelf life of the tracheostomy tube. Now, in what position do we do a tracheostomy? It is done in rose position. Can you also name 2 more surgeries for me which is done in rose position? Yes, adenoid surgery is done in rose position. And then you also do the tonsillectomy surgery in the roses position. Okay. Now, how is the rose position? Which are the joints that are extended in the roses position? They are nothing but AO and CT, that is the atlanto-occipital joint and the cervicothoracic joints. So these 2 joints are in extension in roses position. Now, which is the tracheal rings that is dissected in case of tracheostomy? It is nothing but T2, T3 rings. Basically, the isthmus of the thyroid comes at this area and you are going to dissect this. What is the indication of tracheostomy? There is something called as high tracheostomy. Okay, so the indication for high tracheostomy is nothing but CA larynx. So high tracheostomy meaning you do tracheostomy at a level higher than the normal, that is T1. This is the cartilage level where you are going to do high tracheostomy. Now coming to the complication, there could be necrosis of the larynx because of increase in the cuff pressure. We have studied about subglottic stenosis. No, there was stenosis in the subglottic area. Most common cause, congenital. Acquired, what was the cause? Because of the increase in the cuff pressure. Therefore, how are you going to prevent it? By too early deflation of the cuff. Because whenever you do too early deflation, it is going to reduce the pressure necrosis that is happening in the subglottic area. And whenever a person is intubated, after how many days you are going to do a tracheostomy? Normally in children you can wait for about 7 days and in adults it is done after 3rd day. Now if the tube is blocked, what are you going to do? If it is a partial block, you are just going to clean the inner cannula and put it back. You can clean it either with water, saline, sodium bicarbonate, mucormyx, whatever. But if it is a complete block, you have to remove the tube and change the tube. And all this has to be done fat in seconds. It has to be done. Okay. Now, what are the indications of tracheostomy? If there is retained secretions in the lung and the patient doesn't have enough muscular power to put out the secretions. For example, he is suffering from some MLS, or if he is suffering from paralysis of the respiratory muscles, that is when you can offer tracheostomy. Whenever there is respiratory obstruction, prolonged mechanical ventilation, and even when the patient comes with stridor, or whenever there is some surgery pertaining to the maxilla, open reduction, internal fixation, you also do a temporary tracheostomy in these people. Now, a quick question for all of you. What is the level at which we do tracheostomy? At which tracheal ring? At the level of 2nd and the 3rd tracheal ring. And when we talk about high tracheostomy, we do it at which level? T1. Nothing but the 1st tracheal ring. Okay. And when do we do the high tracheostomy? Whenever a person is suffering from laryngeal carcinoma. As you can see, normal position tracheal ring 2 and 3. High tracheostomy meaning tracheal ring 1. Now, coming to the surgical landmarks of facial nerve and parotid surgery, this is one important thing that you have to know. So, there are many landmarks, out of which 4 are very important. Okay. Number 1 being the tragal pointer. So, tragal pointer is one of the important landmark for identifying facial nerve in the surgery of parotid. So, where is a tragal pointer? This blue color structure that you can see is nothing but the tragal pointer. After this, we have the second one, which is nothing but the tympanomastoid suture. Tympanomastoid suture is another landmark. And then we have the styloid process. Can you show me styloid process in this image? Styloid process is seen here. The sharp projection is nothing but the styloid process. And then we also have another marker, which is nothing but the posterior belly of digastric. So, posterior belly of digastric. Where is it in the image? This muscle that you can see here, no? This is the posterior belly of digastric. Now, can you show me facial nerve based on all these landmarks? You can see that this is the facial nerve that we are talking about. Okay. Now, coming to these 4 landmarks, which do you think is the most important and consistent landmark? It is nothing but the tympanomastoid suture. It is the most consistent landmark. There are two maneuvers given here. Let us do a quick revision and find out what are these. The number one image that you're seeing here is nothing but the image of a Heimlich maneuver. What do you understand by Heimlich maneuver? It is a maneuver that is done in order to remove foreign body in those people who have choking. For example, you have gone to a wedding, you are sitting and eating food happily. You see a person suddenly holding his neck and he is choking, he is not able to breathe. As a doctor, what are you going to do? You're going to go to that person, stand behind the person, and you're going to make a closed fist and keep it just above his belly button. You're going to stand backside, you're going to keep your fist above his belly button, just below the rib, and you're going to give pressure posteriorly and upwards. And when you do this again and again, the food bolus which is stuck and causing aspiration, the patient is choking because of it, that food bolus is going to come out. Okay, this is going to be a life-saving maneuver. So coming to the second image, you can see that there is a person who is leaning forward and pinching his nose tightly. What is this? This is nothing but a trotter's maneuver or a trotter's position. When do we do this trotter's position or trotter's maneuver? We do it as an initial management of nosebleed. So whenever we have nosebleed, there is a common misconception that they have to bend back. No, you should never bend back because the blood is going to the lungs and it causes aspiration. You always lean forward and put pressure. This is going to be the initial management that you do in terms of nosebleed. Now let's look into certain instruments that we commonly used in ENT. You need to know all these because one of these can come as a spotter for you in your NEET exam. Okay. So the first instrument that you're looking here is nothing but a bull's eye lamp. So what is going to be the focal length of a bull's eye lamp? It is around 30 to 40 centimeter, and the lens that the bull's eye lamp uses is a biconvex lens. So you can see here, this looks like a big bull's eye, hence called as a bull's eye lamp. So you have to know that this bullseye lamp can give best illumination for the examination of ear, nose and throat. Even though this is obsolete, it has historical value. You need to know it henceforth. Okay. Now the second image that you're looking at here is nothing but that of a seagull's speculum. So we have seen seagull speculum in a lot of places, right? We do fistula test with it. We check for the tympanic membrane motility. We do Gell's test, and also we can check for the glomus blanching. Now let us do a quick revision. What is fistula test and how do we do it? With the help of a seagull speculum, we increase and decrease the pressure in the external auditory canal and look for the direction of the nystagmus. Okay. There can be a true positive fistula test, false positive, false negative, everything. Okay. Now coming to the tympanic membrane mobility, where do we check it? Especially in the type 3 and type 4 retraction of the pars tensa, because whenever you do otoscopy to check, you are not able to properly say, because in both the tympanic membrane and other two promontory, you won't be able to say which is third and which is fourth. Hence, you check for the mobility. If the tympanic membrane is mobile, it says that it is stage 3. If it is not mobile, it is completely sticking like glue to the promontory, it means that type 4. Gell's test. So even in Gell's test, there is use of seagull speculum. In Gell's test, where are we going to do Gell's test? In otosclerosis. Whenever you do Gell's test, what happens is that you are going to take the tuning fork, vibrate it and place it in the mastoid of the patient. Next, you're going to take seagull speculum and increase and decrease the pressure in the external auditory canal. If the sound heard remains same, it means the test is positive. But whenever you're increasing the pressure, if the sound heard is less, and when you decrease pressure, if the sound heard becomes better, it means that the test is negative and it is characteristic of otosclerosis. Okay. Now coming to glomus blanching, you can check it with seagull speculum again. You're going to take seagull speculum, increase the pressure in the external auditory canal. There is going to be sudden increase in the pulsatility of the glomus tumor, and then it is going to blanch completely, which is called as pulsation or Brown sign. So much is the significance of seagull speculum in ENT. The next instrument that you're seeing here is nothing but otoscope. What is the use of otoscope? You're going to use otoscope in order to check for the external auditory canal and the tympanic membrane. Okay. How are you going to pull the ear? You're going to pull it posteriorly, backwards and laterally in order to make the external auditory canal and visualize the tympanic membrane. So what are these? These are nothing but reusable speculums. This is also a speculum. These are the speculum that is connected to the otoscope. Where do you connect? At this portion of the otoscope, you are going to connect the speculum, because you can't put the dirty end of it to every ear, no? So each time you are going to reuse it and look for the tympanic membrane. And it comes in different sizes. For a person or a child with smaller canal, you can use a small size speculum. For people with wider canals, you can use a big size speculum. What is this? This is nothing but a Simpson's oral syringe. Okay. So why do we use it? As a name suggests, oral syringe, no, in order to remove impacted wax or foreign body like insects from the ear canal. So now what you do is you use a large syringe, fill it up with water in body temperature and direct it posterior superiorly, okay. But a traditional instrument that is used for the same purpose is called a Simpson's oral syringe. So you have 3 places where you can put 2 fingers and thumb, and you are going to direct water inside. Now one more instrument. What is this instrument? See, if you see the end of the instrument, there is a sharp diamond-like projection in the end of the instrument. This is nothing but myringotome. As a name suggests, myring. It is used to do something in the tympanic membrane. So you are going to create a myringotomy incision with the help of a myringotome. So in which quadrant do you do a myringotomy incision? So if this is the tympanic membrane, which side tympanic membrane this is? The upper end is pointing towards right, lateral process is pointing towards right, cone of light is towards the right. So this is the tympanic membrane of the right side. So what are the quadrants? You're going to draw 2 lines. This is the posterior superior, posterior inferior, anterior superior, anterior inferior. So you are going to do an incision in this quadrant, in the anterior inferior quadrant, in order to replace the functioning of the eustachian tube. Where do we do this usually? In order to give the child relief from serous otitis media. And then you are going to insert a grommet here, so that effectively the secretions get drained out. Okay. What type of incision do you do? Radial or curvilinear? You're going to do a radial incision, because whenever you do a radial incision, the incision that is shown in this picture here is nothing but radial incision. So when you do a radial incision, the fibers are going to come close to each other and hold the grommet in position. But if you do a curvilinear incision like this, for example, in the posterior inferior quadrant, it is not going to tightly hold the grommet. But is there use of this curvilinear incision anywhere? Yes. Whenever there is a lot of pus or fluid collected in the ear, in order to relieve the pressure, you can do a curvilinear incision in the posterior inferior quadrant. Now, coming to the next image, what is this? This is nothing but Tilly's packing forceps. So why do you use this? So whenever you do a procedure, like for example, whenever you want to do a diagnostic nasal endoscopy, whenever you want to do septoplasty, FES, whenever you have to visualize the nasal cavity, first of all, you have to reduce the size of the turbinates, and that is when you use a Tilly's packing forceps to pack the nose. There's another type of packing forceps, this one, which looks like a plucker with a bend in anteriorly, the sharp bend. This is nothing but Wild's packing forceps. Now, coming to the next instrument, this is nothing but a posterior rhinoscopy mirror. So, this mirror is used to conduct a posterior rhinoscopy examination, and as you can see in the image that it has a sharp bend like this. Okay. Whereas an ideal mirror does not have this bend. Now, in the next picture, we'll also look at what are the structures that are seen whenever you do a posterior rhinoscopy. Okay. Now, coming to the next instrument, what are we looking at here? This is nothing but a Killian's or a Vienna's self-retaining speculum. What do you understand by the term self-retaining speculum? It means that once you insert, it is going to stay in the same position for quite some time. So where do we use this? Again, you are going to use this to visualize the nasal cavity in nasal surgeries. For example, septoplasty, for example, FES. Okay. Now, what is the next image? This is nothing but a Jobson's horn probe. How do you identify a Jobson's horn probe? It is going to be a thin, slender, cylindrical probe with a sharp serrated edge in one side and a round structure like this in one more side. So, why do you use this? In the sharp serrated side, you can put in a cotton and make an appearance of a bud to clean the ear. In the other portion also, you can scoop out the discharge, scoop out the wax in the ear or even use it to remove some foreign body from the ear canal. Now we looked into the structure of the posterior rhinoscopy mirror. No? Now how are we going to say that it is a posterior rhinoscopy mirror? By the sharp bend that is there here. The sharp bend is not there in an ideal or indirect laryngoscopy mirror. Okay. Now remember that posterior rhinoscopy is not usually commonly done these days because of advanced technology like diagnosing nasal endoscopy that we have. Okay. Now in case we do a posterior rhinoscopy, we can see certain structures. How many structures are seen in the posterior rhinoscopy? We can see about 7 structures. So what are these 7 structures? Number 1, we can see the adenoids. Okay. So this is the adenoids that we can see in the posterior rhinoscopy. We can see the posterior end of the nasal turbinates. So these 3 are the posterior end of the nasal turbinates on both the sides. Next, we can also see the eustachian tube opening. This that I am marking now in orange, this is the eustachian tube opening that is also seen. So what are the 3 things that we saw? Adenoids, posterior end of turbinates and the eustachian tube. Next, we can see the posterior border of the nasal septum. This area is the posterior border of the nasal septum. We can also see some other structures. What are those? Torus tuberous. What is torus tuberous? The bulge behind the eustachian tube is called as the torus tuberous. And after torus tuberous, you have one more structure where the nasopharyngeal carcinoma comes from. What is that? That is nothing but fossa of Rosenmuller. Okay. Next, you can also see the upper surface of the soft palate. This is the upper surface of the soft palate. So these are the 7 structures that is appreciated when a person does a posterior rhinoscopy. And it is not done mainly because most of the patients won't be cooperative. They will have excessive gag. It's a tedious thing to do. That is why it has become obsolete now. Now, this is one more mirror, but here you can see that it is relatively straighter. This is nothing but an indirect laryngoscopy mirror. Now you know that you're going to see vocal cord, the piriform sinus, the epiglottis, epiglottic fold, valvula, base of tongue, so many more structures in the indirect laryngoscopy. No? There are about 5 structures which are not seen. So your examiner knows that you know all the structures that are seen and he's going to catch you at this. So which are the 5 structures which are hidden, which are not seen in posterior rhinoscopy? These are nothing but 1. Subglottis, because it is there under vocal cord. It is not seen. 2. Vestibule. Vestibule is also not seen. 3. Postcricoid area. Postcricoid area is also not seen. 4. The laryngeal part of epiglottis. Laryngeal part of epiglottis. And 5. Nothing but the apex of the piriform sinus. These are the 5 things that are not seen in an indirect laryngoscopy. Now, you can see one more structure here. You can see a blade-like thing with another blade-like thing perpendicular to it and the end is curved. What is this structure? This is nothing but a Lux tongue depressor. Why do we use it? As a name suggests, we use it in order to depress the tongue. Whenever we have to see the posterior pharyngeal wall or tonsils, we are going to use this. Even while checking Irwin-Moore sign. What is Irwin-Moore sign? This is one of the signs that is seen in chronic tonsillitis. That is, with the help of a tongue depressor, if you press the anterior pillar of the tonsil against the tonsil proper, it is going to bring in white color caseous material out. This is called as Irwin-Moore sign. Apart from this, there are also 2 more signs in chronic tonsillitis. What are they? They are nothing but a flushing of the anterior pillars and palpable jugular digastric nodes. Now, the next thing that you can see here is nothing but a Tudicum's nasal speculum. Why do we use it? You use it in order to examine the anterior nasal cavity. You are going to hold it in your hand, insert it, and then you are going to observe. Remember that when you insert it, you are going to close and insert, and once you enter inside the vestibule, you are going to open it. But while removing, you are not going to close and insert, because when you close it, in case some hair gets stuck inside, entrapped inside, when you pull it, it's going to be painful for the patient. Hence, slightly open it and remove it. Okay. Now, coming to the next image, what can you see here? This is nothing but a retractor. What type of retractor are we looking at? This is nothing but a Mollison's self-retracting hemostatic mastoid retractor. This is what we are going to look at. Okay. So how are you going to identify and say that this is a Mollison self-retaining mastoid hemostatic retractor? It is by looking at the instrument only. Okay. So first of all, there are these serrations, screw-like serrations here. No, this is going to provide a lot of pressure and cause hemostasis and self-retention. Now we are going to say that this is a Mollison's retractor by looking at the ends. So if you look at the ends here, you can see that there are equal number of serrations on both the sides. It could be 3 each or 2 each. So this is how we are going to identify a Mollison's retractor. We also have certain other retractor called as Perkins retractor, which looks exactly similar to this, but only differentiating feature there is both the ends are different. Okay, I'll be explaining that with an image in a short while. So coming to the next picture, in the next picture we have a, what is this? This is nothing but a Druffin's bipod stand. So what is the use of a Druffin's bipod stand? So in the surgery of an adenoid or tonsillectomy, you are going to put a Boyce Davies mouth gag and open the mouth. So once the mouth is opened, it has to be held in position so that the surgeon can easily operate. No, so that holding in position work is done by this Druffin's bipod stand. Next, we also have one more instrument here. This is nothing but Epistaxis balloon catheter. So what is the use of this balloon catheter? Whenever there is a posterior epistaxis, you are going to put this epistaxis balloon catheter to the nose, and in the nasopharynx you are going to inflate the balloon so that because of the pressure effect there is going to be stoppage of the bleeding. We saw one type of retractor which is called as what retractor? Mollison's retractor. So this is a second type of retractor used for again mastoid surgery. This is called as a Janssen retractor. How are you going to identify and differentiate from the other retractors? As you can see, both the other retractors had 2 spaces where you could put your finger. No, so basically they were like this. This is how those retractors look like. So this area where you could put your fingers is not there in a Janssen's retractor, but it shows a coin-like, a key-like thing is there at the end of the Janssen's retractor. And both the hands of the retractor are also quite shorter. Now coming to the next retractor, this is nothing but a Perkins mastoid retractor. Now this Perkins mastoid retractor and a Mollison's retractor almost look alike. Okay, so this line diagram that I have drawn on top, let us consider it as a Mollison's retractor. So in the Mollison's retractor, in the ends it has equal number of serrations. For example, 3 and 3. This is how the end looks like. But in Perkins, you can see that in one area there is a broad plate-like structure and you have thorn-like structure in only one limb. This is how we are going to differentiate it as a Perkins retractor. So both Mollison's and Perkins retractor can give you hemostasis. Now in the next image, what are you finding? This is nothing but a Boyce Davies mouth gag. So you use this mouth gag in order to keep the mouth of the patient open during the oral cavity surgeries, for example, oropharynx surgeries like tonsillectomy and adenoidectomy. So it's a C-shaped thing with an adjustable handle. Okay. Now, what is this instrument that you are looking at? This is nothing but a St. Clair Thompson adenoid curette. St. Clair Thompson's adenoid curette with and without guard. These structures that you see here are nothing but the guards. So you are going to use this in order to scrape out the adenoid tissue. Now, there is one complication that could occur whenever there is subluxation of the atlantoaxial joint. What is that? That is nothing but Grisel syndrome. That is seen as a complication of adenoid surgery because of the hyperextension of this joint that happens. Okay, so you have to be very careful to avoid this mistake. Now you are going to see 2 forceps here. No, now we have already seen this whenever we studied about the nasal fractures. So what are these? So one of these forceps, as you can see, has an angulated bend in the apex. The apex is angulated. A for Ashe's forceps. So where do you use this Ashe's forceps? In order to correct the septal deformity. If the septum has depressed inside, you're going to use this forceps to bring it up. What is the next one? A relatively straighter one. This is nothing but a Walsham's forceps, and you use this Walsham's forceps in order to correct the lateral nasal wall deformities. What are the 3 types of nasal fractures? Chevalier, judge away. And the third one, no, nobody wants to get it, naso-orbitoethmoidal fracture. Now coming to the next image, this is an image of a Tilly's Littwitz trocar and cannula. So this instrument Tilly Littwitz trocar and cannula is used for the antral puncture whenever you try to increase the size of the maxillary antrum. Whenever you want to clear the disease, you can use this antral puncture by the Tilly Littwitz trocar and cannula. Then you have certain endoscopes that are shown here. These are the endoscopes that you use in FES. So there are various degrees, okay, green for 0 degree, red for 30 degree, black 45 degree, and yellow as 70 degree. So there is a mnemonic which is called as GRAY, no, gray. So instead of A, you are going to put B. So G for green, 0 degree, red for R for red, which is 30 degree. Instead of A, we have put B, which is 45 degree, and Y for yellow, 70 degree. Then we also have this knife, which is called as Ballinger's swivel knife. So this is a knife in order to remove the excess cartilage in certain surgeries of nose like septoplasty and rhinoplasty. So whenever you're doing this cosmetic surgery or surgeries to help the patient clear deviated nasal septum, you're going to remove the excess cartilage by this Ballinger's swivel knife. Then you also have a Lempert's curette. If you look at the end, there is a curette like a cup-like thing. This is used to scrape out excess disease or bone from the mastoid antrum or the mastoid cavity. So this instrument is called as a Lempert's curette. Now, in the next image, we are looking at a tracheoesophageal prosthesis. So, if you look at the image here, there is a small device that is located in between the trachea and esophagus, right? This is a tracheoesophageal prosthesis. So, it can be operated in two ways, either by closing the device with the help of a thumb that is shown in the first image here, or there is a valve-like adjustable valve which is there, which automatically closes it so that you do not have to move your finger all the time when you have to talk post laryngectomy surgery. Okay. So what happens is that the air that is coming back from your trachea through the tracheoesophageal prosthesis is directed into the esophagus, and then it comes up to the oral cavity, and this air vibrations are converted into voice. This is how voice is produced by using a tracheoesophageal prosthesis. Okay. And in the second device, we can see a handheld device, and this device is called as a electrolarynx. Okay. This electrolarynx is going to provide patient speech following laryngectomy, but it is going to be a mechanical type of voice that is produced post laryngectomy. So there is a long tube which is there, which causes vibration in the oral cavity, and these vibrations are resonated so that voice is produced. And because it is a machine that is producing voice, it is going to be a very mechanical type of voice. Now we have another image. So there are two parts of this image. Okay, this is 1 and this is 2. What are we looking at in the first image? We can see that the food passage and the esophagus, stomach, everything is normal. And the second passage, that is breathing and trachea, air going to the lungs, this is also normal. We have two channels. We can see esophagus, trachea, and we can also see the vocal folds. So all these are seen in the first image. Whereas, come to the second image now, you can see a stoma that is created in the neck. So whenever you see stoma, it means that a laryngectomy surgery is done, following which we have a stoma, and now we can see that breathing is not happening from the nose. The arrow starts from the stoma. That means air is directly going from the stoma into the trachea and lungs. And we have one more passage here, which is the passage for the food pipe from the mouth to the esophagus. Okay. There is also something that you have to notice here. There is a word called as pharyngoesophageal segment which is mentioned, which represents this portion. It is called so because it is a pharyngoesophageal segment vibrations which help the patient to produce voice post a stoma formation in a laryngectomy surgery. Now, coming to one of the extra edge topic that I want all of you to know is nothing but stridor. So stridor is one topic that is confusing for most of the students, because you might be like, there is inspiratory, biphasic, expiratory. What am I going to do? I'm confused. No? So I'm going to tell you an easy trick in order to remember from which place. Like for example, if you're talking about a lesion in supraglottis, what type of stridor you're looking at, glottis, what type of stridor, and so on. Okay. Firstly, we'll talk about inspiratory stridor. We need to know that inspiratory stridor is produced whenever there is an obstructive lesion either in the pharynx or in the supraglottis. Okay, let us look at the image here. If you look at the image, no, you have to always draw this image, okay, in your exam also. Just one sec, you can take like 5-10 seconds to draw a line image. So anywhere, if there is a lesion in the pharynx or the supraglottis, this entire region, for example, if there is laryngomalacia, or if there is, let's say, an abscess, retropharyngeal abscess, these are all there in the supraglottic or pharynx area, no? So you are going to have an inspiratory type of stridor, okay? Now, we also have some other type of stridor, that is, we have the expiratory stridor. So when we talk about expiratory stridor, we need to understand that it is produced by the lesions of either the thoracic trachea or it is produced by the lesions of the bronchi, the primary and secondary bronchi, that is the lowermost part of the respiratory tree. So if you look at the image here, all this entire portion, the ends, the thoracic trachea. See, in trachea also you have cervical part of trachea, which is the initial trachea, following which you have the thoracic trachea. So if you have any lesion in thoracic trachea and its bifurcation, the bronchi, like for example a foreign body or tracheal stenosis, that is when you are going to have an expiratory stridor. That is nothing but noisy breathing aggravates during the time of expiration. Now you have a biphasic stridor, meaning both in inspiration and expiration you can hear stridor. It is seen in between. So inspiratory top, expiratory below. Whatever there is in between this area, no, this is an area where you get biphasic stridor. So what are the lesions that constitute biphasic stridor? Nothing but lesions of the glottis, subglottis and the upper part of the trachea, that is cervical trachea. So what are the parts? Glottis, then we have the subglottis, then we have the upper part of trachea, that is cervical trachea. Some conditions include laryngeal papillomas. Larger papillomas, when they are so big that it is obstructing the opening completely, vocal cord paralysis or a subglottic stenosis. Quick question. Most common cause of subglottic stenosis? Congenital. Acquired, could there be? Yes, if the cuff pressure is more. So this is something that you have to know. Now let me ask you questions, okay? Laryngomalacia. What type of stridor do you have? Inspiratory stridor. Papillomatosis of the vocal cord. What type of stridor? Biphasic. Foreign body in the trachea, expiratory. Okay, let's move into the next topic. So in this picture, you can see a round puffy tumor in the forehead, no? In the frontal sinus area. What is this? This is nothing but Pott's puffy tumor. Okay, so Pott's puffy tumor is nothing but a subperiosteal abscess that develops in the area of the frontal sinus. It is most commonly seen only in the frontal sinus area. Because of the osteomyelitis of the frontal sinus bone, there develops a subperiosteal abscess and the patient is going to come to you with a big puffy tumor in his forehead region. So how are you going to treat it? You are going to do something called as a frontal sinus trephination. So by doing frontal sinus trephination, you are going to clear the disease and make the person rid of the disease, okay? And there is a special type of incision that you put here. The incision is called as Lynch-Howard incision. Can you think of any other condition where I gave a gist of this incision, Lynch-Howard incision? It is also done whenever you are treating inverted papilloma. I told you that the treatment of choice for inverted papilloma was endoscopic over external. But if you're planning to do an external, you can do a Denker's incision, you can do a Lynch-Howard incision, example, okay? So Lynch-Howard incision is done here. At this space, you're going to do a Lynch-Howard incision and do a frontal sinus trephination. Now let's look at what are mucocele. So mucoceles are nothing but slow growing mucus containing benign collections that are seen mostly in the area of the frontal sinus and they develop years after head trauma. So if you go retrospectively and ask history from the patient, they always say that there was a history of head trauma and the frontal sinus is the one which is commonly affected from a mucocele, and the order of the sinuses which are affected is nothing but frontal, more than the ethmoidal, more than the maxillary, And the last sinus to be affected is nothing but the sphenoid, as they are located posteriorly. Now, the frontal mucocele presents with certain features. And what are the features? Headache, diplopia, proptosis. Headache because of the pressure symptoms. Diplopia because whenever it goes near the sixth cranial nerve, abducens, it's going to cause diplopia. Proptosis because when it becomes too big, it is going to push the orbital contents forward. Okay. So, a cystic non-tender swelling, it noted, and it has a characteristic egg shell crackling. So, whenever you try to touch it, press this mucocele, no, it gives you a sound which is similar to that of a sound that is produced whenever you try to crack a eggshell. Okay, so in a question, if they mention about a swelling, soft cystic swelling that is there, which is non-tender, there in the forehead and gives a eggshell crackling, we are talking about mucocele. Now, whenever we talk about nasal mucociliary clearance, there are few tests for it. So, you can get a question in the exam saying that which of the following is not a test for nasal mucociliary clearance. So, let us look at the names of the tests for the mucociliary clearance. These are nothing but number 1, saccharin dye test with or without color test. And then you also have one more test which is nothing but the radioisotope transport test. And also you can measure the ciliary activity in vitro. You can also do a scintigraphy or you can do a charcoal method. Charcoal method is very less commonly used these days. So what are the tests? Saccharin test, radioisotope transport test, scintigraphy, measuring the ciliary activity in vitro, and a charcoal test. Now let us look at two of the PYQs that were asked recently. Okay. So the number 1, you can see a surgeon taking a needle and blocking one of the nerve just near the dorsum of the nose at this point. So, which nerve is the surgeon blocking? He is blocking the anterior ethmoidal nerve. So, anterior ethmoidal nerve gives supply to the skin on the dorsum of the nose, to the tip of the anterior aspect of the septum of the nose and the tip of the nose by an external branch. So, when you block this nerve, it is going to stop all the sensations from these areas. So, anterior ethmoidal nerve is a branch of which nerve? Anterior ethmoidal nerve is a branch of a nasociliary nerve. Okay. So, nasociliary nerve is a branch of which? Nasociliary is a branch of ophthalmic or V1 division of the trigeminal nerve. Got it? Okay. Now, we have another image here which is showing us a surgeon blocking this point. So, this point is just above the medial canthus, slightly medially. So, what is the nerve that the surgeon is trying to block? He is blocking the nasociliary nerve. This is something that you have to know. Now, if you look at both the images here, one is the lateral image and the other is the AP image, showing us how the pharynx is demonstrated typically. It is showing us the anatomy of pharynx encountered during a barium swallow. So, let us look at various points, okay. So, A, this structure shown by A is nothing but the tongue base. Next, we have B. B is nothing but this structure. This structure here points the epiglottis. So, in the AP view also, we can see the epiglottis here. Now, C is nothing but vallicula. This area is vallicula. So, in AP view, you have vallicula on both the sides and you can see some whitish colored structure here, no? Hyperdense area. This is nothing but vallicula containing a small amount of residual barium. Next, D. What is a D structure? D is nothing but the hyoid bone. This is the hyoid bone. And then you have E. E, and at E, what do we have? We have the laryngeal vestibule. So, laryngeal vestibule is E. So, you can see, in the AP view also, this area represents the laryngeal vestibule. Next, this laryngeal vestibule actually is coated in barium consistent with laryngeal penetration. Next, at F, we have pyriform sinus. This area in both the sides, this pyramidal area, this is nothing but the PFS or the pyriform sinus. It is containing small amount of barium. How are you going to identify it? Because as you can see in the image, there is whitish color, hyperdense barium that is seen. Now, G. What is G? This area is nothing but the vocal fold. Here also in AP view also, you are going to see the vocal fold, vocal cord or the vocal fold coated in barium. H, you have nothing but the barium coating in the anterior aspect of the trachea. which is consistent with the tracheal aspiration. So, these are the various parts of the pharynx as looked upon in an X-ray taken after a barium swallow, both in lateral and the anterior posterior view.